effective. And if we compare the length of mechanical ventilation with the length of hospitalization, we see no difference between bolus versus infusion, nurses-led protocols, or wake-up test. This is Professor Clark, my friend, that start this campaign to recognize pain in intensive care. He like the Italian wine, so he think that they can have sedation also with the wine. It's a joke, of course. And, in this trial, I want to show that we can use a daily interruption of our therapy or interruption on base of clinical symptoms. Which are the result? The result about propofol and midazolam are this, all given morphine infusion, of course, but the length of medical ventilation was less for daily interruption, not to wait for clinician symptom. And the loss in ICU is less in daily interruption than in clinical interruption. So no, we ask not a painful coma. Talk with your patients, and probably you can say that we are talking about something very important for them. So we prefer pain-free comfort, which are the most common treatment in our ICU. This is a recent research in Italy. We have, first of all, mechanical ventilation for 70% of our patients, arterial catheter 51%, pulmonary catheter 4.4%, or cardioactive drug for 16.8%. And what happens about the pain? The first day we start, we understand that our patients don't need only sedation, but or ventilation or cardio drugs, but and you see we give opioids for in the 30% point free, and not NSAID in 11.4 or 10.7, both. But we have no analgesia in the 47% of our patients. It's a lot. It means that half of our patients suffer. In the second day, the situation became worse because the routine says probably he has no problem, and we diminish the opioids, and we have only 17.5%. So the people that have no analgesia is 74.5%. And what happens if we go through a questionnaire? There are many in the literature of our patients. 64 experience pain despite analgesic. 22% analgesia was declared that was insufficient, and 48 sleeping disorders despite sedatives, and 50% was related to anxiety and pain. So, if we understand better what the patients want in the ICU, we can see that they prefer to be awake, not asleep, or very few don't know. But you see the balance between what the doctor wants and what the patients want. There is a big difference, okay? Because our target We are very expert in ventilation. We are very expert in ECMO. We are very expert in many situations. But this, for the patients, is one of the main problems. And we make a questionnaire with the nurses that works in the ICU. And they was very realistic because they say, we prefer a patient sedated, paralyzed, catheterized, colostomy, weight only 50 kilo, okay? Unmarried, orphan, with no friends, so they have no problem. This is just a joke, okay? So why have we gone wrong? Probably because we are fear of opioids, because the opioids give respiratory depression, antitussive addiction, or coma. And we consider their action unpredictably. How can we do better? It's possible. Which drug when? I would like to remember, my time? Okay, yes. That the pillar of our conduct, clinical conduct, are three. To know very well the pharmacokinetics, to know very well the pharmacodynamics, and to be very confident with the pharmacogenomic. If we know these three aspects, we can handle any kind of patients. Because we know when, during my practice, I went to OR, I know that every patient is following by another patient that is completely different from the previous one. We are not like a car, all the same. The humans are very complex, and you show in your talk during this congress. So, which drug we can use? We are lucky because we have a modern drug that can give hypnosis, anxiolysis, and analgesia together. And not only, with the same drug. This drug, I know that you're using, is remifentanil. We call this drug a friendly drug. Why? It's the drug that don't require metabolism by liver. It's the favorite drug for liver transplant because it's not metabolized by the liver. Because is metabolized everywhere in the tissue, and there is no accumulation, and is for this considered very friendly. So one main problem is to understand the drugs, because we cannot talk about opioids and confuse with the new drugs like remifentanil, because the action is completely different. Another important aspect of remifentanil that if you close the infusion of remifentanil, in 5 minutes the patients will be awake. Try to do this with fentanyl, with fentanest, with other opioids. The neurosurgeon must wait 1 day at least to have a really good observation of the patients. With this drug, you have no problem. Here you can see the balance between concentration and infusion, and the day in days. That means that the concentration decline very quickly and without no problem at all. So, please leave midazolam for other purpose, okay? I remember when at the beginning the gastroenterologist make to the patients to make endoscopy of the stomach, the midazolam. They think that was completely without accumulation, and they make the second and the third sometimes. And we have a lot of death in Europe. So we say it's important to know the mechanism, the pharmacokinetics and the pharmacodynamics of the drugs. And what about the concentration in arterial and venous is quite the same. That means that we have really, and you can see that the concentration decline in the same time, and that means that there is no accumulation. Try to do, I don't have the slide with that compare with all the other opioids, but there is a big difference. So we need to consider also that every drug has very metabolized. And what happens? Are all active? Are all giving a problem with the clinician symptom? We know that, for example, the morphine have many action with its metabolite. Okay, you can see in yellow. So we need to consider that not only the morphine is active, but we need to add also the activation of its metabolite. And if we don't consider this, the patient sleep. We can say about midazolam, as you can see, there is some metabolite that are active. But if you consider remifentanil, no problem at all, okay? Remifentanil has only one metabolite. Very few people know about this, but it's completely inactive. So I prefer to use knowledge to change the emphasis. So do we need a new short-acting opioid? What's wrong with the old one? Very easy. Old opioids are cheap, so they compare with remifentanil, okay. Unpredictable. You see that the morphine recently has changed its pharmacodynamic profile because they discovered that the comorbidities. This morning we talked about the different biomarkers, not biomarkers, the different biology in precision medicine. I was interested in this talk, okay? For anesthesia are the comorbidities. That means the age, the weight, the tall, the bodily mass, and all this. And this is very important, recovery rates. And not only the race. For example, morphine is very active in some population, not active in Negro population or in Africa. So we need to consider all this. And for this, they are unpredictable. There is a new category. I wanted to open a new scenario to all of you. How many of you knows the similarities? Can you stand up at the end? We know the brand, the generic, and now we have the similarities. Thank you, but I know that you talk about this. Okay, no one knows. But the market is full of similarities, but no one knows that are using something completely new. Okay? That is registered by FDA, but don't trust in FDA. Sorry, okay? I work with the FDA for many years, believe me, but nothing good. Have you seen with the COVID-19, the register with a few patients, and now we have a problem with a long post-COVID, okay? I am in the European Commission, and I bring the CEO of Pfizer to be responsible of this, because it's something very, very heavy in the medicine, okay? We need to be open eyes. Don't believe when someone went to you say, this is a new drugs. I say, wait a moment. Your information probably is correct, but it's a partial information. So please check carefully. Following, get away with them most of the time. We have renal failure, liver disease, the elderly. So we can use this. Progress may have been all right once. Yes, I like the progress, but it went too long. And this is important to check every time. But we have another drugs that is really friendly. I check my time. Huh? Okay. We can finish. Okay. Dexmedetomidine is the only alpha agonist, pure. That means we don't need to combine with any other drugs, okay? And is also very friendly because you see the negative feedback on the alpha 2 receptor give a big stability to our patients. We have no time to talk about these new drugs, but I want just to show this, okay? You can see a wake state and on the other part, the REM sleep. That means that the action of this drug is so physiological that it's quite impossible to separate the normal sleep of the patients with the sleep given by dexmedetomidine. This is really important. I have prepared also a talk, but there is no time, about delirium post-operative. I think that this is a very big problem. And I understand that in all the intensive care unit, we have this problem. And this is a good drugs to take care of this. I want to show just the electroencephalogram spine, the activity during the dexmedetomidine sedation compared with physiological sleep. The author and many publications conclude in this way. The EEG nearly identical to normal sleep. Identical to normal sleep. This is really important. So, what we can act, because I think, yes, the bell sound. I think that when we go to our ICU, we need to think about, I don't want that you change your attitude, because you must be convinced. And the statistic says that only 20% can change immediately the attitude. All the other must think, and it's correct, okay. So now our practice is based on hypnosis, and there's just a small analgesia. Now we need to convert our action with a principal analgesia and a small hypnosis. And I read just tonight, because I cannot sleep, on the internet, a recent review about a group, a very important group, Norwegian and Swedish, and they conclude in this way: the exitus or the destiny of our patients in ICU can change if we use less drug that can give hypnosis and we treat better pain. This is an important group, and it makes the same conclusion that I show you today. So the best monitor in awake patients is this one. So I would like to conclude. Thank you for listening to me. It's just a brief talk, okay? Let's bring back the care into the intensive care. This is ethic and mandatory for all the doctors that works in ICU. Thank you. Namaste. Okay.
So you are rightly said that in ICU there are so many causes of I think if yeah, there are so many causes of patient panic in ICU, and just by giving midazolam or sedative, it doesn't solve the problem. So we have to take all the causes of making the patient panic, and you have to solve. Then only we'll have a better this thing. So we have very good drugs, midazole, this thing, dexmedetomidine and remifentanil, and besides these drugs, we have to give proper care, and that will help in avoiding most of these sedatives in ICU. Thank you so much. Thank you so much.
Thank you, sir. I request our chairpersons, please felicitate our speaker with the memento. And I request our chairpersons, please collect their mementos from the memento desk. किसको? Okay.
Sorry for this, but I have a recent surgery on my back, so the steps are still very dangerous for me.
Thank you, sir. For the next topic, we have chairpersons, Dr. Abhijit Raijada, Dr. Devpri Lakra Madam, Dr. Avinash Tiwari sir, Dr. Arun Kedia, and Dr. Ramnesh Murthy sir. And here is some announcement from Dr. Kirino. Please, sir.
So, on behalf of my World Society, I would like to thank all my friends. I read, I don't want to miss anyone. Okay. Dr. Javert, Dr.
Dr. Yash Javeri and
Dr. Vishal. Right? Okay. And I would like to call Vishal Jasmine to the podium to give the plaque. Okay? And as an organizing person, chairperson, The motivation is in recognition of your continuous effort and dedicated service, hard work, and leadership. Thank you from all of us. Where is?
Dr. Vishal.
The second one.
And Dr. Yash Jhaveri.
And of course, to my friend Javert, he followed me during all this, the preparation for this Congress, and there are no words to express our deep felt thanks. Your talent, medical knowledge have been very important for all of us. Thank you for all you have done. Professor Quirino Piacere, okay? Thank you.
For the next session on malaria AKI prediction, I invite Dr. Marcus Schulz, Professor of Intensive Care Medicine at University of Amsterdam. He is a founding member of Protective Ventilation Network ProveNet, a worldwide collaboration of intensivists and anesthesiologists in ventilation research and lung protection. Over to you, sir.
Thank you so much for the introduction, and thank you very much for inviting me. It's a super pleasure to be here.
Dr. Monica, please join the dais for a chairperson.
Actually, I had today be present in Rome and tomorrow in Munich, but when I got this invitation, I immediately canceled all the other meetings and say, I have to be here because it's lovely to be in India. I love you people, I love the dinners, the food that you have, and I love being in the country. Everything is so nice, and this meeting already was very fantastic in the first part. So I like to enjoy you a little bit further. Now, having said this, I have to admit that I don't feel in my comfort zone. Why? Because I need to talk about a topic which is not really my topic. Usually I'm talking about mechanical ventilation in the ICU or intraoperatively, but almost never about malaria. But I got the opportunity, let me put it like this, to talk about this topic. And it is because I am partly involved in malaria research. So you see here on the bottom, I'm working in Amsterdam and also in Vienna. This is where I do my ventilation studies. But I'm also affiliated with the Bangkok University, where we do a lot of malaria research and where some of the work I will present today is coming from. So I have no disclosures to mention, but I have, of course, an academic interest, and some of the slides are actually my own work. And why is this topic so important? Well, I'm not telling something new to you today. I think you are the ones that see malaria much more often, especially severe malaria more often than I do. I'm from background an internist infectiologist, but working in the Netherlands, that does not mean that you see too many malaria cases. And when I was an intensivist working in Amsterdam, maybe 2 handfuls of patients were coming as an import from other countries with severe malaria. So your experience is much bigger. So bear with me. I'm maybe going to tell you some things that you already know, but I try to make it more attractive at the end. But why is it so important? Because malaria is, I think, soon again on the rise. We have seen over the last 10, 20, 30 years a huge decline worldwide, but I think due to climate change, but also maybe due to resistance, it will come back. And we are expecting actually, if the climate change continues, that we will have malaria again in Europe. And of course, as a transport disease or import disease, it will also be on the rise. And mortality is high. These are always numbers that shock me when I look at your country in this graph, but also the surrounding countries. Mortality is extremely high. And of course, it depends a little bit on which population you're talking about. Is it on ICU patients with malaria? Then, of course, the mortality is way higher. And a lot of these patients develop acute kidney injury. So a kidney injury usually is already unrecognized worldwide, but there are several diseases that we know of that are heavily associated with the development of acute kidney injury. And when you look at this map, it's actually in most of the countries in the top 5, if not the number 1, malaria as the cause for acute kidney injury. So, what am I going to discuss today? I will talk a little bit about the AKI incidence in malaria patients. I will talk about AKI prevention in these patients. How could we limit the progression of the disease? I will talk about the prediction of AKI and especially the prediction of the need for dialysis in these patients. And I think it's important that we recognize that this is an issue in many ICUs worldwide, but some words on that later on. And finally, I come with some research on biomarkers that can help in the prediction and nomograms that we developed in Bangkok recently. So first, the AKI incidence or acute kidney injury incidence. It's a little bit depending where you are in the timeline, but the AKI incidence has been very varying. It has been very low to very high, also in malaria cases, and that's all because we used all kinds of different definitions. And with the introduction of the KDIGO definition, I think we became more stable in defining what AKI is and the incidence is in these patients. But most importantly, we saw with the introduction that the incidence of acute kidney injury is quite high in these patients. Again, it's a little bit depending on the population you're looking at, but there have been reports in severe malaria of 20 to 45%, in the ICU up to 60%, and in children it's also higher, 24 to 59%. And especially this last population is often oliguric with a high mortality if it's left untreated. And as I already said, it's a little bit depending on where you are in the world. It's maybe depending on the differences at a regional level. Can you make a diagnosis of AKI or can you not make it? It's depending on the resources that you have available. So in Africa, it would be lower than in Asia for these reasons. But it's also depending on the species which is causing malaria. For instance, in falciparum malaria is much higher as compared to Vivax and even much lower in the no-lazy, which is much less around in the world. And as I said, the cohort differences. If you are in the ICU due to hypotension, for instance, or hypoxemia, then the risk of acute kidney injury is much higher. And it develops quite fast. We have to realize that within the first 1 to 2 days in the ICU, these patients already have acute kidney injury. So it's a rapid progression, and it's presenting itself as oliguria, anuria, but also non-oliguric AKI is common in these patients. And if it develops, it's highly mortal. So approximately 2 times to 4 times higher mortality rates. And it's even much more limited if you have no access to treatment of these patients. So conclusion 1, but I think you all know, AKI in malaria patients or severe malaria patients is very high. It develops early and it's a deadly complication of the disease. So why is it important to prevent it or to identify it early so that you can take preventive measures? Well, simply as with every form of AKI that we have or that develops in our patients in the ICU. If it develops, it's hard to reverse. It is associated with a high mortality, and the more severe the AKI is, the higher the mortality is. So early intervention have a great potential to improve the outcome of our patients. And there is, of course, a part of the pathophysiology that we have to hold in mind when we think of early identification. I will not discuss it in detail, but we have to think of the microvascular obstruction, was already alluded to by one of the speakers this morning. There is hemolysis, which play a role in acute kidney injury, and there is immune activation. Most of it is monocyte immune activation, and that maybe gives us some tools in hand to do early prediction by looking at markers of this form of immune activation. And then, of course, the treatment is in part just supportive. So avoid fluid overload when you have to give fluids to these patients. Avoid nephrotoxins. Sometimes you cannot do without it, but try to reduce it as much as possible. Of course, there's the malaria-specific treatment. Also already discussed this morning, artesunate is really a breakthrough, but we have to realize that artesunate resistance is also coming already it has been reported and it's on the rise. And then, of course, you can give dialysis if needed. It can be peritoneal dialysis, but we prefer to give chronic renal replacement therapy in the form of CVVH. And it's depending, of course, on how you can use that in your ICU. And this was one of the points I wanted to make earlier, and now make it a bit stronger. If you do not have access to dialysis in your ICU, it can be very handy. It can be very useful to know which patients are needing a renal replacement therapy soon, so you can transfer the patients. And I realize every time I come to India or to other countries outside of my country, where in the Netherlands and in Austria, every ICU is more or less the same. Here, ICUs can differ with regard to what they can provide to patients. It's improving a lot, I noticed, over the last years, but still I can imagine that it might be wise to early know about the patient where there is need for renal replacement therapy so that you can transfer the patient early. So, second conclusion, early recognition is important. You give fluids, but not too much. You give antimalarials, of course, or you give the correct antimalarials to the patients, and you try to prevent injury for as much as possible. So can we actually predict AKI, or can we predict the need for renal replacement therapy in these patients? This is what I already mentioned. This is what we would like to know beforehand. So it's not that we want to look at a patient and say, yeah, now there is renal replacement therapy needed, let's transport the patient, but already early in the start, so in the first day, or even before the patient goes to the ICU, you want to decide where you want to go with your patient. And we can use clinical predictors. Of course, there is this grading of the severity of malaria, and it's probably very much related to whether or not AKI will develop, but it's not always telling the complete story. It's not always telling us whether renal replacement therapy is needed. And by the way, creatinine, that has been used for a long time, is not going to help us because it's a quite late marker of acute kidney injury. When that one is rising, when this marker is rising, you can be sure almost that there is AKI and or there is need for renal replacement therapy. So coming back a little bit to the pathophysiology of severe malaria and what happens to the kidneys, I think there are several markers that might be of interest. And of those, I will discuss two. One is an immune activator marker, SUPAR, and the other one is a parasite load marker. So first, SUPAR. I love this biomarker for several reasons. It is a biomarker that is in a healthy population already can predict who is becoming to be ill in a couple of years. So it's a marker on the long term. But during very acute diseases, it's also a marker of death. It can help us predict which patients are going to die. It's been used in big studies in hospitals in Denmark, for instance, to see if trauma patients were having a better chance of dying, of surviving, than other patients. And the signals that came from this marker are very high. You can see here why SUPAR is called SUPAR. It's an activator or a biomarker for the activation of monocytes, and monocytes do play a role in the organ damage which is there with malaria. And we have have a lot of interest in SUPAR. This is not work from us, but in previous work, it has already been shown that SUPAR levels are strongly elevated in patients that have malaria as compared to patients not having malaria, and also compared to healthy controls. But it's also associated, or strongly associated, with the more severe a patient is. So there's an association with death, there's an association with types of organ failure like coma, hypoglycemia, severe anemia, and also kidney injury. The other marker of interest is the Plasmodium falciparum histidine-rich protein 2, PFHRP2. It's actually a marker of the load of the malaria parasite. So in the past, we were looking at the percentage of infected cells, but that's not telling us too much, if not nothing, about the cells that are causing harm in the tissue, where they are stuck in the microcirculation and actually causing the problem. And this protein is released from the schistons, from the infected cells at the moment they burst, and work by Arjen Dondorp, a friend of me in Bangkok. By doing modeling, he could show that with every new period of schisson burst, there was an increase in the level of this biomarker, actually very nicely reflecting the real load of the parasite in the human body. And he also showed, together with his team, that this marker is more related to the real load than this other marker, the percentage of infected cells. In uncomplicated malaria, in severe and also in fatal malaria, there was a clear signal. And they used this marker in a post hoc analysis of two large randomized clinical trials in Africa, where they show that this marker is highly associated with the development of more severe forms of malaria or the complications, including acute kidney injury. Of course, we have to be a little bit careful with biomarkers because we can find associations or correlations, if you like, but associations is usually the way we express ourselves, but maybe it's not telling us the whole story. You have to perform diagnostic testing, which includes ROC analysis, and that's almost never done. We also have to realize that some of these biomarkers are not easily measured, and with easy I mean they may not be always measurable in your hospital, the test may be absent, or it could be simply too expensive to use. But for SUPAR, for instance, there is a dipstick technique. It's not too expensive, but also not cheap, to be honest, and it can give you at the bedside within a couple of minutes a SUPAR level. So that one is working, but I'm unsure if you, for instance, looking at the histone release protein in your hospital where you can do that. So what did we do? And show you two examples of research that we performed over the last couple of years. First, the biomarkers. In this study, it's a small study, by the way, performed in Bangladesh. It's actually a post hoc analysis using the blood samples of these patients. We looked at SUPAR levels and we looked at the HRFP2 levels and show very nicely that there is a discrepancy, there is a difference between the groups that we created, no AKI, mild AKI, moderate AKI, and severe AKI, and severe AKI being defined as the need for renal replacement therapy. We saw the same for HRP2, very clear signal, but if you look at these figures, you have to realize that indeed there is a difference, but there is not so much contrast. And we failed actually to look at the real performance. So we did all kinds of regression analysis, univariate and multivariate, and every time showed that there is high association with outcome. In this case, it was the prediction of or the need for renal replacement therapy, but we did not do a real ROC analysis. And this will be one of the next steps that we want to do. So they might be helpful, they might be useful, but it probably remains limited due to the cost and the availability. Now, something that we are used to work with as intensivists are nomograms. Maybe you don't realize on a daily basis that we're using nomograms, but we're actually using the Apache score and subscore, which is based on a numeric number, a number that we give to the presence of certain symptoms or certain biomarker levels that we have in the blood, or the presence or absence of oliguria or anuria. And we did a new research project in patients with Plasmodium falciparum malariae. This is approximately 650 patients, where we looked at how we could build a nomogram, alike what you do for the Apache score, the SUBS2 score, or the other scores that are all out there. And we focused here on whether we could predict the need for renal replacement therapy. So here in this figure, in this graph, you can see, this table, you can see which beta coefficients and other factors are there, showing how well a certain part of the nomogram is being related to the development of the need for renal replacement therapy. And you can make a picture of this slide if you like, because in the next slide, I will actually show how we built that nomogram and how you can use it. I will show the example, but here on the bottom, you can see the URL that brings you directly to the nomogram itself. So this is the nomogram, how it looks at the website. So you can actually say, how old is this patient and what type of malaria does the patient have? What is the platelet counts, etc., etc. And by changing this, you actually get a risk score, which is here on the bottom. And there's also an advice, what should you do or what could you do? So here it's a very high risk for renal replacement therapy. And the advice is to urgently contact people, colleagues that can take care of this patient. And that could mean that you have to decide to transfer a patient. Now realize this is still under review. It's just being submitted, but the website is already there. So if you want to use it, you can use it. But let's see how the reviewers are going to look at this data. So in conclusion, malaria is on the rise again. And with that, I think there is more risk of malaria-associated acute kidney injury. We have to prepare for that. And I think prevention and early identification is very important. It may help us taking a decision to have a patient early or earlier transferred to another healthcare facility. Blood and plasma markers are there, but they are not completely tested with regard to their diagnostic or predictive validity or usefulness, so to say. And I have my worries because they are expensive to use and are simply not always present in every hospital worldwide. And nomograms could help. It's something that we used to work with, and it's very helpful. I have to say, when I look at the nomogram that we developed, whether the nomogram is not just telling us whether the patient is having severe malaria, which is true. So we have to see how it outperforms the simple severe malaria scores that are out there. But it's useful and handy, especially if you're less experienced with malaria. So maybe not you, but when you're in another country and you're faced with malaria patients, you can use this tool to have a prediction and decide what to do. And this is where I would like to stop and give the word to the chairs of this session. It's a pleasure to give this lecture.
Thank you very much, Dr. Marcus, for that wonderful presentation, bringing global perspective to the problem that is so very rampant in India. And with all the predictors and clinical markers, I have Dr. Devpriya and Dr. Saab and Abhijit and stalwarts like Colonel Dubey and all practitioners, Ravi sir and all. I mean, we can have a good, healthy discussion, and not only questions, we can have even observations that we come across and we have seen, making it meaningful and interactive. So the session is open for discussion.
So how commonly do you see malaria in your part of practice?
It's a little bit depending on where you ask where I am. So I work in Amsterdam and I work in Vienna, and yeah, their malaria is really an imported disease, and we see it maybe a handful per year, and that's not even severe malaria. But when we go to Asia, here, for instance, and the hospitals I'm affiliated with in South Asia through the Bangkok University, it's much higher. Up to 20% of the patients that come with a febrile disease are having malaria as the cause.
And so what do you feel is the strongest predictor of AKI in malaria, sir? Which is the most important predictor so far in your practice? What have you found?
Yeah. Correct. If that's what's your question.
Sir, what is your comment on the strongest clinical predictor for AKI?
So the strongest predictor, if you look at the nomogram that we built, the strongest predictor was actually the rise in the BUN and the creatinine. So again, you come to these biomarkers, but the added value of the others were as important. So it could be that in some patients, and this is what I like about the nomogram, in some patients where their BUN and the creatinine is still low, but the other factors are higher, that is giving us a better prediction. Not as high as this 90% as I gave in the example, but lower, but it's still very helpful.
And how commonly do you see patients presenting in shock?
Well, this is a difficult question for me because I do not have the personal experience with that, but we see quite some patients that come in with shock. The problem here is that in the areas where we do the research, they often come with a co-infection. And the question then is this malaria? Or was malaria just a bystander? And is there in reality a bacterial infection? Or is it a combination of the two? I have to give a rough guess of what we have seen in our studies. I do not have the numbers at hand, but it's approximately 10 to 20% of the patients that came in with shock.
Sir, in last 20 years, still the mortality is very, very high in this part of world. So these particular markers, if they are applied in particular subset of patient, maybe a huge benefit to our population will be there. But most important part is, you said creatinine, either we have to check in every patient or particular subset of patient where creatinine is going up, because you said it is a very early marker. So which are the preferred patient, which should be, this particular markers must be tested if available?
Well, that's for me a very difficult question. I think you can give the answer way better yourself, is all your experience. So I would like to give the question actually back.
Yeah, we are in secondary setup, and this part of the Chhattisgarh is huge. It is flooded with malaria with a very high mortality, and most of the patients are referred in multi-organ failure or hemolysis, or for that matter, very, very sick patients with so many comorbidities. So that marker must be a very helpful thing, handy thing. Thank you, sir.
Thank you, sir. I think if any question, we'll discuss later on.
Yeah.
So before we going to next session, I request our chairpersons, please collect their mementos from the memento desk. Thank you, sir. Thank you. We have some changes. So
next topic is by Dr. Jayanti Mani on status epilepticus. Ma'am is a consultant neurologist and head of epilepsy program at Kokilaben Dhirubhai Ambani Hospital in Mumbai. She has more than 20 years of experience in the field of neurology with special interest in epilepsy.
to chair the session, I would like to invite Dr. Chhatrapal Sahu sir, Dr. Parvati Gupta, Dr. Menka Agarwal madam, and Dr. Lalita Rao ma'am. Please on the dais to chair the session. Over to chairpersons. I repeat, chairperson Dr. Chhatrapal Sahu, Dr. Parvati Gupta, Dr. Menka Agarwal, and Dr. Lalita Rao. I request Dr. Shailin Sharma to please give a mementos to our chairpersons. I request Dr. Santosh Singh give a mementos to our chairpersons at memento desk, please. Over to chairpersons.
Good afternoon, all. I think Dr. Jayanti Mani ma'am is not a new name in our Chhattisgarh region. She is well known among our neurologists, and I think general medicine people have also listened to her talk earlier.
Thank you.
She will be speaking on the very important topic, status epilepticus, which is, a very important emergency medicine topic. And it is very important to know the exact and timely management of status epilepticus. Over to you, ma'am. Thanks.
Thank you so much. Thank you, chairpersons. And thank you to Dr. Vishal for inviting me here. I really feel excited seeing this vibrant audience here with a full packed room, and looking forward to sharing a few nuggets about status epilepticus. So this is going to be the outline of my talk. I'll be first giving some concepts and definitions. Then we will look at what is the pathophysiology and how it impacts how we are treating epilepsy emergencies now. We'll also briefly look at how we can classify status, the etiology and the complications, but mainly I will be focusing on the management aspects and review certain recent changes in treatment strategies. So status epilepticus has been recognized, years ago, and as early as 1970, Gasto defined it very conceptually and called this a condition where there is enduring epileptic activity for a sufficient length of time that it makes it unlikely for the seizure to stop spontaneously. So this is a very interesting concept because we know that most seizures stop in about 5 minutes. But if it goes on for a critical period beyond that, it's unlikely to stop on its own, and we need to intervene because it can cause brain injury beyond a point. So the question always is, how long is the sufficient period before which it wouldn't stop and before which it can cause damage? So for a long time, it was assumed that 30 minutes, when seizures last beyond 30 minutes, that would be status epilepticus. This was because it was based on brain injury caused in animal experiments. But more lately, we have a more operational definition. And in this, we look at status in two ways. One is when seizures last beyond 5 minutes. It's not 30 minutes anymore. And this is based on some pioneering work done by Lowenstein and published in Epilepsia. The other way of looking at status epilepticus is if there are discrete seizures, if they keep happening over and over again, without complete recovery of consciousness, even this would qualify as status epilepticus. So the question will be, why did this timing change? Why did it move from 30 minutes to 5 minutes? So there are a few reasons, and this is based on scientific observations over a period of time. We all know that the average time that a generalized tonic-clonic seizure lasts is about a minute. And if it lasts 5 minutes, it's actually 18 standard deviations from the mean. That's how infrequently that a seizure lasts beyond 5 minutes. We also know now that the longer the seizure, there's less likely to stop spontaneously. Also, longer the seizure, it's also more difficult to control because they have found that if we gave the benzodiazepine or the phenobarbital in a patient with status, if it is given within less than 20 minutes, there's an 86% chance of the seizure stopping. But if you give it late, that is, if you give it beyond 30 minutes, then this drug is likely to respond, the person is likely to respond only in 15% of the occasions. So time is really brain, even in the situation of acute seizures, because we really need to intervene early. Also, even survival data shows that longer the seizure, from here, as you can see, if it lasts more than an hour, then the survival rates are much lower than if it lasts less than an hour. So the top line is if it lasts less than an hour. The bottom line is the survival curve at 30 days with the mortality if it lasts for more than an hour. And you can see how dramatically the survival rates can reduce if the seizures last long. So still coming back, then the ILAE, that is the International League Against Epilepsy, came up with this definition about status epilepticus, and they defined 2 time points. They said T1 is the time beyond which we realize that seizures will not stop on their own. This is now for convulsive seizures at 5 minutes. And time 2 is when if the seizures go on and on, there would be risk of long-term consequences. So the operational definition of 5 minutes refers to the time point T1, and the 30-minute time point would be for when there could be permanent damage, and that's time point T2. Now, when we look at seizures themselves, we all know that tonic-clonic seizures are only one type of seizures. You can have complex partial seizures, you can have absence seizures, and the extent of damage can be slightly different in each type of seizure. For example, if someone is in absence status, the likelihood of brain injury is much lower, so you have a longer leeway time, and this is represented in this situation here, where it shows that the T1 and T2 timings can vary according to the type of status. It's much longer for absence in the lowest bar, which is yellow. It shows that it can be up to 15 minutes, the T1 time. And in fact, there may not be a clear T2 time because we are not documented permanent brain injury with absence status. So according to the duration also, we can classify status, and we will look at this. There is an early phase, there is an established phase which lasts beyond 10 minutes, Then there's a third refractory phase where it depends on how they are responding to the treatment as well, and usually it's 30 to 60 minutes. And then there is a super refractory phase when none of the drugs and even the anesthetists are not working, and this is usually beyond 24 hours. So when we look at pathophysiology, this point is very important because this is now directing how we treat patients with status. So in the early phase, it's the neurotransmitter is the GABA neurotransmitter, which is the most predominantly operational neurotransmitter. But in the later stages, in fact, it's the GABA transmitter, the receptors get internalized, and there is an excess of glutamate receptors in the surface of the neurons. And in fact, it may be the anti-glutamate drugs that may work better. This may also be the reason why benzodiazepines really don't help very much in established or advanced status. Then also we know that the damage to the brain by various mechanisms is also time bound. Now, etiology is again a lot of causes can lead to status. And why this is important? Because more and more we realize that just addressing the seizures is not enough. Parallelly, we need to be exploring and evaluating for the cause and also treating the cause, because unless the cause is addressed, just repeatedly giving various anti-seizure medicines may not do the job. So among the common ones are, of course, stroke and CNS infection, and sometimes missed anti-epileptic drugs, and more lately, autoimmune and paraneoplastic causes are also being identified as very much treatable causes of refractory status epilepticus. So with this background, now we'll go to the treatment. And what are the principles? Again, it is about being in a hurry. When you start with status epilepticus, you have to be in a real hurry to start treatment early. In fact, the treatment doesn't begin in the ICU. It begins actually as a pre-hospital care. And that is very, very important to remember. So you also have to remember to use the anticonvulsant doses in fully. Many often, half the amount is given and then the seizures don't stop. So you have to use full doses of anti-seizure medicines. You have to be ready to escalate the drugs rapidly in a time-bound fashion. In fact, there is a dictum that too low and too slow, these are the causes of poor outcome. It's not really about the choice of medication. It's about how rapidly and how adequately you use each one of them. So it would be also, for example, phenytoin, normally we say beyond 20 micrograms per ml is kind of a low dose. But here you will see it is much, you need to keep much higher levels. And you also have to provide supportive care and identify and treat the cause. You have to remember to maintenance therapy has to be started. So importantly, the amount of evidence we have is very limited for controlled trials to give us any guidance on what kind of drugs to use. So again, I emphasize treating early and hitting hard is the most important thing to do. And treatment starts outside the ICU with impending status, and then we get into established and then refractory status. In pre-hospital treatment, benzodiazepines are the best. We have various formulations, and now the most popular is the intranasal midazolam because it acts the quickest, as you can see here. Intravenous works in 5 minutes, whereas the intranasal works in 15 minutes. All other forms of benzodiazepines, rectal or buccal, take much longer to act. So once you have the patient in the ICU or in the emergency room, of course you can use these drugs intravenously. Lorazepam is the best one to use because its effect lasts longer, so there's less chance of a relapse of the seizures. And for the same reason, diazepam is not so much preferred because it tends to cause peripheral redistribution and the seizures may come back. So once that is done, earlier we used to use either phenytoin or fosphenytoin. We would repeat phenytoin after 15 minutes in a half-loading dose. This used to be the conventional way of treating status epilepticus. And right now, we also need to remember that between phenytoin and fosphenytoin is much safer, not that it is more effective, but it is safer because of this one thing which can happen with phenytoin. That is what is called the purple glove syndrome. You have to be very, very careful that you use the diluent should always be saline and never glucose when you use phenytoin. And you have to keep the rate of phenytoin infusion at 50 milligram per minute and no more. So this is where phosphenytoin scores over phenytoin because it is water soluble. Now, the previous studies for established status were very ambiguous and arbitrary. We didn't have clear data. So we would use either phenytoin or phenytoin with phenobarb. This used to be our common options. But this very landmark trial that was done in 2019, again by Lowenstein's team, and this was published in NEJM, they've looked at a prospective study and compared 3 drugs, phenytoin, valproate, and levetiracetam, and they found that all 3 are equally effective. And that is why now we can use either phenytoin or valproate or levetiracetam as our first-line drug after a benzodiazepine. Subsequent to this, if the seizures continue, it will all depend on the facilities available. If there are no ICU facilities or ventilation facilities available, one could then go ahead and use one more round of anti-epileptic drugs, maybe phenobarbital or even lacosamide nowadays is a good option, and it gives you some more time to shift the person to a higher center. If you have facilities for ventilation, then it's better to intubate the patient and look at either midazolam or propofol, and less likely thiopentone. Now, earlier, midazolam and propofol there used to be comparative studies were very limited, and it appeared as though propofol was not a safe option because of this dangerous propofol infusion syndrome. But more recently, a larger study looked at propofol versus midazolam, and in fact, both compared to each other, both in terms of its efficacy and safety. So I think we are learning to use propofol more safely, especially in smaller doses and for shorter periods of time. So this is where, we may be able to use either. So as I said, one should be still aware of this propofol infusion syndrome. It happens when you use it at very high rates, or if you continue it for a much longer period, or if you're using concomitant steroids, or if the person is poorly built and is in critical illness and sepsis. So finally, when none of these work, then we call it refractory or super refractory status. And as I said, because some drugs like propofol and ketamine work via the glutamate receptors, they may be better choices after midazolam doesn't work. So that is why there has been now more and more research on ketamine, and there is very good evidence that it is a safe drug to use. In fact, 57% of patients showed a resolution of seizures within 24 hours when it was tried in adults. And we have much more evidence, both in adults and in children, that it works very well, and in fact may be much better than all the other anesthetic agents. So we also need to know that we may have to use EEG in these situations to treat refractory status. And there is now a concept that you don't need to go to burst suppression. You can just do seizure suppression because the doses of drug required for burst suppression on EEG are much higher, and that can lead to much more complications. So this is an example of a burst suppression EEG, and this is an example of periodic discharges on the EEG. So as you all know, we have to keep providing supportive measures. I'm not going to get into this in the interest of time. We have to identify and treat the cause. If it is, for example, meningitis, you have to treat it with the appropriate antibiotics or antivirals. Autoimmune etiologies have to be explored for. And when you withdraw the coma after all this is done, you have to do it gradually. Please don't try to take off the drug, the sedation every day and to check what is happening. It's rather that you keep the coma for 24 to 48 hours and then gradually withdraw it. Keep monitoring with EEG because sometimes the person may not wake up and may be in subtle status like this. It could be, they could be having electrical seizures and not be waking up because of that. Then 2 words about these 2 conditions, NORS and fires. These are all examples of sometimes where we don't find a reason and their patients come with first time onset seizures, which is super refractory and very, very difficult to control. Now there is more information here that other than using anticonvulsant drugs, you have to institute immunotherapy really early. In fact, methylpred, immunoglobulins, plasma exchange within 72 hours. And sometimes you may also have to resort to rituximab versus tocilizumab to treat these conditions. There are also other drugs, and I will not get into this. Sometimes you may have to resort even to ketogenic diet, and very rarely surgery has also been done in focal status. There are a lot of complications. We need to take care of those. And we have to be aware of this whole big other condition called non-convulsive status, which I'm not getting into today. It has a high mortality. It often goes under-recognized because it's people with unexplained coma or altered consciousness in the ICU. So you should get an EEG done in such patients. Interpreting this EEG will need the help of a neurologist or an electrophysiologist because it can be complex, but you may be able to decide treatment based on this. The outcome of status depends on multiple things. The type of status, if it is refractory, then it as high as 33% and even up to 50% in non-convulsive status epilepticus. And there is also risk of further seizures. The age, the etiology, the comorbidity, the duration of the status, and the level of consciousness, all of these impact the outcome. And there is a score that is used called the STESS score to help you make an early prediction of what the prognosis can be. I've really rushed through this, bear with me. So I'm going to stop here and say my motto is seize the seizures early. Every minute counts, and you have only 30 minutes. So you have to really move fast because time is brain. So thank you so much. And it's kind of overshot a bit, so yeah.
Thank you, madam, for the short and very elaborate
Rapid.
talk.
Yeah, thank you.
Any questions?
Thank you, sir.
Thank you so much for your detailed analysis, because this is a very difficult topic, and being obstetricians, when we get patients in epileptus, it's very difficult for us to understand what to do.
Yeah, so there is magnesium gets used in pregnancy quite a bit. I did mention, but I didn't get the time to talk about it. So many situations are quite unique. Yeah.
Thank you so much.
Thank you, ma'am. I request our chairperson, please felicitate our speaker with a memento. And I request our chairpersons, please collect their mementos from memento desk. And I request, yeah, you have question? Actually, madam have to rush. She is having flight. You can, please. For the next session, I would like to invite to chair the session Dr. Vikas Goyal, Dr. Pankaj Modghare, Dr. Sanjay Pandey sir, and Dr. Ambar Garg.
I once again invite Dr. Venkatraman Kola to shed some light on coagulopathic emergencies in ICU.
I request Dr. Ravi Jaiswal, please felicitate our chairpersons with the mementos at memento desk. I again repeat chairperson, Dr. Sanjay Pandey sir, Dr. Vikas Goyal, Dr. Pankaj Modghare, Dr. Ambar Garg. Over to chairperson. And I request Dr. Jaya Lalwani, please join the dais as a chairperson.
A warm welcome to Dr. Venkatraman Kola, the Clinical Director at Department of Critical Care Medicine, to please begin his deliberation on coagulopathic emergencies in ICU.
Thank you, Chairperson. It's very heartening to see such a jam-packed halls. Not a common phenomenon in the current conference era. Conferences are flooded, and we see a few delegates in the audience, and most of them are the next speakers or the chairpersons. But an exception, this has been a phenomenal Congress. So for the next 15 to 20 minutes, I will try to cover the coagulopathies in ICU. It's a vast topic. It's a wide range of syndromes and phenomena will come. So what I did is I took 5 cases of my last 5 weeks cases of my own ICU and tried to bring insights of all those cases. So the major components of hemostasis goes through these 3 or 4 mechanisms. The blood vessel, the platelet activation, coagulation cascade, and all of the 3 plays a virtuous stride components, and anti-thrombotic effect keeps the blood in flowing without clogging. So all of them act together. And whenever there is a injury to the vessel, initially the vasoconstriction, platelet plugging, then a coagulation cascade creating thrombin, which converts fibrinogen to fibrin, and a more firm blood clot forms. And later, the plasmin has been fibrinolized and clot degradation happen. And this will be the basis of all our discussion in the future. We all understand the intrinsic, extrinsic pathway and a common pathway to get into the thrombin, which actually converts a plasminogen into plasmin. So the initial phase where a intrinsic initiation happens with a tissue factor, and then that followed by a amplification phase where you actually get the activation of a platelet, and then you have a propagation phase. Finally, there will be a clot formation. So generally, whenever we talk about a homeostasis or coagulation issues, we talk about to approach in this way. We take a quick history, we do a clinical examination, and then we actually send these basic tests to see the coagulation cascade. We send platelet counts, we send a prothrombin time, we send activated partial thromboplastin time, and we send a fibrinogen. This is a common panel which we send most of the times. Please keep attention on this slide. So this is talks about the history where we rule out inherited defects or use of any antithrombotic or anticoagulants in your patient. Then is the bleeding local or it is a generalized? Is there a hemo joint? A joint has been filled, deep-seated, mucous membrane, skin, all that gives you a clue. Then if there is a generalized bleeding, we look at coagulation screening. If you look at all this, these are the permutation combination which you get in your patient. The first one, low platelet count with normal results on coagulation screening. That is, PT, APTT are normal with a low platelet count. Either the production is low with your marrow supporting or the survival has a problem because of antibody-mediated platelet destruction, which we say ITP, or you have some splenic pooling, which sequestrates and take out all your platelets out. Or a low platelet with a fragmentation of your RBCs. That gives you a clue you have a cystocytes. So are you dealing with some microangiopathic hemolytic anemia? They are MAHA. Or a normal platelet count with coagulation deficiencies like PT, APTT are also prolonged. It can be due to survival decrease. In many situations where coagulation factors have been in low in quantity, or is there a DIC happening there? In DIC, you go through this whole process, which we will discuss in the later part. So this whole summarizes if this patient has a low platelet count alone or in combination. In ICU, when I actually look at a thrombocytopenia, the first thing what we do is we rule out a possibility of a pseudothrombocytopenia. Is there a clogging happening in your blood container or a test tube? And you check whether there is any EDTA dependent platelet antibodies there. And if that is there, you can ask for a citrate and ask for a manual count. That's the first thing you have to rule out from your blood bank. The second, you ensure that you are not using any drugs there, heparin or any anticoagulants which can, or antiplatelet which can hamper your platelet count or it can be a cause for a thrombocytopenia. Then there is a big list of things. Sepsis, major blood loss, a fragmented RBCs which we see in extracorporeal therapy, in pumps, or a immune-mediated thrombocytopenia, microangiopathic hemolytic anemia which we see in TTP, HUS or immune-mediated thrombocytopenic, and then hypersplenism or your marrow-related issues or a cancer. Again, the first common cause of coagulopathy in critically ill can be a combination which we see a lethal triad is hypothermia, acidosis and hypocalcemia. Whereas a dearranged homeostasis can be because of a DIC or a sepsis or a cardiac surgery, whereas consumption-related thrombocytopenia can be seen with the external circuits or enlarged spin. Acquired things can happen with a trauma or a cardiopulmonary circuit or a the placental disorders. The blood loss, again, in a trauma or a basal blood loss can be another phenomenon. Dearranged generation, when I have actually a vitamin deficiency, liver diseases, hemophilias, dysfibrinogenemias, drugs which actually consume them, or a marrow suppression, or a B12 or folate deficiencies, all this will come in the category where your generation is in deficit. I'll just try to actually take you through. Suppose we have a coagulation issue. So we test APTT, PT, and a common TT, that is thrombin time, and we find them to be abnormal or normal. The confirmatory test is generally done by a factor assessment. And factor assessments are done in most of our centers to identify the factor deficiencies. Then, if I have a problem with von Willebrand factor, we look at the platelet function analyzer or a von Willebrand factor antigen. And antigen platelet activity genetic testings are done to actually identify this. If I wanted to look at the platelet function, which is one step ahead, I told the screening test is generally done by the platelet count. But if I wanted to actually look for a platelet function, probably I will go for this different ergometric tests, which are again available in a higher centers that. And fibrinolysis, euglobin test, which is the commonly attended. And anticoagulation effect. If I wanted to check anticoagulation effect, probably we will check APTT, PT, TT, depending on the pathway which this anticoagulation is affected. I will now take you to the 5 series cases which we have seen in the last couple of weeks, which will tell you the spectrum of coagulation disorders which happens in ICU. This was a 65 years old gentleman, came with a fever, chills, loin pain, very typical of something related to the urosepsis with a pyelonephritis, a known diabetic hypertensive with a benign prostatic hyperplasia, received to us after 5 days of empirical ceftriaxone in an outside center, developed hypotension there, so that's why this patient was shifted to us. On investigation to our hospital, there was a drop on HB, there was a raised leukocyte count, there's a drop in platelet, APTT and INR were prolonged, fibrinogen was low, D-dimer looks higher. So there was also elevated LDH, there was a peripheral smear suggesting cystocytes. So impression, differentials. There will be different differentials which can come in this. There is a sepsis on bound, cystocytes are there. There is a raised LDH from a microangiopathic hemolytic anemia to a possibilities of a DIC is there. So this case is more of a septic shock with a DIC rather than what we generally thought about a microangiopathic hemolytic anemia. The reason is, along with the thrombocytopenia, you see PT, APTT, both are prolonged, INR and APTT. Generally, when we talk about a TTP, HUS, microangiopathic hemolytic anemia, your PT, INR, APTT will never be prolonged. So this goes in more in favor of a possibility of a septic shock in DIC. So again, whenever we talk about a DIC, we first look at the risk factor. In this case, we had a sepsis on board, shock on patient is in shock. So that fits to the sepsis. Underlying disorders where you actually score the DIC on the basis of your platelet count, on the basis of your fibrinogen degradation product or D-dimer, on the basis of your PT and fibrinogen levels. If you see platelets are less than 50,000, it goes higher. Your fibrinogen degradation product or D-dimer is not increased, it's 0, strongly increased is 3. If prolongation of PT is there, you go into the negative score. If it is less, then you go in the higher score. So we use this DIC score and then calculate the possibility of a DIC in them. Again, whenever we come across a DIC, it is a disseminated intravascular coagulation. You have a consumption coagulopathy and there is ongoing clogging everywhere in a microvasculature, which we see as a purpura fulminans in a septic patient. So in those cases, I wanted to know whether I have a bleeding tendency, because of the deficiency of platelets or deficiency of clotting factors, or I have a problem with more clogging. How do I do that? Most of the times we are PT, APTT, or your platelets and fibrin degradation products or fibrinogen will be low. We do it by this, either a TEG or a ROTAM, thromboelastic meters, which will tell you about the possibility whether I am having a problem with more of clogging or I am having a problem with bleeding. So again, the R time or a CT time, the angle, the R time talks about your clotting factor deficiency, and then you talk about the strength of the thromboelastography is more talks about your platelet stability or a platelet count. And again, lysis will be talked about your active fibrinolysis in them. So again, this is a way where TEG has been interpreted. If I have a problem with art time, probably I talk about the time to start of the clogging is getting delayed, so I have a coagulation proctor problems. So probably I will supplement with FFPs or a maybe the 4-factor PPPs which come. If I have a K time prolongation, I have a problem with fibrinogen, I will use cryoprecipitate. Alpha angle has a wider, I will use a cryoprecipitate. Amplitude has a problem. Probably I will use platelets. If I have a quicker lysis, probably I will use a tranexamic acid. So this is how actually we interpret them in a patient who has a DIC. I don't know whether I to give a anticoagulants or I use blood products to support them. Depending on this ROTEM or a TEG, we can consider them to transfuse. So the ROTEM, and again, the final come is you use either a FFPs or PCC on the basis of your CT or R, and you use your platelets on the basis of your MA or MCF. You are on the basis of lysis, you use a TEG. Then when you look at the DIC's pathophysiology, we always see ki whenever a patient is in sepsis, along with a pro-inflammatory phenomenon, you actually land up into this microvascular clogging. So if I have a DIC in place, if I see the patient has undergoing invasive procedures and I have a problem with the platelets and coagulation factors being abnormal, probably I will supplement them. For that invasive procedure, we avoid platelets. Most of the time, we try to give FFPs or a cryos. But if I have no major bleeding and I have a possibility of a microthrombi, maybe I may consider a careful anticoagulation in them. So this is the way we proceed. So again, these are the examples where we see DIC, severe infections, malignancies, trauma, OBZ, and all these were the conditions, AML or a multiple trauma, burns, abruptio, and vascular malformation, immunological issues and all. The second case, so that was a case of a DIC. Second case where a patient with fever and body pains of 5 days came to us with a low HB, low platelet, 1 episodes of seizure, referred to our center. You could see there is a drop in hemoglobin, peripheral smear saying cystocytes. There is a platelet drop, LDH was high, bilirubin was high, and APTT, PT were normal and with a normal fibrinogen. So this most of the times suggesting a TTP or a TMA with a plasmic score, score giving you a clue in them, and we send Adams 13 levels and we use a plex early. So all the septic patient may look like they can have a TTP. You need to differentiate because in sepsis, you only control the source and give antibiotic. But in TTP, without a plex, without this effective treatment, you may lose these patients and there is a high mortality. And plex can drop down your mortality from 70-80% to as low as 10%. So you need to differentiate between a septic DIC versus a TTP, which will give you a therapeutic option. So this is how actually we conclude thrombocytopenia, your PT, APTT and fibrin degradation products are normal. Then you look at whether you have raised LDH, cystocytes, and these are the 4 which differentials come. They are prolonged, then you are dealing with a DIC. This is the third case where a patient with fever, cough, and SOB presented to us and had a known APLA case, and we have a dearranged APTT alone. With all the other parameters looks normal. You have a thrombocytopenia with abnormal APTT. And generally, when we actually come across such situation, we look for mixing studies. And what is a mixing study? Mixing studies is we add healthy plasma to this plasma and see whether it is getting corrected. If it is getting corrected, probably I have a factor deficiency on board. If it is not getting corrected, it is not factor deficiency, but some antibodies which are stopping my clogging factors. So how do this get corrected? It will not be get corrected by any replacement of FFPs. It will only get corrected by treating those antibodies and taking out them from the body. This was the last but one case where a ILD patient on ECMO for a bridging transplant in the last week had an end-stage lung disease. There was a drop of HB, there cystocytes in the peripheral smear with thrombocytopenia, raised LDH, raised bilirubin, and we realized that this patient was on heparin, and when we sent a hit antibody turns to be positive. How do we actually diagnose a hit antibody? We use a 40 clinical probability score, thrombocytopenia, timing of onset, thrombosis, that is if you have a skin necrosis or thrombotic episodes, and we score them, and a hit antibody positive, I need to stop heparin and change alternative anticoagulants in them, either a vivaloridine or alternative modalities in them. And we stopped heparin, changed to vivaloridine, and this patient thrombocytopenia is slowly improved. The last case, a fever with abdominal distension in an alcoholic CLD, which is not an uncommon cases to all of us, has a dearranged coagulation parameters with ongoing INR was high, platelets were low, and the total bilirubin was going high. So most of them is a decompensated CLD, which actually needs again the source control, and most of the times we don't treat them with FFPs and platelets if they are not actively bleeding. The reason for that is this. See, whenever you have a CLD and decompensated liver failure, your production of clotting factors drop below 30, then your hemostasis comes into problem. Similarly, there will be a drop in production of anticoagulants. Coagulants will drop, anticoagulants will drop. So there will be reset of your homeostasis mechanism. So there is a resetting. So you really don't have a probably a hypercoagulable state, but many of the times we land up in hypercoagulable state. If you do a TEG in them, your PTINR, APTT will be high, but if you do a TEG, you will realize that they are hypercoagulable. And the examples for that is, most of these patients will be having a portal vein thrombosis. They will have a hypercoagulable state. So treating them with FFPs or cryoprecipitates or platelets will increase the risk of death and further problem if not indicated for an active ongoing bleed. And the other things which commonly we see is your dysfibrinogenemia and a ongoing lysis of that, which is again not uncommon in them. So to summarize, if I have a thrombocytopenia on board, I look at PT-APTT. If PT-APTT are prolonged, I will look at whether there is a major bleeding. Is there a factor deficiency? If no, then we look at D-dimer, prolonged low fibrinogen level, and a DIC score. If that is positive, it is a DIC. If all of them are negative, we look at sepsis and liver dysfunction or anticoagulant or a drug use. If there is a heparin exposure, and there is no PT-APTT prolonged hit comes, if there is no heparin exposure, then if I have a cystocytes, then I will come TTP, HUS, thrombotic microangiopathy as a possibility. And if none of them are there, no cystocytes, immune-mediated thrombocytopenia can be a cause. So this is again an example of PT-APTT when they are normal, abnormal in a combination. You will see in your reports PT is normal, APTT is normal, and you have a coagulation, bleeding patient. The problem is with platelet dysfunction. If a normal platelet count, you will see that. If my PT is prolonged, APTT is normal, you will find all these extrinsic pathway being involved. If my PT is normal, APT is abnormal, you will find most of the intrinsic pathway being abnormal. Both of them are involved, maybe a common pathway, or you have these deficiencies or causes. So this is
Sir,
again a
we should conclude, I think.
yeah. So this is again a classification of all the disorders with what are the clotting or what are the different coagulation tests which will be abnormal, and these are the different drugs which can cause which kind of prolongation with which form. And this will be the last but one slide where you can actually see the all anticoagulant, antiplatelets, and what dearrangements they can cause. So again, the blood products, you can also see what are the disadvantages and advantages. This was my last slide. Again, a massive transfusion, a massive blood loss can also cause a severe dilutional conjunctional coagulopathies, which will need a tranexamic acid, which we say start a loading and use another gram in next 8 hours as an infusion. And you use FFPs, platelets, RBCs in 1:1:1 ratio and perform a serial coagulation test. If you have actually inbuilt any rotum or TEG, use them. Otherwise, depending on whether you have a low fibrinogen, use cryos. If I have a low PT-APTT or high PT-APTT, use FFPs. If you have platelets count which are less than 50,000 and patient is ongoing bleeding, probably use platelets. So this is the final concluded slide which will give you a overview of a massive transfusion related protocol. With this, I thank all of you for patient listening. Thank you.
Thank you, sir, for the very elaborate presentation along with the real life scenarios. I would like to know your experience of the use of factors in the treatment of coagulopathy, individual factors.
Yeah, so we have acquired factor deficiencies which we know can happen with the hemophilias and different kind of, and these factors are available when I know which factor is deficit. Suppose these are all kind of hereditarily somebody has a hemophilia deficiencies. These factors are exclusively available, and our hematology department most of the times get a referral and they give these products and the factors to them. So a factors assessment is done to evaluate which factor deficiency. And currently, in one of our cases, we also saw acquired factor deficiency. We all were aware of hereditary factor deficiencies, but we also see some of them during one of our case in a ECMO. We also saw some acquired factor deficiencies, which we, being a clinical practitioners, has a new exposure. This all comes only by the assessment of these factors in a lab where it is available, and there are exclusive factors which are available. If I don't have a specific thing, in particularly when I actually have an anticoagulant, Novak related bleeds, we use 4-factor supplements, that is PPC.
Thank you, sir.
Thank you, sir. I request our chairperson, please felicitate our speaker with a big round of applause. For the next session, I request our chairperson, please collect their mementos from the memento desk. For the next session, I would like to invite Dr. Tripti Nagaria Madam, Dr. Sarita Agarwal Madam, Dr. Jyoti Jaiswal, Dr. Nirja Agarwal, Dr. Monica Pathak Madam, Dr. Palak Gauri Madam, Dr. Preeti Singh,
I invite on stage Dr. Sharmili Sinha to discuss on obstetric emergencies in ICU, saving 2 lives. She is Senior Consultant in Critical Care Medicine, Apollo Hospitals, Bhubaneswar, having more than 18 years of experience in critical care medicine. She is a teacher examiner at National Board of Examinations and Indian Society of Critical Care Medicine. She also represents India at World Federation of Intensive Care and Critical Care Medicine. Over to you, ma'am.
Thank you. Thank you for your kind words of introductions, and thanks to Dr. Vishal team Raipur Criticon and Team Ramkrishna for this kind inviting. Wonderful city and wonderful venue. And coming to about approach to obstetric emergencies, it is one of my interest areas. And we know that the maternal mortality rate in India over last decades has declined, but it is still high in at least 6 states of the country. And Chhattisgarh, Odisha, Andhra, Telangana, and Gujarat and Uttarakhand are the 6 states where still the MMR, maternal mortality rate, remains above the national average. Hence, the path remains continued education and training. So these are the learning objective of today's session. And what are the obstetric emergencies that we'll be trying to cover in a very short time. And I think it was 20 minutes in the invitee, so I'll take 20 minutes, ma'am. So maternal shock, these are the ones which we'll be covering during our talk. So I'll start with a case scenario and I'll confine my discussion mostly to clinical and critical care perspectives. So this is a 34-year-old lady who has anti-fertility treatment and she is now 35 weeks pregnant, primigravida, obese. Antepartum checkup was normal. She had a vaginal leak with mild pain at 35 weeks. She was taken to a nearby nursing home, found to have premature rupture of membranes and then immediate cesarean section was performed. At delivery, she had significant hemorrhage, which was managed with IV fluids and packing was done. But she continued to have hypotension, tachycardia, and she required vasopressors. She was intubated. There was no, and she was shifted to our hospital. At admission to our ICU, there was no obvious bleed, but she continued to have persistent hypotension, tachycardia. Hemoglobin was 8.2 grams. She was given around 1 unit of PRC in her place. So what is the diagnosis? These are the 4 differential diagnoses, probably the most common ones. There could be anything else apart from this. Just keep in mind and we'll discuss as we proceed. So this is another case, is a 32-year-old female who is postpartum, now presents with a history of high-grade fever, pain abdomen, and she had syncopal attacks in last 24 hours, decreased urine output as per history, and she has a history of LACS done around 1 week ago. On examination, patient is hypotensive, drowsy, she is hypoxic, and tachypneic as well. The total counts from outside reports is around 20,000. Hemoglobin is on the lower side, 7 gram%. Platelets are also low. LFTs are deranged, and so is the urea creatinine elevated. Now, arterial blood gas shows metabolic acidosis. What would be the cause? Most likely, clinically she is in shock. Now we're talking about what kind of shock. So how do you define shock? It is inadequate delivery of oxygen or metabolites to tissues at the end organ level. Whatever said and done, if your blood pressure is say 80 or 90, that doesn't matter. It has to be a clinical manifestation of hypoperfusion that we are worried about. So what are the types of shock? There are the 4 major categories of shock for clinical purposes and for management point of view. Hypovolemic shock. So as far as obstetric population is concerned, hypovolemic shock due to peripartum hemorrhage remains the commonest cause of shock across the world, followed by cardiogenic. It could mostly due to peripartum cardiomyopathy. There could be concealed cardiac ailments, which are mostly these valvular heart diseases in India due to rheumatic heart diseases. These are becoming less and less reported, but I think peripheral centers, they are concealed and at the advanced stage of pregnancy, they manifest. Distributive shock, septic shock is again common due to peripheral sepsis causes, and obstetric causes are usually diagnosis of exclusions. Pulmonary thromboembolism and amniotic fluid embolism are the commonest one among the other causes. So coming to this obstetric shock and shock in obstetric, these are the 2 broad categories. One is obstetric shock, where it is due to the obstetric causes, attributed to the pregnancy per se. And then shock in obstetrics, because the pregnant lady could be subjected to shock as for any other reasons like traumatic hemorrhages, accidents, and any other medical cause for that matter. So quick close, just clinical examination and history taking are the most important ways of eliciting diagnosis at the first place when the patient's present to the emergency department or critical care unit, apart from before you jump on to do this investigations. So fever, pain, and if you have any respiratory or cardiac issues, like patient is getting breathless with slightest workout, exercise at home, while climbing stairs, etc., it gives very important clue in guessing about the existence of cardiac ailments in these patients before you get to do the advanced imaging, etc. Investigations are the basic ones we require in these patients and presentations, like the complete blood count, organ-specific tests like the renal function test, liver function test. And if your center has this facility of doing these coagulation parameters, etc., you can do. But I would like to emphasize about this importance of blood gas analysis. Post-COVID, we know most of the places have got some kind of ventilator, smaller or bigger ones, and this facility of blood gas analysis. Now, this machine, actually, the company who are the two major companies providers in India, they are happy to give you the machine. Only one has to pay for the reagents. Most of the states, including the poorer states in the northeastern part of the country, have these machines now. And once you do this, it's give you immediate clue about the hemoglobin, the electrolyte status, about the oxygen status and acid-base status, because what you are looking is at the hyperperfusion. Acid-base, balance, bicarb, lactate, these are the two important indicators of your perfusion status, and it gives you some clue as to how you proceed with your resuscitations. And of course, you have higher things like ultrasound, you have POCUS, that is point of care ultrasound, etc. We can proceed. And ECG and 2D echo as required. Now, as peripartum hemorrhage remains the commonest cause, so a multimodality approach remains the key. You have to predict, prepare and handle. If the patient has at risk, obviously these are the antepartum period where you can prepare these patients. And once it has happened, you have to clinically manage. So significant PPH, these are the major causes: uterine atony, difficult grades of placenta, cervicovaginal tears, rupture and coagulopathy. So, multidisciplinary hemorrhage protocol, you have to identify, activate the multi-response team, transfusion protocol, and whatever logistics are possible, within that frame, you have to start resuscitating these patients. And diagnosis is early shock or severity of shock. Patient, once you think that patient has started bleeding, as this happened in our first case, immediately start transfusing fluids in this case, call for help, try to secure the airway or the oxygenation if it is compromised, and ensure hemostasis. So resuscitation and surgical management has to go parallel in these cases. IV fluids, we have already discussed this, and I think most of our obstetric colleagues would be more aware and more proficient about these oxytocin agents, using any of these three agents that you need to do. And you have to hemostasis, as was done in our first case with packing, if required, surgery or embolizations or ligation of the uterine arteries in higher, difficult more cases. And if your center is not triggered up or geared up for these higher kind of surgical interventions, you can stabilize the patients and transfer this patient to the nearest highest center after. And thanks to this today's technological advancement that we have this facility of telemedicine. If you are a smaller center, just stabilize the patient, put the tube, make sure 2 good IV lines. Functional 2 good IV lines are very important along with oxygen for shifting any unstable patients, including this critically ill obstetric patient, to the nearest center. And in between, you can actually just give adequate fluids and shift the patient and the team would be ready there to receive such patients and take it further. Intrauterine balloon tamponade, I think most of our surgical colleagues will be very proficient in doing that. Bilateral uterine compression and external aortic compression. External aortic compression, I think technically is a bit difficult to give, but this balloon tamponade and bilateral manual uterine compression is feasible. And this is something I would like to draw your attention for this anti-shock garments. These are very convenient to use, not expensive. And when you're shifting any such patients to the nearest centers, you can always wrap this patient in this anti-shock garment for at least it pumps around 500 to 600 ml fluid in the intravascular compartment to maintain perfusion till the patient arrives at that center. So how do you define massive transfusion protocol? If you look at literature, at least 4 or 5 kind of definitions are available. I do not worry about thinking it is massive or not massive. A patient is bleeding. Any patient bleeding and going into shock is a critically ill patient. So transfuse these patients as necessary and with your continuous assessment. And you heard the previous section, previous talk about coagulopathies. I'm not going into the details of it, but postpartum hemorrhage or peripartum hemorrhage, going on to further deranged coagulation, actually the important factor among all is the fibrinogen deficiency. So these patients do actually benefit from FFP transfusions and clotting factors like the factor concentrate somebody asked about it. There are 3 factors and 4 factor concentrates available. In the second phase, you can give those factor concentrates when it is available. So what are the targets of resuscitations? MAP of around 60 to 65 millimeters of mercury and hemoglobin between 7 to 9. INR less than 1.5, and fibrinogen, if you are able to measure, otherwise you are just giving FFPs. Platelets more than 50,000, I think we can perform the LSCS, but if a patient has got concomitant traumatic brain injuries, usually, or neuro problems, usually we keep it more than 80,000. And always assess the patient clinically, because we treat the patient and not the reports. Patient, as somebody is stable, is actively not bleeding, if your platelet is 40,000, you need not give platelet transfusion for these cases. This we have already discussed. I would just discuss about this protocol of massive transfusion protocol, where it, most including the trauma protocols, also talk about giving RBC, FFP and platelet in 1:1:1 ratios. I actually differ from that, and I think globally also, even in the resource depleted centers also, this is not feasibility. If you are giving 6 units of PRCs, it's not really necessary to give 6 units of platelets in those cases. So whatever available, after 3 to 4 units of PRC, if you are giving blood, if you have whatever is available, you give for that, go for that. And actually it is not available, not feasible, and wastage of resources or lack of standardizations do exist in many centers. And these are the agents we talked about, this hemostatic or blood replacement strategies, like about this factor concentrates. And tranexamic acid is actually also a very good drug which can be given in these acute situations within the first 48 hours. These are the targets we have already discussed. Problems with massive transfusions do exist, like volume overload, TRALI, that is transfusion-related acute lung injuries, and hyperkalemia, disease transmissions if your bloods are not properly screened. Septic shock, I think since morning we had a couple of sessions on sepsis. I'm not going to do the definitions, but these are actually a worrisome cause of shock in postpartum ladies, especially from the reporting from the peripheral centers. And this is a list of causes, obstetric causes and non-obstetric causes, which actually can cause shock in these patients. And apart from obstetric causes, all other medical diseases like this tropical infections, puerperal sepsis, UTI, pneumonia, etc. can happen in these patients. Only the difference is they are more vulnerable due to the physiological changes in pregnancy. So goals in resuscitations again remain. MAP is around 60 to 65 millimeters of mercury for good for good perfusions, and antibiotics. Urine output is a very good measurement of cardiac output and perfusion in most of the cases. If you do not have the advanced monitors for monitoring blood pressure or perfusion status, urine output per se is a very good indicator, and it is also has been called as cardiac output of a poor patient. Early source control, like the second case that we have, probably if you can go for ultrasound, if there is some collections, intrauterine collections, that can be avoided, and fetal monitoring has to go on parallelly. Now, among fluids, which one you give? In our categories, in our critical care field, actually it is often discussed. So there is consensus is crystalloids are preferred. Any of these, normal saline, Ringer's lactate and balanced salt solutions, they can be given. I'm going to take 5 minutes more. And if you look at the SSG guidelines, I believe some of the lectures covered it. It says up to 30 mils per kg. So any patients presenting with shock, actually just did not give, suppose 70 kg. You do not go for just giving 2.1 liters of fluid. Always go for in small aliquots of fluid, say up to 10 mils per kg. Because the problem unique to our continent is patients get treated in smaller centers, smaller hospitals, where there will be no records. Kuch nahi hua, then the patient can refer to the higher center. So you do not have any data or information about how much fluid the patient has already received in that place. Neither the relatives can tell you. So it is best and safe to give a small aliquots up to 10 mils per kg, assess the patient for perfusion status, including urine, lactate, your ABGs, and go up. Colloids are not preferred, like albumin, hetastarch, or gelatin, etc. are not preferred. Having said that, this 4 or 5% albumin, if a patient is requiring more than 2 to 3 liters of crystalloids, you can go for 1 bottles of this albumin as crystalloids. Adequate IVLins are very important. 2 good running peripheral lines, either it is 16 gauge or 18 gauge, are necessary. And if your patient is in shock, you're requiring administration of vasopressors, then you can go for central line. Then regarding the choice of the site of central line, it is very important. Any patient who is in multi-organ dysfunction, respiratory distress, or tachypnea, do not go for the neck lines or the subclavian line, because that could be concomitant coagulopathy in these patients and it can cause hemorrhage. So femoral line is in situations of emergency is the safest to go, though not the best from the infection control point of view. But after 48 hours to 72 hours of resuscitations, you can switch to a line in a safer place and remove the femoral line in such cases. Vasopressors, I think we had discussed in the sepsis panel that NORAD is the vasopressor of choice. And low doses actually can be started in the peripheral line also. So this is one beauty of this drug, and in the latest addition in our practice, that NORAD, how you prepare? You prepare 2 ampules in 50 ml of normal saline, and you can start it as say 2 ml, 3 ml or 5 ml per hour. So these dose actually can go through the peripheral line. But if you're exceeding that, it is better always to switch for a central line or at least an external jugular line, EJV line in such patients. Ephedrine is a drug, safe drug, which can be used to buy some time, because sometimes placing a central line actually takes time. You need expertise. So this can be given in small boluses to buy time to build up the blood pressure. Vasopressin is the second vasopressor of choice. Cardiogenic shock, peripartum cardiomyopathy can happen up to 6 months. Usually it starts unfolding in the second or third trimester, up to 6 months. Any heart failure, this remains as a differential diagnosis. And of course, there are occult vascular, valvular heart diseases, etc. that can manifest, decompensate and manifest. POCUS, point of care ultrasound, is very useful in these patients. Along with the cardiac problems, also it can tell you about the lung status. So you can actually manage your fluids, and any other correctable causes also can be identified along with the valve situations or the blood flow across these valves. So all these kinds of shock, ABC of resuscitation matters, cardiorespiratory support in terms of ventilations and fluid and vasopressors should apply, and non-invasive ventilations, invasive ventilations should be instituted as soon as possible. And always in pregnant patients, airway remains an unanticipated difficult airway. So always call for help if you think a patient is near decompensating and is going to require airway management in such cases. Obstetric shocks are rare. However, having said that, these are usually diagnosis of exclusion. So this is the last case, and I will conclude after 3-4 slides. This is a 33-year-old nulliparous patient. And she's 34 weeks pregnant now, come to the hospital, now presented with severe headache, nausea. Blood pressure is 150/98. Fetal movement present but reduced. Ultrasound shows less LICA, and there's a live fetus. So what drugs will you use to control blood pressure? So no doubt this patient has got preeclampsia, mostly going towards now severe preeclampsia. Which drug will you give? Role of magnesium and how much doses, etc. That we'll discuss. So I think all of us, these are all available in all the literature and books. I'm not going into the details of this. More than 140 systolic, more than 90 diastolic, and proteinuria is very important. And I think it is very repeatedly emphasized in OPS guidelines across the world. And preeclampsia, there are a lot of, it can affect any organ from head to toe. It can affect any organ. But in preeclampsia, neurological symptoms are usually predominant. Our patient had got severe headache, very ominous sign in such patients. And also they get right upper quadrant pain or epigastric pain, which is also an imminent ominous sign in such cases. So these are the spectrum of different hypertensive disorders. I'm not going to the details. So emergency management remains ABC of resuscitations. Seizures happen, we have to control the seizures. Benzodiazepines and thiopentone, you heard the lecture. And also injection magnesium sulfate. 1 to 4 grams per hour. This is something in an area of concerns because many of the peripheral centers, they just give IM magnesium sulfate, no monitoring of the levels. And we have reports of patients who have actually arrested due to magnesium toxicity. So along with the blood pressure management, airway protection is necessary. Always call for help in such patients. Because of this mucosal edema, due to the tongue enlargement, epiglottis is large and patient positioning is difficult. Termination is pregnancy is the answer in such cases. Anesthetic planning is also challenging because this patient might have some concomitant coagulation abnormality. Take a high risk, go for this termination of pregnancy because without that, the lady is not going to survive. And of course, you have to have a neonatologist backup as well. HELP syndrome is again another subset of this severe preeclampsia. Acute fatty liver of pregnancy, not so common. I think again it becomes one of the diagnosis of exclusion. Homozygous presence of one of these enzyme deficiency is actually the cause. Multiple gestations, preeclampsia may be associated, male babies, and nulliparity are the challenges. The issue is clinical overlap. Most of the last 3-4 diseases or the conditions that we mentioned, they might have clinical overlap. Nevertheless, ABC of resuscitation remains same, and they might have multi-system involvements. With the termination of pregnancy, if it is due to the obstetric cause, all this tend to settle. So remain aggressive because the outcome is very rewarding in such cases. Along with other tropical fevers, hepatitis A and E are common in these populations. Diabetic emergencies with increasing age of conceptions and lifestyle changes, we see more of these cases. However, management remains same as in cases of other non-obstetric populations, and termination of pregnancy if the patient is close to the term and fetus is viable. Amniotic fluid embolism, usually we find it after vaginal deliveries. After cesarean section, it is not so common. So again, the diagnosis of exclusions. Respiratory failure can happen again as a part of this obstetric causes multi-organ syndrome or due to the pneumonias. In COVID ARDS, we had actually done, I had done a retrospective analysis of pregnant women who were admitted to ICU with COVID-19 infections, PrEP-COV study, which we completed successfully with 207 cases, and maternal mortality was very high. This is published in IJCCM 2023. Maternal cardiac arrest, last two slides. It's a very special situations. What we need to do, I'm not going into the details, but left uterine displacement remains the key, so that IVC is free of pressures, keep wedge with tilt, and IV lines are preferably to be kept or to be used after above the diaphragm levels. CPR protocol remains same with your chest compression 30:2 ratios, and consider peripartum cesarean section as appropriate. I think we have wonderful stories, and I think one of the Dr. Chetna Raman from Ramkrishna had recently performed a peripartum cesarean section, and they could have saved a life. So I was very glad to hear that story. Within 4 minutes is the line, is the time limit where you have to deliver the baby. And the good part is for this peripartum section, in a pregnant lady who was arrested, you did not get any consent. So there is no medical legal limitations or problems in performing peripartum cesarean section in such cases that we have already discussed. And about this early delivery of baby, there are some questions. Sometimes people are worried about, families are worried about early delivery of this babies in these cases. But if the problem is due to an obstetric cause, baby has to be delivered. Other than that, the mother's life cannot be saved. But if it is due to the medical causes like ARDS, malaria, tropical infection, etc., then probably it may not be helpful in such cases. So this is the key point summarizing. Anticipating, you have to act fast, stick to the basics of resuscitations, ABC. I think be it life or clinical science, always common things are common and uncommon things are uncommon. So stick to basics, and it actually helps you saving more lives than not. Hypovolemic shock remains the commonest form of shock in pregnancy. IV lines are very important for emergency critical care physicians or for any doctor caring for such a patient in emergency period. Massive transfusion protocol, keep in mind, but whatever you get, you give it. You do not have to give always 1:1 ratios. And hypertensive disorders of pregnancy, they are the ones who should be referred early for safe confinement. And with slightest problem, if you do not have provisions, try to refer it to the nearest best center with help of the telemedicine. And multidisciplinary teen approach is always necessary. Again, telemedicine helps. If you do not have a neonatologist, you need not worry. You can always take help from your nearest centers. So with that, I conclude, and I would welcome you all for this Criticare 2026, our annual signatory event of Indian Society of Critical Care Medicine. And this is the obstetric critical care workshop, which we have been holding for last 4 years now. I'm the national lead for that, and I'm also happy to share that we have a 6-month obstetric critical care fellowship course, which ICCM has started since 2023, and this is a textbook. Thank you very much for your patient listening.
A very nice presentation indeed, and you have rightly also included a number of the cases which are there in the routine practices, and very nicely explained what to do and how best we can do. And I'm glad to say that the government is also taking an initiative in this factor and has decided to open up more of the HDU and ICU in the medical colleges and the district hospital, with 4-bedded ICU and 4-bedded HDU, minimum 8-bedded HDU in medical colleges. So that is how we are trying to improve the maternal outcome in the pregnancy. And they are also planning for training others, and there are a large number of the training courses that are also being run so that we can improve. You have rightly said that there are a large number of the maternal mortality, and actually they do occur in the peripartum phase only.
Right.
So it's very nice presentation from you.
Thank you,
so much.
ma'am. I think continuous education is training is the only way forward to increase the things.
Yeah, Dr. Sharmili Sinha, you elaborated many of the obstetric emergency in a very nice way. There's one thing, we are getting lots of cases of AFLP nowadays and associated very high mortality despite of doing lots of effort. I just want to know your experience with AFLP and if you can suggest some early intervention which can be helpful in saving the lives.
Yeah, I think AFLP, as you said, I mean, you probably have seen more than us. And these patients do not present to us. Actually, as you said, the mortality is very high. One of the problem with these patients who have got present in the critical condition is the clinical overlap. There are at least 4 or 5 conditions like severe eclampsia with multi-organ dysfunctions, with multi-organ affection, again eclampsia with multi-organ affections. Nowadays, we get many of these tropical infections also, like dengue or hepatitis E, etc. In the advanced stage, they present. And when that patient has already presented with us with multi-organ dysfunction, with severe jaundice, I think those are the cases where you feel you cannot actually pinpoint a diagnosis. It becomes a diagnosis of exclusion. Having said that, actually, I think the onus remains on the patient and the doctor she is visiting. If the jaundice is rising and the patient is becoming rapidly sick, I think that is the point before your vital functions have deteriorated. Vital means mostly the blood pressure and the breathing functions. These patients, due to the physiological changes in pregnancy, they have very low reserves, especially the respiratory and the cardiac factors. So if they are breathing and the blood pressure is starting getting disturbed, those are the points they should be immediately shifted to a higher center where there is critical care facilities there and immediately deliver the baby. But if patient remain like many times the tachypnea in pregnancy is considered normal because they do have elevated respiratory rate at baseline. But tachypnea and respiratory distress are different. In respiratory distress, you have flaring of the alanazi, you have working, the sternocleidomastosis are working, there is a chest recession. But tachypnea, you do not have that. So these are the few clinical examination when you're talking to patients or examining a patient, or you see discerning an important decline in the clinical condition of the patient. Whenever they're awake and talking to you, that's the point, early referral. I would say that is the most important case. And you rightly, actually, you reminded me of a case. She was a lady magistrate. She had late pregnancy. And she came to us again in an advanced condition. She was not feeling well. Despite being educated to that level, she kept at home. She remained at home for 4 days. And on 5th day, when she came to us, she was in shock and multi-organ failure. But she had a disproportionate jaundice, disproportionate hepatic failure, which made us think that it is most likely an AFLP. She also tested positive for dengue. So I don't know, we do not know what is the predominant cause. But again, dengue having a predominant hepatic component is rare. I mean, it's usually multi-organ. So that could have been this homozygous homozygous deficiency of this enzyme is actually responsible for AFLP. So that could be there. So I would say that clinical examination, when the patient presents, disproportionate rise in jaundice compared to blood pressure or any other or other organ functions, patient just should be referred early and termination of pregnancy. I think 24 weeks of pregnancy you are accepting.
24.
With a good center, baby can survive. So termination of pregnancy if it is from the obstetric cause. Thank you.
Thank you, Dr. Sharmili. It was an excellent talk, and you have very rightly said that early diagnosis and aggressive management with coordinated multidisciplinary approach will definitely save many of our mothers, and as well as the baby's outcome will be improved.
Thank you, ma'am. I think obstetricians have a very important role to play, and that's why we are happy to invite you for this obstetric critical care workshop.
Yeah.
And to join the courses if possible online.
I'd like
Thank
to
you.
thank
madam.
Dr. Sandeep Dave sir, and also organizing team chairpersons like Dr. Abbas Naqvi, Rahman sir, Rakesh Gupta sir, and my dear friend Chetna Ramani for inviting and involving we obstetricians in this Criticon.
Thank you, ma'am.
Thank you, ma'am. Pleasure.
Thank you so much.
I request our chairpersons. Please felicitate our speaker with the memento. And I request our chairpersons, please collect their mementos from the memento podium. I request Dr. Chetna, please give mementos to our chairpersons at memento podium. Now we move to the next session.
May I just make a simple request to all of you. Today, during the inaugural function, we are going to honor few of our doctors across the state, and for that ceremony I request each and every one to be present inside the hall so that they get what they deserve. So I'll be highly obliged that if the hall is 100%, more than 100% full during the inaugural ceremony. Thank you.
Thank you. I request our chairpersons for the next session, Dr. Mahesh Sinha sir, Dr. Rahul Pathak, Dr. Kaisar Salim sir, Dr. Arpit Agrawal, and Dr. Umesh.
The next topic on end-of-life care shall be presented by Dr. Roop Gursani, sir. He's a clinical neurologist at PD Hinduja Hospital, Mumbai, with special interest in epilepsy and neuropalliative care. He's a member of End-of-Life Care in India Task Force, LSET, and Forum for Indian Neurological Education. Over to you, sir.
Right. Thank you, organizers, for inviting me here. I have one disclosure. I'm neither an intensivist nor a palliative care physician, just a clinician with about 38 years of experience. And I'm going to speak to you about the responsibilities of the physician intensivist in prognosticating, diagnosing dying, and managing the process, and also to understand how end-of-life care is getting institutionalized in India. The story actually begins with the use of morphine for cancer pain by this remarkable lady by the name of Cicely Saunders. And as she went along, she realized that there was more to it than just physical pain. And by the 1990s, palliative care had moved beyond cancer. Simultaneously, in the US, it was a different approach, and that was based on patient autonomy and human rights, with patients taking charge of their own last days and securing doctors from litigation. It spread politically, and eventually we realized that what was required was a conversation. Indian Supreme Court judgments, the first was before 2000, but the main judgments came after 2011, and that is when I was involved in the Aruna Shanbag case. And some time after that, we also realized that Indians die badly. If you look at these red arrows, the one at the bottom on the left side is India, towards the bottom of Group D. And if you look there, the UK is right at the top, partly because of the Saunders story. But below that are Sri Lanka and Mongolia. They're not much richer than us. And they are much, much better. In 2015, the three National Medical Associations of Neurology, Critical Care Medicine, and Palliative Care came together. And we had a bit of luck. In 2018, a court case that had been winding its way through the Supreme Court finally came to judgment, which actually gave a full standing to the constitutional right to healthcare autonomy, which means that if you choose not to be treated, that is your right. Unfortunately, that judgment put the judicial magistrate first class in charge of this whole process, and really nothing moved. Although we did have some work done, but it was only in 2023, after the pandemic, when the Supreme Court removed that requirement, that things began to move. Some of you may be aware of the guidelines that were published last year by the ISCCM and the IAPC together. And if you have not read that, you should. But I'd like to take you to a slightly wider thought. And that is that when you look at this whole field, it begins with constitutional morality and ethics. And based on our constitution, our Supreme Court judges have enunciated the principles that underlie this. Together with that, public awareness is rising, guidelines and policies are in place, but there are two black holes. One is that we do not have laws, and laws are important because they say, thou shalt not, on pain of. Without laws, nothing moves. And practice has not evolved, and that is our own fault. Some of you may be aware that palliative care is much more than end-of-life care. It is applicable to all serious health-related suffering, and that's now understood. When we talk of end-of-life care, we are talking of the last 6 to 12 months of life. Terminal care is when it is down to weeks, and active dying is an irreversible process. Palliative care is involved throughout. Some definitions to note. One especially is very important, and that is terminal illness. It's a state from which recovery cannot be expected with currently available treatments, and death is considered to be unavoidable in the foreseeable future. You may say that this is a pretty inexact definition, but it's the best we can do. But regardless of that, you do have the responsibility of prognosticating. Some of it you can influence from within the ICU with organ support, monitoring, infection control, reversing reversible organ dysfunction, and short-term physiological rescue. But before the ICU, it's the patient age, comorbidities, frailty, and functional status that determine the state they reach you. If there is an irreversible trajectory, and if there are long-term biological limits, then there is a limit to what we can do. It's important for all of us to understand how we as humans die. Remember that after the age of 50, less than 10% of people die suddenly. It takes a lot of punya to get the kind of death that our long-haired president got. At the age of 84, lecturing, gone. Typically, about 20% of people will die of cancer, and in cancer, at some point, the tumor burden takes over all biological decision making, and the decline is extremely predictable. Organ failure has a looping trajectory. People cycle in and out of crisis. Eventually, they die. Of course, old age frailty is going to affect more than 50% of us. And here, the trajectory is long and winding. We also do have catastrophic brain injury or critical illness, which accounts for less than 5%, but which dominates our thinking, where people survive, but not too well. The point to note is that 90% of all deaths can be predicted weeks to months before they occur. Cancer is probably the best predictable, but in the others also, some amount of recognition of terminal illness is possible. These are 4 triggers that have been identified in palliative care. The first is the surprise question, and this is an intuitive response to this basic question. Would you be surprised if this patient were to die in the next year? And oncologists can get it as much as 80 to 90% of the time. And most of us, provided we start opening our third eye or Shiv, can also get fairly high. But what we do need to pay systematic attention to is general indicators decline, where you look at activities of daily living, and then specific clinical indicators related to illnesses. But there is one more factor that is important, and that is decisional. When you decide that no more, that too decides when people will pass on. I usually pay attention to activities of daily living, and if you ask your patients, ask your families what your patient was doing before they entered the ICU, that gives you a fairly good idea of how far down they were. So often people say that somebody was well, and then you find out that they needed help to get to the toilet, they were often incontinent, somebody was occasionally feeding them, and so on. So loss of basic activities of daily living tells you that somebody is quite far gone. Regardless of all of this, we must also differentiate between the more predictable and the less predictable deaths. Cancer has a defined trajectory and it is very predictable. Neurologic, non-oncologic deaths tend to have erratic, prolonged trajectories. Admissions may be unavoidable. In fact, in my own field, in dementia, people lose control of their minds. And for all of us, it is important for us to learn to communicate for end-of-life care. You need comm skills training because otherwise you'll struggle. And there are 3 things that we pay attention to. First is goals of care. Now, goals of care is something that we do all through medicine. Remember that whether you're treating a simple sardi or a chest infection or sepsis at the end of life, you have 3 basic targets: maintaining functionality, ensuring survival, and avoiding suffering. In minor illnesses, all three are possible. At the end of life, you may have to choose one and only one. As you go through goals of care, it's important to talk to the patient and family about advanced care planning. Here you need them to designate a healthcare representative who will speak for them, make their living will, but ideally it needs a system for implementation. If you do this right, then shared decision making becomes possible, where patient and clinician inputs allow us to make in the moment decision. But we don't do this well at all. These are self-perceived barriers to competence. And one of the first is that it is stressful. It is stressful. It reduces with training. People say that it is time consuming. That I do not agree with at all. In fact, most of these intensive conversations, structured well, can be done in 15 minutes. Honesty does not destroy hope. We can identify signposts of decline. Patients and families are willing to discuss uncertainty because it allows hope. And accepting reality, in fact, allows us to work with patients and families at the last. The reason, the outcome of our failure to communicate is the loss of our prognostic function. As long back as Hippocrates, prognosis was recognized as consisting of foreseeing and telling. If you do not commit to foretelling, your foresight will inevitably atrophy. And this is important because end of life choices that can be decided in advance include the preferred place of care and or death. No intensivist I know wants to die in his own ICU. Life-saving treatments that only provide prolonged dying and can be refused. This includes IV fluids and medications, of course. Tube feeding is life-saving treatment. Dialysis, ventilator, chemotherapy, all of us understand. And CPR, we should all recognize how poorly it performs in sick or dying patients. You can put all of this together under the advanced care planning umbrella, which consists of all these various instruments which can all be made. The thing is, managing dying is not considered an intensivist job. But if you have to do it, you have to know how to do it well. High quality end of life care consists of one, identification of goals of care. We've spoken about that. We'll do it a little further. Comfort care, where you tackle pain, dyspnea, agitation. But more importantly, you discontinue unnecessary procedures. Two things to knock off are suction and unnecessary blood draws. Family support is important through the meeting. Spiritual and emotional support is important. We don't have chaplaincy, but counseling is possible. And you can manage emotions. And you must have ethical clarity about what you're doing. So I think conducting a family meeting for end-of-life care is part of the core competence for intensivists. This schema is based on something called the Spikes protocol. You may be aware of that. You must set the stage by confirming that the appropriate surrogates are there, and the hierarchy starts with the spouse, not the parents. Remember that. Ideally, the patient should have designated a healthcare representative. Your team should be aligned with a lead identified. You must have all your reports handy, and you must make sure that your body language is not out of sync. Then you find out what they do know, what they want to know, give them a warning shot that bad news is coming up. Ideally, you confirm whether the patient had made any wishes known, and then you communicate prognosis. For that, we have a system called the best case, worst case scenario, and we avoid giving numerical percentages unless they insist. Then emotions have to be tackled, validated by this mnemonic: name, understand, respect, support, and explore. But you end with two important outcomes. One is a time-limited trial where you define an intervention, put together the duration, the outcomes that you want, or move towards foregoing life support, which means you move on to comfort plans. But whatever you do, you need to confirm to the family that you will not abandon them. 3 rules: appropriate body language. The second, learn the power of silence. And in this meeting, speak less than 50% of the time. And we use a technique called ask, tell, ask. Ask the question, give them information, ask again, and do this again and again. When I do this, I usually split it up into one quick meeting outside the ICU at the first round, which usually doesn't take too much time, because I tell them I'm going to speak to them in detail in a sit-down meeting, latest by day 5, ideally by day 3. And with that, you actually go on to identifying when people are dying. This is essentially a clinical diagnosis. The first phase, months to weeks before that, we call it pre-active dying, is physical and psychosocial withdrawal. These phases are best identified in cancer because, as you remember, the trajectory is really well defined. In the weeks to days before death, active dying begins, and this is marked by CNS decline, the appearance of encephalopathy and delirium, and imminent death is marked by deteriorating vital signs. And you will notice all of these. For me, probably the one marker that I always look out for is gasping. I have never yet seen a patient who's gasping survive beyond about 48 hours. Families are bothered by these end-of-life symptoms, and there are basic principles that we must follow. You have to alleviate pain, dyspnea, agitation, avoid over-sedation, use symptom-based titration protocols, use bolus doses, and you monitor breathing patterns, facial relaxation. I think I'll take a couple of minutes. And absence of grimacing as comfort indicators. Use the principle of proportionality. So increase medication only to the level required for symptom relief. Remember that opioid or benzodiazepine use, increasing it does not shorten survival. There are drug choices and schedules available. This is a paper from the American Academy of Critical Care Medicine that came out some time ago, and you will find this pretty useful. I won't go too much into this. As far as foregoing life support is concerned, that is a clear ethical basis to it. Autonomy, beneficence, non-maleficence, all important, because prolonging suffering with futile treatments, treatments that cause more harms than benefit, are all important to stop. And when you have limited beds, it's also important to manage resource care. Withholding and withdrawing are not different at all. Both allow natural death, and sometimes we follow the doctrine of double effect, where in giving relief, one side effect may be death. I won't go into the details of identification of futility. Futility in medicine can be complex, and you've seen from the other lectures that you have multiple situations in futility appearing. But remember, imminent demise or lethal condition futility means you really can do nothing. But futility in neurology is a whole different ballgame, because it becomes a question, much more than anything else, of prognostication and ethics. And you have to decide if this is no longer a life worth living. How do you judge this? When is this decided? Who decides? How do we proceed? That's a whole different lecture, and I'm going to skip it. What about the due process for foregoing life support therapy? In India today, we know that we have a two-step process. The first step is the identification of futility by the primary team, which must consist of at least 3 clinicians, including the primary physicians. Once they decide that this is futile, they communicate with the family. If the family and the primary team are both on the same page, then a secondary board, which is to be constituted by the hospital, should include one government-nominated doctor, will then take the final call. As of now, except for Karnataka, no state has taken the steps to make the secondary medical board happen. So ideally, this should be done by standard operating procedures within the hospitals itself. And then you go ahead and implement withdrawal. But I'd like to point you to one more thing. And that is that the Ministry of Health and Family Welfare put out these guidelines about who should be admitted or not be admitted and who should be discharged from ICUs. You can look this up on the net, just to point out that they are available on the website. And the Supreme Court is now beginning to get into the act. So many of my colleagues believe that playing safe, DAMA and so on will protect them from litigation. No. In the US, the bulk of the litigation is for wrongful life. When somebody is resuscitated against their expressed wishes, hospitals end up paying millions. Remember that poor end-of-life care is one of the major causes of systemic distrust of the medical profession in India. Now we have no excuses for not addressing this issue. And if we don't do this, I hope you're not a VIP. Atal Bihari Vajpayee died after 2 weeks in the ICU. In the same year, George and Barbara Bush died in Darbar in their own homes, comfortably. They sailed off to heaven. Lata Mangeshkar, those incomparable vocal cords were raped not once but twice. So my rule is that if you're an Indian VIP, you're condemned to torture before death. Let's hope we don't end up as VIPs. Thank you.
Thank you, sir.
Hello. A very tough and very difficult situations which are to be taken. Me being the pediatrician, and I've been practicing the pediatrics for the last 45 years. Very many times we have the newborns who are severely asphyxiated, or the very extreme premature babies. Now the situation comes, if we revive the child, children, they are most probably going to have a very miserable life. So do we have some ethical criteria for these things? And the second point is, in some sects, for example, जो संत लोग होते हैं और अपनी लाइफ एंड कर लेते हैं, उनके रिचुअल्स होते हैं कि उनको पहले रिचुअल्स करते हैं, पूजा करते हैं, उसके बाद उनको एक कॉफिन में वो करके
समाधि,
दे लेट दी गाय टू एंड हिज लाइफ. इसके बारे में आपको क्या कहना है?
These are two full day conferences. It's not easy to give a short answer, but pediatric palliative care is evolving very rapidly. And I suggest that as and when there's an opportunity, you look at the amount of discussion that is already happening. These decisions are difficult, but they can be taken. And they can be taken in such a way that everybody is left comfortable at the end of it. The other one is about samadhis and so on. India is a vastly diverse country. At one level, we prevent people from being pulled off the ventilator, and at the other, you have people going into samadhi. How do we make laws that cover everything?
Thank you, sir. Thank you for your nice deliberation. I request our chairperson, please give a memento to our speaker.
Nice deliberation.
I request our chairpersons, please collect their mementos from the memento podium.
There are a couple of changes. So for the next talk, we are inviting Professor Dr. Suresh Advani sir, who is a chief guest, and he is going to deliver his keynote address to the August gathering. To chair this session, may I request Dr. Vivek Chaudhary sir, Dean, GMC Raipur, to take the chair. Dr. Bhavna Siroi ma'am, Balco Medical Center. Dr. Yusuf Memon sir, Senior Surgical Oncologist, Sanjeevani CBCC Cancer Hospital. Dr. Ashutosh Gupta sir, Senior Surgical Oncologist, Government Medical College, Raipur. Dr. P.U. Saxena sir, Consultant Radiation Oncologist. Dr. Manjula Bek ma'am, Professor, Radiation Oncology, GMC, Raipur. Dr. Suresh Advani sir needs no introduction. He has 6 decades of experience practicing and he's a consultant medical oncologist currently practicing at various hospitals in Mumbai and Sushruth Hospital. Sir had 30 years of experience as a head at TMC Mumbai. Sir is the first person to do bone marrow transplant in Mumbai. Sir is a recipient of Padma Shri. Sir is a recipient of Padma Bhushan and many, many awards. And to his credit, are lakhs and lakhs of patients who he tells only one word that he delivers them: hope. May I request all of you to give a standing ovation to Professor Advani sir. It's indeed a matter of pride that he has taken flight 6 a.m. in the morning where he had option to choose a flight 3 o'clock so that he can meet all of you, listen to all of you. So over to Chairperson Vivek Chaudhary sir to take the session forward.
Sir, very good evening. In 90s, 92, 93, I was your student. And today I'm having the same feeling after being Dean Medical College. I'm still your student and I will be your student. What you taught, really marvelous. When I was in Tata Memorial, the principles and teaching take-home messages you have given is still with me. Really, we are treating around 3 to 4 lakh patients per day, per month, per year. Really, is because of you. All credit goes to you. Thank you, sir. Sir, welcome to my city, Raipur, sir.
Hello. Respected Chairperson and colleagues. First of all, I would like to thank the organizers for giving me this opportunity to visit Raipur, a new Raipur, I must say that, because I have visited here 15 years ago, and now I can see a total change in 15 years. And that's really a great leap forward. When I received the invitation, I was wondering why critical care needs an oncologist. That was a big decision for me, that what shall I talk? The oncology is a huge subject and I have to give a talk in 20 minutes, which will be useful for everybody gathered here. And then I thought that intensivists and the oncologists meet very often, particularly in ICU. We all are, if I go for the round, 30-40% of my patients are in ICU. That's a criteria. Because in wards and all, we hardly keep the patients. Most of the patient receive the treatment as an outpatient. So if the patient is admitted, mostly he needs the intensive care in the intensive care unit. So I thought that there is an association, and what is this association is not at the personal level. There's nothing personal about it, but it's the level of sales. Ultimately, what the oncologist is doing, oncologist today is doing so many things, killing the tumor cells, stimulating the immune cells, and all of them are responsible for controlling the disease through some sort of inflammation or anti-inflammatory treatment. That's how the oncology today is working. I will come to it little later on. Same way is true also for all of you in the intensive care, that how you are looking at the intensive care management. All of us know that how people develop the bilateral extensive pneumonia, which may not be pneumonia, but it may be the what we used to call it respiratory distress syndrome, which may not be really infection. And the treatment for that remains even today. Of course, the antibiotics, but also the anti-inflammatory approach, which has rapidly developed in last few years. So I think with this thing in mind, I thought that I will today show you how the oncology is changing. As I told you, Raipur has changed in 15 years. So is the oncology. Change in 50 years, 50. I am in practice in oncology since 1974. And now it's 25. And I have really seen the paradigm shift in the not only in cancer treatment, but understanding of the cancer as well. So what used to happen in olden days? We had few drugs, we'll use those drugs, and we knew that those drugs will affect the tumor cell, but will also affect the normal cells. And both of them will be destroyed. Maybe cancer cells more, and tumor cells more, and normal cell less. So this was what was happening those days. That means you drop the atomic bomb in Hiroshima, everybody died. And so that was the warfare in those days. Today it's no more like that. Trump ordered the killing of the people in Iran, and they went and killed those people alone. How did they achieve that? It's all changing paradigm. That how the missile went and killed only the selected people. So I think that is what is really happening in the cancer. Up till now, we had three areas: surgery, the chemotherapy, and radiotherapy. All were killing the many normal cells as well. The concept was surgery, white surgery. That was the best surgeon is the one who does a very white surgery. Radiation, white radiotherapy. And similarly, the chemotherapy was, of course, killing the normal and abnormal cells, giving rise to the side effects. But what really changed is today is with the introduction of what we call it targeted therapy. You target the area where you are interested and eliminate the tumor cell alone. And that is what has really changed in many diseases, the outlook. Similarly, we have a immunotherapy. It's a big buzzword today. Immunotherapy is becoming very common. How does it act? It does not act on the tumor cells at all. It acts on the immune cells, and that too only the T cells. Remember that, how selective it is. And then it brings the T cells in close contact with the tumor cells and eliminate only the tumor cells. So that's why how the things have changed, that it has become more personalized and individualistic approach, which is happening. So also in olden days, how the drugs were discovered by serendipity. Some little observation, how they observed the nitrogen mustard when it was exposed to the enemies, the animals over there developed the lymphopenia. And then the nitrogen mustard came into the use for lymphoma by just this observation. That's how the disease treatment was developed in olden days. So you can see that in olden days, how drug used to be developed. Because that time we knew only DNA, double helical molecule. All of us knew as a student that what is DNA, double helical molecule. So you destroy the DNA, the tumor will be killed. But what will happen to the normal cells? They will also be killed. And that's what used to happen. We had all the drugs which act on the DNA. Multiple drugs were there, but they were non-selective. They used to produce lot of side effects. But in spite of this lot of side effects, we achieved success. In 1974, when I started, there were many diseases which were incurable. But with the concept of chemotherapy, combination, adjuvant, neoadjuvant and high dose chemotherapy with rescue, we achieved or cured so many diseases. For last 30 years, Hodgkin disease remains curable. The acute lymphoblastic leukemia, 80% of them get cured. Osteogenic sarcoma, the most curable disease. And Wilms tumor, Ewing sarcoma, and germ cell tumor. So you can see that how the history of oncology really changed. And this is just the protocol for the acute lymphoblastic leukemia. The previously the survival was so low, and today, of course, the survival rapidly improved. But then came the paradigm shift, and this shift was basically change the life history. All of you must be remembering we used to see a lot of chronic myeloid leukemia. And this chronic myeloid leukemia, everybody used to die in 3 years. Today, they are living beyond 25 years and more or less cured. How did this occur? This happened because of the fact that we realized that there's a definite change in the chromosome. There was a balance translocation, number 9 and 22. That gave to the production of the new DNA or new gene, which was the BCR-able gene. And that produced a new protein, the BCR-able protein. And that led to the proliferation of the leukocytes. And you can see over here that how the new protein produced or got phosphorylated by changing the ATP and producing the ultimately CML. So what we have to do is to block this cancer VCR able, and that was blocked by a tablet, simple tablet called Gleevec, and that produced a revolution. One tablet a day, and it has cured the chronic myeloid leukemia. That means the life history of chronic myeloid leukemia has changed. And look at the survival. Today is almost more than 90% beyond 20 years survival. So it is this target therapy which has made a big difference in terms of the not only achieving the better cure, but also less side effects. And in one of the disease, lung cancer, I remember the days people used to be diagnosed with a lung cancer and they used to go back home because the survival was poor. Today, the survival has changed. Why it has changed? Because we have identified the various genes inside the tumor of the lung cancer. And for each gene which is mutated, we have a drug which can eliminate the abnormal gene protein. And that is what really happened in so many genes which are. So today, a lung cancer is treated, not many of lung cancer are treated not by chemotherapy, but by target therapy, which are tablets. I could not imagine 40 years ago that we'll be treating some of the lung cancer with a tablet alone, without chemotherapy. But that is what has happened today. EGFR mutation. We have a wonderful drug, and that can produce the long-term survival. Look at the X-ray before and the X-ray afterwards, that how it has changed. Look at the whole metastatic disease, how it improves within 4 to 6 months. Rapid resolution and the improvement in the survival. So all these things have happened. Again, ALK gene. ALK gene, today the survival in lung cancer with ALK mutation is more than 5 years. So you can imagine what a change that we have seen. Look at the whole metastatic disease and changing in just about 4 months. So it's a tremendous sort of various genes for which we have the tablet, and we can achieve the better cure in this. And the survival has improved. Now, what I would like to do at this stage is to shift back to the immunotherapy. And I think that is something which is really happening just now. What is this immunotherapy? The immunity is all but T cells as far as the cancer is concerned. All of us know that many of us probably have the cancer cells, and our own body, T cells, destroy those few cancer cells. But something happens that the T cells cannot kill those few cells, and then it develops the full-fledged cancer. That is a hypothesis on which we have to think. So it's all T cells. And what does the immunotherapy does? It empowers the immune system to detect. That's a word which is to be, it's not only that it destroys, but first part is it detects the cancer cells and then it selectively destroy. I think this wording is very important when we are talking about immunotherapy. Now, what is immunotherapy? To what it reacts? It reacts against the abnormal gene. Most of the tumor cells have the abnormal gene. So the abnormal gene, what does it do? Abnormal DNA, it produces the abnormal messenger RNA and it produces the abnormal protein. So the protein is expressed on the tumor cell surface. So you have a neoantigen, foreign antigen on the tumor cells. So T cells should be able to recognize and kill them. So immune system, how does it work? If you understand that, you will be able to understand a lot of things, not only about the cancer, but about the infection and inflammation as well. I think the neoantigen, which is expressed, it is recognized, and then the T cells are activated. And once the T cell is activated, it undergoes further activation. But that only activation is not enough. In the body, if the T cells are activated and they are not inhibited, they will produce the autoimmune disorder. And therefore, the nature has given inhibitory mechanism for deactivation of the T cells. They always get deactivated. And here you can see that how the T cells get deactivated by the protein on the T cells. We call it PDL1 and also the CTL4. These are the two proteins. We call it checkpoint inhibitors. And these cells, they are inhibitors. So in immunotherapy, what do we do? Very simple. We remove the inhibitor. You remove the inhibitor, T cells will go on getting activated. It will go on getting activated and go on killing the tumor cells till you achieve the zero kill. So, theoretically, the immunotherapy can produce the zero kill and therefore even cure. And some of our patients of lung cancer and many other diseases are getting cured now, which cure word we never used to use for the lung cancer. But now we are trying to use that words because we are getting the cure. So that is what really happens. Now when the T cells get activated, what does it do? Yeah. I think T cells, when they get activated, what does it do? It activated T cells goes and attaches to the cancer cells and produce the perforin and granzyme. And these granzyme and perforin produce the pores on the tumor cell surface and the cells die. And during this process, it produces the cytokines. And it is these cytokines which are dangerous. So in all our immunotherapy, our major problem is production of the cytokine, and therefore we call it cytokine storm. That is one of the major side effects of the immunotherapy, that when you kill too many tumor cells by the immune mechanism, you produce the cytokines also in a large amount, and that goes and produces the shock. Same thing happens even with the bacterial infection. So previous speakers were talking about the bacterial infection, septicemia, producing septic shock. Is all based on that mechanism. That it is the cells are dying, and when they are dying, and the T cells are active, they produce the cytokines, and cytokine produces the shock. And that's why a lot of drugs are being developed which are anti-shock drugs, but they are not really anti-shock. They are anti-cytokines drugs which are being used to correct the shocks. So I think, colleagues, what I have given you in last 25 minutes or so, a bird's eye view as to how the science is changing, how the science is giving us a good insight into the disease, and it is giving us the mechanism of action of the various drugs which are being developed. So today, the drugs are not developed by serendipity. They are being developed by understanding the mechanism of the disease and also developing the specific drugs to correct that defect and allow the body to become normal and eliminate the abnormal cells. Thank you very much.
Thank you very much. A very difficult topic covered in a very simple way. So if anyone is having any doubt, they can ask, sir. If no, then we are already running short of time. So, sir.
What makes you going? Why there is so much of fire in your belly still? What should we learn on that regard?
Well, I think the way I have seen the oncology, not only oncology, that's a subject, science. All of us are reading the science and we are becoming better. But the patient's outlook has changed. Today, the patients have got lot more chance to live with good quality of life, to get cured. And the way they come and talk to you is phenomenal. Some of my patients I have seen, they come and tell me that, well, doctor, you have treated my grandfather. He got very well. He lived a good quality of life for 3 years. You treated my father also, and he also got a good life for almost 10 years. And now you are treating me, and I want to live for 20 years. So that is what really gives you the...
That's the reason of the kick you get at this age, I suppose. Thank you very much.
Thank you, sir. I request our chairpersons, please felicitate our eminent speaker, Dr.
Just a 1 minute.
Advani, sir.
1 minute, sir. Sir, I want to ask you a question. You have a very big name in the treatment of cancer patients. I want to ask you, what is the scope of high intensity focused ultrasound waves in the treatment of cancer, particularly in the liver cancers and the prostate cancers? Thank you.
Yeah, I think there's a great scope for the local therapy which has come up. Like the surgery was one of the local treatment. But now we want to do something non-invasive. So the radiotherapy came in, and now all these other treatments are coming up, where ultrasound guided destruction of the high velocity ultrasound, producing the destruction of the tumor, and also the cold hypothermia, also which can produce the tumor destruction. So all these things are developing. They of course have the local effect. But mind you, the cancer is usually not local. Invariably, it is systemic disease. And therefore, the success of that is really very limited, but in fact, it controls a local disease. So nowadays, you use multiple sort of treatment facility, whichever is available. So our treatment is mostly multidisciplinary. Thank you.
Thank you, sir. Please, I request again our chairpersons, please felicitate along with Dr. Ravi.
As we are running short of time and due to the commitment of time and program with the Chief Minister of Chhattisgarh, a request to all delegates, any questions to the speakers will be addressed henceforth in person.
For the next session, I would like to invite chairpersons Dr. H.P. Sinha, Dr. Kishore Jha, Dr. Anil Sharma sir, Dr. Ajay Nagraj sir, Dr. Amit Agrawal, and Dr. S.N. Madharia sir, Dr. Kaushlik Thakur sir. The topic
is traumatic brain injury current management by Dr. Venkatesh. He's a senior consultant at Care Hospitals Banjara, Hyderabad, with a remarkable track record of more than 12,000 surgeries.
I request Dr. Ravi Jaiswal, please felicitate our previous chairpersons at the Momento desk. Over to chairpersons, Dr. H.P. Sinha sir, Dr. Kishore Jha sir, Dr. S.N. Madharia sir, Dr. Kaushlik Thakur sir, Dr. Anil Sharma, Dr. Ajay Nagraj, and Dr. Amit Agrawal sir. Over to chairpersons.
नाम क्या है यार वेंकटेश ना ट्रॉमेटिक ब्रेन वेरी गुड कॉमन टॉपिक traumatic brain injury is a very common traumatic injury. It is a vast topic, so please start.
Yeah, thank you very much. First and foremost, I would like to thank the organizers for inviting me to Raipur. This is the first time I have been to this place. I would also like to thank Dr. S.N. Madharia, who is my senior in college and my first guru in neurosurgery. So this is a topic very vast, but let us focus only on the simple things, in the sense that most of the complex problems in this world have very simple solutions. Stick to the basics and try to understand the pathophysiology behind, though, of course, for the brain, the pathophysiology of traumatic brain injuries has not been completely elucidated like any other field in medicine. We only know part of it because we understand brain very little, but we think we know everything. So let us go further. Most of the traumatic brain injuries are easily treatable, provided that the patient comes on time, right time, and we should have a facility where we can treat these patients without much problems. In fact, our ICU care teams are very, very important. Our nursing teams are very important. Rehabilitation teams are very important. And the leader of this team is the surgeon, the neurosurgeon. That is very, very important. And brain is such an organ which controls most of the functions of the body, either directly or indirectly. And it itself gets affected by any abnormality in any other system in the body. If there is uremia, there is uremic coma. Hepatic coma, if there is a liver failure. If there is hypoglycemia, there is coma. If there is hyperglycemia, there is coma. Hyponatremia, there is coma. There is hypernatremia, there is coma. Every damn thing. And most importantly, the hypoxia, hypercarbia, anything which affects any organ in the body will indirectly or directly affect the brain. And brain is the first organ to show you the signs outward. So I'm speaking about an organ which we all have in great abundance with us, but we use it very little. And with this introduction, I would like to go further to talk about this trauma. Let us forget about the slides which I'm going to project there. Let us understand the concept behind it. The brain as an important organ. If you go at the brain paradox, it has got high demands, no reserve, unconsolidated budget. In the sense, the brain has no reserve at all, but it actually uses about 20% of the resting total body oxygen consumption, and that is about 50% in children. And global cerebral metabolic rate of glucose is about 20% of the resting total body glucose consumption of adults, and 50% in children. Just imagine an organ which has only about 2% of the body weight, utilizing about 1/5 of the energy resource. And this is the organ when it gets injured, and like any other organ in trauma, whether it's a bone or any other part of the body, muscle, bone, skeletal muscle, and brain, already it is having so much of demand for metabolic substrates. And when it undergoes an injury, we all know that catabolism is at the highest in the acute injuries. And brain, being an organ which is in a very compartmentalized system, it is surrounded by a bony compartment, and it is again divided into 3 compartments there. Then the frontal or the anterior fossa, the middle fossa, posterior fossa, and there is no space for the brain to expand like any other organ which gets injured. The edematous brain cannot expand at all because the skull is there. That's where the surgeon's role comes in. So most of these injuries are either focal injuries or there are diffuse injuries, and now we know that most of the traumatic brain injuries also have a diffuse component, which we call, earlier we used to think that it is shear injuries of the axons. But now we know that every injury of the brain, whether it's a minor injury, whether it's a moderate injury or a severe injury, will have some amount of axonal injury, and whether it could be focal or diffuse. That's the reason why it becomes much more difficult for us to treat these injuries, and we had to be very, very, very rapid in treating these injuries, and we should understand the pathophysiology, and especially more than anything else, we have to protect the neurons and the axon and the glial cells, both of them. The 2 most important components of the brain, the astrocytes or the glial cells and the neurons. The neurons actually take up utilize about 75 to 80% of the energy what the brain utilizes, because they're also conducting the impulses for our day-to-day activities. And the axons utilize only about 10 to 20% of the energy. So this is one of the things which I wanted to convey to you, because if you knock down the neuronal activity during treatment of these injuries, you can actually save much of the energy which the brain can utilize to repair itself. So in any injury, we have 2 components. One is the inflammatory response. Other one is the inflammation, as we all know, is the beginning, the starting point of healing. And this starting point of healing of inflammation, if it is not directed towards the healing process, it consumes the body. We all know that. Inflammation can be very detrimental if it is in a very bad shape. And all of us physicians have to concentrate on this, making this inflammation go in the direction of a proper healing. So the basic principles of traumatic brain injury, there are 2 major things that we discuss about this. The first and foremost thing is the primary injury, what the person sustains there. In fact, India loses about 1.5 lakh people every year to just traumatic brain injuries. And this is a very huge number. And if you say 1.5 lakh people are dying, how many people are coming out with disability? How many people are in a vegetative state? How many people are actually not in a completely dependent state? And how many people are actually independent but still not totally productive? So that's why it's a very huge problem. And a country which is having 1.4 billion population, with people traveling day in and day out, there are a lot of road traffic accidents. Nearly 60 to 70% of our traumatic brain injuries are road traffic accidents. The initial injury is the primary injury. That is not that important. But most important is the secondary injury that is caused after some time. The secondary process can be mitigated. That's where we come into play actually. Because primary injuries already happened, but secondary injuries are ones which require the treatment to prevent further damage of the brain. And first and foremost thing I want to apprise of all of us, everybody should understand this, that the cells of the brain, the neurons as well as astrocytes, are permanent cells. Once they're damaged or they're dead, you cannot regenerate them. Period. That's it. That's the reason why the greater responsibility lies with all of us to protect these nerves, neurons, and the astrocytes, and without further causing much damage to them. Whatever damage happened at the primary site has happened. The secondary processes should not cause more damage. So these are we classify the traumatic brain injuries into mild, moderate, and severe based on how conscious or unconscious the patient is, what is the level of consciousness. And mind you, not only the severe head injuries which come into ICUs, which come into the hospitals, even the minor head injuries can cause a lot of problems, like memory disturbance. Minor head injury means a CT scan is normal, but the patient is had met with an accident or a small injury. He just got up, went back home. He is leading a normal life, but he is also facing some problems like behavioral problems, memory disturbances, sometimes becoming agitated. So even minor head injuries are not that simple, Even minor head injuries can cause so many difficulties for the patient. So we all know about the Glasgow Coma scale. I assume that most of us are in critical care, so we know about Glasgow Coma scale. We just have a scale between 3 to 15, and based on that, we also define whether it's a moderate or a mild or a severe head injury. Anything less than 15 is always considered to be a head injury with consequences. A person who is in 15 by 15 GCS after a head injury is considered to be okay. But anything below that, even 14, is considered to be an abnormal thing which has to be addressed at the earliest. So, India being a very big country and a lot of different types of facilities are available, in the sense there are certain places where we do not have a proper medical facility, or we don't have a neurosurgeon there, or we don't have a critical care unit there. With all this lack of resources, even in a simpler, smaller town, we should be able to, even in a small place where there is a person who has fallen from the height, sustained head injury, we should be able to treat him and bring him to the a second level or third level or a higher level center to treat him. So first of all, the people who are there should understand this. So at every stage, from the pre-hospitalization, hospitalization, post-hospitalization, rehabilitation, at every stage we have to understand that we have to save the neurons, save the neurons, save the neurons. There is no other thing that we should do. We only save these neurons because once they die, we can never get them back. And it also holds good for the astrocytes. So these are all recent things. In fact, Brain Trauma Foundation of the US, they started this research into this traumatic brain injuries in 1986. And over a period of last, say, about 40 years, they've reduced the mortality by 50% by following guidelines in every center. Now, neurological, the National Trauma Society of India has also formed some guidelines based on the same guidelines of the BTF. And today I'm going to talk about only a few guidelines, because most of the guidelines do not have a class 1 evidence, level 1 evidence, because most of the things, no two head injury patients are similar. No two GCS scores are similar. The patients have different injuries. A subdural hematoma and extradural hematoma both can present with GCS5 or GCS6. A traumatic brain contusion can also present with GCS5, GCS6. So it is very difficult to actually extrapolate what we see in the real scenario to actual, making guidelines or level 1 suggestions. So there are only two things that so far have been proven beyond doubt with a level 1 evidence. One is corticosteroids are detrimental, not to use at all. For any head injury, you should not use corticosteroids. This is a level 1 evidence. And second one is start feeding as early as possible. In the first 24 hours, the feed should start with at least half of resting expenditure, the metabolic expenditure that we do usually, resting metabolism. In that, at least 50% of the caloric value and at least 2 grams per kg body weight of protein has to be provided. These two are the only level 1 evidence so far that food is required for repair and for an organ which is having a very high metabolic rate, to provide that kind of substrate so that it can actually counter the detrimental effects of the head injury. So need for TBI guidelines, the level of care that patients with TBI receive in India is extremely variable. But a few urban centers of excellence meet international standards, others have trouble administering even first aid. It is essential that trauma centers be verified and designated by a reliable government or statutory agency. Many people say we treat head injuries, but they don't have anything there. They don't even have a CT scan. But so we should have different levels of recognition of each center and what amount of work I can do. This I usually call it as resource mapping and resource matching. In the sense, if a center has a neurosurgeon, then definitely it can be designated as maybe a class 1 center where we can do all kinds of procedures for head injury. But if we don't have that kind of a person, there's only an MBBS doctor. Still, we can train him to at least do the minimum first aid, ABCs, the airway, breathing, circulation, and then we can transfer the patient to a higher center. So it is essential the transplant center should be verified whether what they are claiming, whether they're doing it or not. There are no established pre-hospital care or patient triage or anything of that sort. Protocols still, they are not established in India. Nationally accepted guidelines for management of TB will help improve many of these shortcomings. So as I told, more than 1.5 lakh people are dying every year in this country. So basic thing is that, as I said, we should keep it very simple. There are a few things that the entire caregiving team should understand, that we have to preserve the remaining neurons which are not damaged in the primary injury. So sensitization pre-hospital, hospital rehab teams about the nature of brain cells being permanent and not having regenerative ability, not to give up. Brain has immense ability to heal and recuperate provided we give time. My personal experience says that sometimes we feel that the patient will die, but he makes a very good recovery. So we have to have patience. Most of the brain injuries will take a lot of time. Sometimes we wait for 3 weeks, 4 weeks in the ICU setting on a ventilator. And we have seen patients who have come out of all those problems after 3 weeks. I call this as the period of membrane stabilization. The axonal membrane stabilizes over a period of 3 weeks, and most of the improvement we can see after 3 weeks, and especially in severe head injuries. So hospital care guidelines, once the patient comes into the hospital, what are we going to do? So as I said already, level 1, level 2, level 3, level 4, we have designated some hospitals, the resource available, and what care they can give. And the basics, airway, breathing, circulation, and all these things. So I'll just tell you about the, the level, the evidence-based, because this time is short. So I just want to tell you about some evidence which is there, what we have to do. And the best thing that we can do is to get a CT scan of a patient who is having less than 15 GCS. If it is available, the CT scan is available. And we need to have a trauma ICU where the nurses can monitor the patient around the clock, and especially in the first 12 hours to monitor in every hourly, and later on at least 2 hours, once in 2 hours. And people, they should be able to tell the difference. Anisocoria, they should pick up with a difference of 0.5 millimeters, and that is very, very important because they can alert the surgeon. So whenever there's deterioration after admission in the ICUs, repeat CT scan has to be done, and based on that, we can make many decisions. So so there is a big controversy between whether we have to treat ICP, that is raised intracranial pressure, or the cerebral perfusion pressure. So what the guidelines say, we'll just see that. Most important thing is, many people do not understand that head up position is so important. 30 degrees head up position reduces the ICP by almost 30%, and it also improves the cerebral perfusion because by reducing the intracranial pressure. So ventilator support, osmotic agents. So just I will tell you about the class 1 evidence, what is available today. Avoid steroids in severe TBI, monitor and actively manage ICP, intracranial pressure, to prevent secondary brain injury. Provide early nutritional support enterally as early as possible. Maybe the first 6 hours also is okay if you think that patient can tolerate the feed. Avoid prolonged prophylactic hyperventilation. Prophylactic hyperventilation is dangerous, especially if you reduce the PCO2 below 30 or even below 35, it is dangerous. Hyperventilation has to be utilized only for first 24 to 48 hours and not beyond that. Consider deep compressive connectomy if ICP is refractory and patient meets surgical criteria. Early tracheostomy when indicated to reduce ventilated days in ICU stay. This accommodation to be integrated with a multidisciplinary trauma care pathway, including emergency medical services, neurosurgery, critical care, and nutrition teams. So most of these are level 1 and sometimes level 2A or B. So surgical management, draining of the CSF, removing of the hematomas, expansion hematomas, and sometimes we do, when there is severe cerebral edema and there is nothing more that we can offer, and the patient is, was initially stable and later he started deteriorating, then we can do a decompressive craniectomy. As I said, skull is very rigid, it cannot allow the swollen brain to expand. So we remove the piece of the skull to give the space to the brain. So this brain should not compress in the brainstem and cause permanent damage to the brainstem and brain death. To avoid that, we do what is called a decompressive craniectomy. And once the patient is, we check the Glasgow outcome scale after 6 months, whether somebody is fully recovered or moderate disabilities there, severe disabilities there, coma or death. So this is the Glasgow outcome scale will tell us whether we have done the right things at the right time. So we're still learning. In spite of treating thousands of patients, still we are learning. Still we do not know much about what pharmacological therapy will actually give a good result. So right now we are giving mannitol or a 3% saline to reduce the ICP, head-up position, maintaining PaO2 levels about 100 and PCO2 around 35. So these are the basic things that we do, and early nutrition. And one more important thing is early mobilization, which also stimulates the brain. And one more thing I want to tell you, most of our ICU doctors are actually giving a lot of muscle relaxant. I would suggest that you should avoid muscle relaxant as much as possible. Maybe at the time of intubation of a patient with a severe head injury, and after that, maintain completely on sedation only. Otherwise, it will be very difficult to wean off the patient from the ventilator once he recovers. And second thing is, when in spite of giving a muscle relaxant, you will be comfortable that patient is not moving, but actually his heart rate is going up and his BP is shooting. All these things happen because patient has got awareness, and that's why we have to adequately sedate the patient and avoid as much as possible the muscle relaxant. So these were the Brain Trauma Foundation recommendations. So hyperosmolar therapy, prophylactic hypothermia is to give. In fact, as I said, in diffuse axonal injuries, we find that the temperature is very high. Sometimes patient is having a lot of sweating. He is having shivering. His ICP is going up very high. So in such patients, we are using bromocriptine of 2.5 mg twice a day. And we have found that most of them will become normothermic in, say, about 24 to 48 hours. So that's a very important intervention that we are using in our ICUs. When we find a patient with diffuse axonal injuries with, there is something like a neuroleptic malignant syndrome-like syndrome, which happens in severe brainstem injuries, and there bromocriptine is working wonders. I think the conclusion is the development of guidelines for the management of traumatic brain injury, and we had to follow them. The Neurotrauma Society of India, in collaboration with the Neurological Society of India, has done a very good job. In the last 5-6 years, we have got almost guidelines on a yearly basis. If these guidelines are expected to bring about an enormous change in the management of TBI across the country, especially if followed by the treating doctors, thereby improving the outcomes of the TBI. Thank you very much. I know there's a lot to talk about traumatic brain injury, and it's very difficult to actually finish off in 20 minutes. I will skip a lot of things, but as you know, the basics you have to follow. Follow the airway, breathing, circulation, early nutrition, maintaining all homeostasis, in the sense, maintain glucose levels as normal as possible. Do not bring down the hyperglycemic levels very fast. Rapid is not indicated. We have to do a permissible reduction to 140 to 180. That is what is to be maintained in a hyperglycemic patient. Who is in hypoglycemia, you have to maintain at least beyond 100, 120. So glucose levels are very, very important. And the physiotherapy, in-bed physiotherapy has to start as early as possible, because that also stimulates the brain, as when we are doing, especially the posterior column stimulation, by doing the joint movements and all that, will stimulate the thalamus, and that in turn stimulates the cortex. And this is how the improvement in the brain happens. So all these things have to be followed very rigidly, and we have to train our nurses to take care of these patients, especially the pupillary dilatation has to be picked up at the earliest. Thank you very much for giving me this opportunity to talk about traumatic brain injury. Any questions?
Thank you, Venkatesh, for nice elaborated presentation in very short time to a most vast subject and most dynamic pathology which we are facing every day in our life. Unfortunately, this is most neglected part in our practice because everybody consider to manage the head injury very easy way. But this is most dynamic things. Thank you very much.
Thank you, sir. I request our chairpersons, please felicitate our speaker with a memento. And I request our chairperson, please collect their mementos from the memento podium. Dr. Santosh, please give a mementos to our chairperson at mementos desk. Dr. Santosh Singh Dr. Santosh. For the next session, I would like to invite Dr. Sanjay Pandey sir, Dr. Sushil Sharma sir, Dr. Alok Agarwal sir, Dr. Sudarshan Vishoi sir, Dr. Ketan Shah, and Dr. Alok Agarwal sir to chair the session, and respected Dr. Anil Verma sir. Please join the dais for the next session.
It is truly my honor to introduce our next speaker, Dr. Sanjay Dhar sir from Mumbai. He is senior orthopedic surgeon with expertise in trauma, robotic and spine surgeries with experience for over more than 30 years. He has been president to Bombay Orthopedic Society, Navi Mumbai Orthopedic Association, and also chairman to many orthopedic national courses. He's also been mentor and guide to many young orthopedic surgeons across the country. So over to you, sir.
Good evening, everyone. It's my proud pleasure and honor to be here. Thanks to the organizing committee of Ramkrishna Care Hospital. And it's really tough to stand here in front of such a large non-orthopedic crowd, probably a first time for me. So I have the pleasure of talking about disaster and orthopedic perspective. As we all know now, I don't have any affiliations or this is no financial relationships. So coming to the topic itself, as we all know, disaster is now all around us, whether it is because of the earthquakes, whether it is because of conflicts, or whether it is because of any terrorist activities. We do see disasters, and with now natural global warming, we have some disasters occurring very regularly. This is my own home, where we had a scaffolding brought down by a cyclone, and we had 14 patients. All of them came to me as I was practicing very close by, so I had to manage them thanks to my own society forcing me. So overall disasters now are very common, and almost 60 to 80% victims in this are musculoskeletal injuries, particularly when you see more surviving patients than dying patients. Orthopedic comes into very predominant position in such disasters. So commonly we have crush injuries, compartment syndromes, open fractures, pelvic and spinal injuries, and usual soft tissue injuries. And it forms a very large variety of patients, and in those cases, it's very important how you segregate them. So triage is the key. So you have to, one has to classify them. Although in India we lack a very coordinated response in spite of the army coming into position or NDRF, it's generally the civilians who come first, who reach the disaster site first, and it is they who start doing the triage. So that is the irony of all this, because the triage forms the most important thing. So whether how do you segregate the most important who need treatment, who can do well with transportation and treatment, and to somebody who is almost dying and there's no point saving them. So this forms a very important duty for all of us, medical fraternity, to sort of force government, advocate government to get these guidelines into position, as we are still a developing country. So for an orthopedic surgeon, the subacute phase, the phase which comes after around a week of this disaster, is very important. I was in Bhuj when the earthquake happened. The first week, I was not there in the first wave, I was there in the second wave. And when I landed up there, every orthopedic surgeon or general surgeon had operated almost every patient. Something which you have never done open reductions, internal fixations in a compound injury. They had put plates everywhere, so they created a second disaster. So that is something which is still happening, and in our own urgency to do things, we basically lack how do you manage these. So surgical care focus is towards optimizing outcomes, soft tissue coverage, efforts are made to assess the full extent, and we should have a long-term plan. So broadly, you divide the orthopedic injuries into crush injury, crush syndrome, or compartment syndrome, with or without a fracture. So these are things which would probably make high morbidity for these patients. So a crush syndrome, a traumatic also called as traumatic rhabdomyolysis, it can happen within 1 hour of compression. Suppose there's a wall collapse or a building collapse. Even within 1 hour, somebody can develop a crush syndrome, or it may optimally take around 3 to 4 to 6 hours to develop this crush syndrome. So identification of this crush syndrome is very important, where an intensivist comes into picture to identify the elevated CPK, elevated hyperkalemia. All these things need where an ICU management becomes very important. An orthopedic surgeon, probably very naive to all this, is more worried about the fracture or the soft tissues, but the biochemical happenings in these cases are rapidly changing the whole scenario. Then crush syndrome and compartment syndrome, early recognition becomes very important, whether it is swelling or pain out of proportion. So in such cases, the right decision at the right time, when to do fasciotomy, the understanding of that whole mechanism is very important. So avoid tight bandages at the site. So people who are not well versed with the triage, they would just give tight bandages, put very tight, and try to shift them as fast. By the time they reach the hospital, the tertiary center or the center which is taking care, they would already develop crush syndrome and probably would lose the patients. So, and then wound infection and management. Even if in non-sterile environments, like maybe on the road, it is very important to maintain sterile environment in such cases. So using VAC dressings, nowadays we use VAC almost in every case, and it has really changed the management of these wounds. So the first debridement is the key. When you get the patient first, the initial reaction maybe we'll just get away, amputate it. So somebody's junior most there sees the patient, decides that it's very bad, the pulse is not felt, you may amputate. But first look and first debridement probably becomes most important. So that is where the senior most member of the team is important. So somebody very senior should do this debridement, because he understands the whole tissue injury and probably would be able to do get a much better prognosis in such case. So this is something which is very heartening at the end of it. Somebody whose limb would have been amputated but is able to, you can see the amount of gratitude they have for you if you have done it rightly. So then somebody damage control orthopedics comes in picture in these cases. So instead of somebody focusing on one single patient where you want to do the best and get the good bone reconstruction, graft it, nail it, plate it, it is very important that you rapidly do something so that she doesn't deteriorate or he doesn't deteriorate. So don't do any fancy fixations, rather than just try to stabilize them, do a good debridement, and try to give them good wound therapy, antibiotic therapy. They would probably survive the whole trauma. So coming to amputation and limb salvage, that is the difference. So rather than wasting time on certain things where you will not be able to get it right, it is very important to take a quick decision rather than getting them into a crush syndrome scenario and then losing the patient in the ICU. It's very important that an orthopedic surgeon or the senior most member of the team has a good look and decides in consultation with the parents and with the relatives, and take a consent and try to save or amputate the limb. So adaptability and flexibility is very important. That is true orthopedic surgeon who always is like a chameleon. He changes. Any treatment can work well if you have a thinking mind, a thinking orthopedic surgeon. So whether do a fasciotomy, fracture stabilization, amputation, it is a rapidly changing decision which you have to take it, and you are the key person that time who decides this, and that is going to ultimately, in the long run, make a proper decision work. So key takeaway is definitely orthopedics must wait until disaster becomes a disaster, no more. So don't be a hero. Don't try to do some fancy fixation or a fancy reconstructions at the site or at the first care center, rather than try to save the limb or try to save for the few and create no more disaster. So these they may be very badly seen injuries, or maybe very simple injuries where you feel that I can easily do a nail here and then fix it and everything will be fine, but you are missing a compartment syndrome. So if you're not identified that, you will probably lose a limb in the second week or third week. So that is very important decision making. So this was a young engineering girl doing engineering who had this crush injury, and on the table on there you can think of nothing else except amputation. But thank God she herself refused. She said you have to save it. So we did it. So the first debridement was like this is on the table. Immediately after debridement you can see a completely different look. So a meticulous 3-hour debridement is very important. So second debridement, so ultimately she survived. We did, so debridement is the key. So first, and that too the first debridement, which I would recommend only a senior most person in the team should do it. So secondary stabilization, so we saved a limb which was about to be amputated, did a flap, and finally she walked and she danced. I could not get her picture here for the obvious reasons. So patient counseling and understanding is very important in such cases, and your understanding of the injury is very important. So I will just skip for the lack of time. So you might have impending vascular injuries which you will probably try to solve. All that decision making becomes very important. So neither I am recommending that you be very aggressive, nor I am recommending you amputate at the first site, but it is very important decision making which helps. So now we have excellent facilities like VAC dressings, better understanding of the anatomy, and good implants available which make this salvage or decrease their morbidity of these disasters. So this 10-year-old boy, again a wall falling on his hand, where a very innocent looking injury, bone is out, just reduce it, put it in a slab and let him go home in a primary care center would have meant a disaster. And you can see there is no blood supply going distally, so needs immediate care, and with the help of the plastic surgeon, and you could save the limb and get a good function. So good results do follow good decisions. So you should always take decisions and take responsibility and with the best possible thought of the patient. So rule out the life-threatening injuries and don't focus only on the limb. So it is very important, the teamwork. That is what I said. We lack coordination in our country, where the disaster response is very poor. It is actually the general public who decides what to go and what to shift where. So I would skip this. So take good quality. Now we have phones in every hand. So the first junior resident comes, he sees the patient, removes the slab, gives some shabby wash, and then again put the slab. Then the senior registrar comes, he again opens the slab. So all this is not important. You have phones, you can take good photos, send it everywhere. Of course, it is private circulation. And then rather than opening and contaminating it every time till you finally reach the OT. So aggressive debridement is very important, and it is to be followed as an algorithm, like type 1 3 liters, type 2 6 liters. So we should not rush at that is the first choice. Then coming to external fixator versus definitive fixation. Earlier I remember when I was in a public hospital, the cardiovascular surgeon shouted at me, why did you not put a fixator? Because that was the thing that time. Now we have devices, we have implants which we can implant inside, and we don't need a fixator. So you can, a good debridement with VAC dressing and an internal fixation, particularly in upper limb, becomes a very definitive treatment rather than putting an external fixator and then getting infection and then all that thing. So that decision is yours. That decision is the surgeon's decision, and it is very important. It is taken with a lot of thought. So primary stabilization to protect soft tissues, decreases the risk of infection, allows evacuation to a safer environment, and basic set allows more people to be treated. So you can do it very rapidly. And if you are not very sure about your debridement, external fixator may be a savior. So then otherwise we have now good excellent devices, which these are unreamed nails, or they are nails which can be done without C-arm. You don't need, and I am sure now most of the orthopedic surgeons have learned to do interlocking without the C-arm. We have techniques that we can do it without the C-arm. So that gives you a very quick response time, surgery time, rather than wasting time. So negative therapy or vacuum therapy has changed the whole paradigm of wound management. It allows you large wounds to be taken care of and gives you a faster closure, angiogenesis, very good healing very fast. Coming to pelvic fractures, I'll rush through this. Since there's lack of time, I don't want to wait. So the assessment again is very important. So pelvic injuries can kill a patient. So if you're not identified and segregated them very well, you might lose the patient very rapidly. And in association with the GI surgeons or the abdominal surgeons or the general surgeons, it's very important that you act very fast. So immediate assessment, quick identifying the site of hemorrhage, and then seeing the metabolic acidosis, lactate clearance, you have to take very fast hemorrhagic control. So moral evaluation, something which you might miss in a casualty, and if you're not identified, they can end up in a very bad wounds. So that is why it is very important to identify them, and don't rush to OT or rush to or neglect them. So now vacuum therapies and other things do help in such cases. So open injuries of the pelvis are very dangerous and they have very high mortality. So putting a finger and having a look at the perineum is very important in such cases. So don't do springing of the pelvis, which you conventionally will do, because that can dislodge a clot. Immobilization is very easy. Just a bed sheet in such cases would be useful if you don't have big devices like C-clamp or a pelvic fixator ready, so you can just immobilize. So workup becomes very important in these cases, and rapidly identifying them is very important before we actually do this. So pelvic stability is an early and critical goal, and whether you do it with a fixator or you do it with a simple bed sheet, it's very important to identify and stabilize them hemodynamically. So angiography in some cases where you are not able to hemodynamically get them stable, and now you have devices like Reboa which are available now in India also in many hospitals. We can use them. Pelvic packing becomes gynec surgeons, abdominal surgeons use them very regularly, but we orthopedic surgeons also sometimes when we are losing the patient we can do pelvic packing. So summary: rapid replace losses, angiomobilization, periperitoneal packing, fixation, Reboa is coming. So I'll just rush through. For spinal, these are still lacking. You can see in Hollywood movies, the first injury they have collar put on, but in Hindi movies, we don't do it, not even in the real life scenarios. We just carry them like anything. So what is very important, we are still here. That is something where we are, while we have moved, developed a little from the left side to the middle, we are still a long way to go. So pre-agreed triage protocols, resource allocation, follow guidelines, and preparedness and prevention is very important. So it is the greatest good to the greatest number of people, which is the measure of right and wrong. Thank you very much.
Thank you, sir.
Thank you very much, sir, for an attempt to summarize the couple of days workshop topic in about 20 minutes. So commendable work. You have covered practically everything that polytrauma and disaster orthopedics patients do have. So congratulations.
Thank you. Thank you, sir. I request our chairpersons, please felicitate our speaker with a memento. And I request our chairpersons, please collect their mementos from the memento podium. Dr. Pratik Dhavalia requested to felicitate our chairpersons with memento at memento desk. Now move to next session.
For the next talk, may I first invite the chairpersons, Dr. Mau Roy, Senior Cancer Surgeon, Sanjeevani Cancer Hospital, Raipur, Dr. Rajiv Jain, Senior Consultant, GMC, Raipur. Dr. Amit Agrawal, Consultant Medical Oncologist, All India Institute of Medical Science, Raipur. Dr. Jaswant Jain, Senior Cancer Surgeon, Mittal Cancer Hospital, Raipur. Dr. Debadulal Biswal, Consultant Medical Oncologist, Raipur. Dr. Puneet Seth, Senior Consultant Radiation Oncologist, Raipur. To deliver the next talk, it's my pleasure to invite Dr. Vipin Goel, who is a renowned surgical oncologist practicing in Hyderabad. He is a director of Star Hospital Cancer Unit. So over to Dr. Vipin Goel, sir, and the chairpersons, Dr. Mau Roy, ma'am, please take it forward.
Patients.
Good evening, one and all. Before I start, I'd like to thank my close friend Ravi and Dr. Dave for giving the opportunity to present in front of such a allied crowd. The topic for today is oncological emergency. I want to start with this proverb: an individual can win match, but we need a team to win a tournament. Applies to the topic today, which is oncological emergency. Individual, as an oncologist, I cannot treat the patient. We need support of many more colleagues like emergency physician, critical care team, anesthetist, and many more to treat patient. Cases of emergency, oncological emergencies are rising because of increase in the cancer incidence and also increase in survival. What is the definition? A acute life-threatening situation that occurs in a cancer patient which can lead to immediate death. The word to remember here is, in a cancer patient, the episode should be acute, which can lead to death. It can be because of mainly classified into two, either direct or indirect. With respect to direct, what we know is it is an anatomical problem where the tumor is either compressing the surrounding structure or causing invasion of the surrounding structure, whereas indirect is a metabolic problem which is because of release of the chemicals from the tumor or because of the treatment. Direct again can be classified into organ wise, where the CNS, it is increase in the intracranial pressure or cord compression. Thorax, where there is SVC syndrome, and in abdomen we see bowel obstruction and perforation. I will be sharing few cases where I will go through history, examination. I will give 2 seconds for everybody to guess what may be the diagnosis and what is the treatment. Let's start with the first case. A 47-year male, known case of lung carcinoma, status post-surgery followed by chemotherapy, presented to emergency department with headache, projectile vomiting and blurring of vision. On examination, papilledema was present. Any guess what may be the diagnosis? Sorry? Brain matters. No. Headache, projectile vomiting, blood vision, papilledema is there.
Raised intracranial pressure.
Suspecting some brain lesion, we got MRI scan done, which revealed multiple lesions in the brain. The diagnosis was brain metastasis leading to increase in intracranial pressure. The treatment here is head elevation followed by anti-edema measures like mannitol and dexamethasone. Then depending on the lesion, if multiple lesions are there, we give radiation. If single lesion is there, surgery which leads to decompression followed by systemic treatment is given. Moving to second case, 48-year-old female, a known case of metastatic breast carcinoma on chemotherapy, presented with severe back pain, lower limb weakness and urinary retention. On examination, there was tenderness over the dorsal spine and power was 3/5 in both the lower limbs. What is the diagnosis?
Cord compression.
Sorry? Suspecting some lesion in the spine, MRI was done, which revealed a lesion in the thoracic spine which was causing compression of the spinal cord. The diagnosis was vertebral metastasis causing spinal cord compression. Treatment is very simple, steroid, and in almost all cases, decompression has to be done, followed by radiation and systemic treatment. Next case, 55-year-old male, a smoker, complains of headache and swelling of the face. Symptom worsens or bending forward. And on examination, we saw engorged veins on the neck and chest wall. What is the diagnosis?
SVC syndrome.
Yes. Here we have SVC syndrome where the tumor is causing compression of the SVC. We can see with this diagram, the tumor is present in the thorax which causes external compression of the SVC or invasion of the SVC which will lead to backflow. The treatment depends on the grade. If it is grade 1 or 2, mild grade, then we should know whether it is a known case of cancer or unknown. If it is known, definitely treatment has to be done. If the cancer is not known, we need to do the biopsy and definitely treatment based on the biopsy. Like if it is a germ cell tumor, chemotherapy. If it is a thymoma, surgery. In grade 4, we don't have time. So immediately stenting has to be done followed by radiation. Next case, a 45-year-old male, known case of oral cancer, status post-surgery followed by radiation, presents with breathing difficulty and swallowing difficulty and hoarseness of voice. On examination, stridor was present and accessory muscle of respiration were used. What may be the diagnosis? Obstruction. The case here was obstruction, airway obstruction. The treatment of airway obstruction is immediately managing the airway. Airway can be managed either by intubation or tracheostomy. If the obstruction is below the second and third tracheal ring, then stenting has to be done because your tracheostomy will not help. Sometimes we do encounter cases like this. We don't know what to do. Tracheostomy cannot be done, intubation cannot be done, and stenting cannot be done. Such patient we tell openly, nothing is possible. We give only best supportive care and probably this case nothing can be done. An international patient from Somalia presented to me with chest pain and shortness of breath. On examination, tachycardia was present and elevated JVP and muffled heart sound was there. Investigation ECG showed low voltage QRS and electrical alternance. What may be the diagnosis?
Pericardial effusion.
Very good. The diagnosis here was confirmed on echocardiography, which revealed cardiac tamponade. There was a massive pericardial effusion. To know the cause, we got CT scan done, which showed a big mediastinal mass, which was causing pericardial effusion. The treatment for pericardial effusion is pericardiocentesis on emergency basis, followed by pericardial window. Then, by knowing the biopsy, we know what is the pathology of mediastinum, whether it is lymphoma, thymoma, or germ cell tumor. Based on that, we do the treatment. Our patient underwent pericardial window followed by biopsy. We were very unfortunate in this case. The final histopathology report came as epithelioid hemangioendothelioma, which is not responding to chemotherapy, not responding to radiation, and surgery cannot be done because it was invading the heart. Only best supportive care was done and patient was sent back to Somalia. We don't wanted to waste patient, we don't want patient to die here. 50-year-old man with ovarian cancer on third line of chemotherapy presented with colicky abdominal pain, vomiting and not passing stool. On examination, distended abdomen was there and bowel sound were absent. X-ray erect abdomen was done. Diagnosis here? It's a case of intestinal obstruction, which was confirmed on CT scan, and patient was immediately put on nasogastric decompression, IV fluid, antibiotic, and surgery was advised. We told patient surgery can vary anywhere between radiolysis, resection anastomosis, bypass or diversion stoma. Patient didn't give consent for 3 days. Patient gave consent for surgery after 3 days, and when we took the patient for surgery, this was the finding. Bowel has already gone for gangrene. So in obstruction, we should not waste time. We should do immediately surgery, and we have to do almost 40 centimeter resection of the small bowel and primary closure followed by stoma. 58-year female with ovarian cancer on bevacizumab. This is the point, bevacizumab, presented with severe abdominal pain, vomiting and constipation. On examination, tachycardia was there, hypotension, guarding and rigidity. X-ray electroabdomen was done. What is the diagnosis?
Perforation.
On bevacizumab with rigidity and guarding. Perforation. This was a case of, we can see air under the diaphragm. It is a case of perforation, which was confirmed on CT scan. Treatment here is IV fluid followed by antibiotic, nasogastric decompression. Primary repair is need to be done, and sometime if repair is not possible, only stoma need to be done. We were fortunate in this case. It was a clean cut perforation without much inflammation. We were able to do primary closure. Another interesting case presented to us with abscess and pus in the right iliac fossa. When we put the needle, we can see the pus. What may be the diagnosis? We thought it can be psoas sepsis or some unusual infection. But when CT scan was done, it was a case of carcinoma of the cecum, which has perforated into the abdominal wall and form an abscess. Inflammation and dilatation was not there much, so patient underwent right hemicolectomy followed by ileocolic anastomosis. Two more interesting cases I want to present before I end. This is a 34-year female patient who is known case of CKD post-renal transplant presented with abdominal pain. We never expected this. When we did CT scan, this was the finding. There was a huge IVC sarcoma which was completely occluding the IVC, and you can see the kidney was in the right iliac fossa, which was joining the right iliac vein and artery because of transplant. Native kidneys were not working. The problem here was, now the venous drainage is not there IVC, only the transplant kidney was there, which may also go for failure. Patient was concealed for surgery, very extensive surgery, and resection of the IVC was done completely, followed by PTFE graft. This was such a rare case, it was published in cover page of International Journal of Venous and Lymphatic Disorder, where they have taken our case and published as a cover page, and also covered in various news medias about this case. About indirect causes of emergencies, we have because of the metabolic problem like
Sorry to interrupt you because the CM sir is on his way. I just request all of those guys who have their vehicles on the way, it's an emergency, please remove those vehicles immediately from the porch. Anybody of you who has their vehicles in the porch, please immediately, it needs to be removed right now. Thank you so much. ऑल्सो इन द वे जो पोर्च के आने वाला रास्ता है उस पर भी कुछ गाड़ियां खड़ी हुई हैं, जिन भी महानुभावों की हो कृपया करके उसके तुरंत हटाने की कृपा करें. धन्यवाद. सॉरी, प्लीज कैरी ऑन.
थैंक यू. About metabolic causes of like indirect causes of medical emergencies, just want to tell names and skip because I want to present one last interesting case which so much have impact on my life, has taught me such an important lesson of my life. I will never forget that case. Tumor lysis syndrome is because of the rapid breakdown of cancer cells releasing chemical into the blood, leads to increasing uric acid, potassium, phosphate and creatinine and low calcium. They are present with nausea, vomiting, fatigue, seizures and cardiac changes. Management is very simple, aggressive hydration and aggressive cardiac monitoring is required. But if they don't respond to treatment, then we have to do dialysis. Hypercalcemia of malignancy is abnormally elevated calcium. Either it may be because of the tumor secreting PTH hormone or maybe bone metastasis which are osteolytic, which will lead to high calcium in the body. They can present with arrhythmias, and on investigation, calcium will be usually more than 14 with suppressed PTH and increase in alkaline phosphatase. Treatment again is IV hydration, diuretic, bisphosphonate. Sometimes we have to give denosumab and calcitonin. Neutropenic sepsis. Any cancer patient with signs and symptoms of infection with total count or neutrophil count of less than 500 is the definition for neutropenic sepsis. It is because of the marrow suppression. Marrow suppression can be because of any reason like tumor infiltrating the bone marrow, chemotherapy, radiotherapy. Patient present with fever, chills, tachycardia, hypotension. The treatment here is blood culture, IV antibiotic and supportive care. I will come to my last case. I will take just two more minutes. Yeah, I will finish in 2 minutes. This is my last case, which I want everybody to spend 10 seconds. And if anybody can tell this diagnosis, definitely they will get one gift from Dr. Dave. Anybody can tell what is the diagnosis and what is this case. This case has left such a big impact on my life. It has changed my complete practice as an oncologist. What is this case? Anybody can guess? Sorry? Spotter. I can give one hint related to gynecologist. Correct? Sarcoma. Somebody told sarcoma. Anything else? Sir has told sarcoma. Yeah. Anything else?
Abdominal wall metastasis.
No. And for this case, I want to thank Care Hospital where I was working before, because this patient was very poor, didn't had any money, but I requested them I want to do this case as an academic case. They gave me completely free hand and only consumable were charged for the patient, and it was done completely free of cost. 5 more seconds, I have 40 seconds, I will go ahead. This is a case of sarcoma of the abdominal wall and she is 36 weeks pregnant. You can see this is the tumor here in the diagram and we are palpating now. I will show you the uterus. Now this is the uterus. She is 36 weeks pregnant. This came to me. Now the doubt was whether to remove the tumor, then what to do baby. And we cannot do cesarean in this case because there is no place left. So I consulted my gynecologist. I requested them, you have to do normal delivery. There is no other option because the tumor was completely involving. I cannot breach the tumor. Luckily, she underwent normal delivery. After that, we have done resection of the tumor completely and reconstruction was done. This has given me very important lesson of my life, which was told by Shri Krishna in Mahabharata to Arjun. Karmanye vadhyaraste ma phaleshu kadachan. You do your work sincerely with pure heart. Don't see the results. And this patient, I advise radiation, but because of cost constraint, patient didn't come for radiation. I told I will give you free of cost, but didn't come. To my surprise, she came to me after 1.5 years. I told, where is the baby? That is the baby which was in the womb. Still, she is cancer free, baby is doing good. That's why, and same thing was published in various newspaper. And thanks to Care Hospital for giving the opportunity to operate this case free of cost. I thank you everybody.
Thank you so much, Vipin Goel, for such an energetic presentation as usual. And everyone is mesmerized by your charm as well as your presentation. Over to chairpersons.
So, sir, what was the histopathology report of this sarcoma?
This was a undifferentiated sarcoma. Now what I can recollect is it was dependent on the hormones which were secreted in pregnancy. Because once the pregnancy is gone, probably the growth factor has gone and tumor has not grown up. In spite of not giving radiation, the tumor has not come back.
I request all the chairpersons to please felicitate our speaker and all the chairpersons to collect their memento from the memento desk.
I request Dr. Ravi Jaiswal felicitate our chairperson with the mementos at memento podium.
Our Honorable CM is about to come. He'll be reaching in any minute. I request all of you to please remain seated. Those who are waiting outside, I request all of you to gather inside the hall and please remain seated. The remaining 2 sessions will be taken after the inaugural function.
टेबल पे रख देना।
इमरजेंसी का छोड़ दो।
अरे मैं तो बोला नहीं है दूसरे हैं
जी कहीं बैठा दीजिए ना 2 मिनट के लिए
बता के गए वो बोल के ना व्हाट्सएप 5 मिनट आ रहा है फिर करते हैं आ जाने मेरा बता के गए बोल के व्हाट्सएप आ जाने प्रिपेयर्ड है फिर वेट करने के लिए तो बिहार चले गए तो उसके बाद चालू करते हैं नहीं वो तो बात बिहार चले गए चुनाव के चक्कर में उनको भेजे होंगे जो भी है वो तो क्या है भाई कमान से जो उनका आ गया होगा तो उनको तो जाना ही पड़ेगा मतलब उसमें तो
A very good evening to you all, ladies and gentlemen, and welcome to the formal inauguration ceremony of Criticon 2025. आप सभी का इस Criticon 2025 उद्घाटन समारोह में स्वागत है। आज इस महत्वपूर्ण सम्मेलन के उद्घाटन में आप सभी को स्वागत करते हुए मुझे अत्यंत प्रसन्नता हो रही है। कार्यक्रम की शुरुआत करते हुए सबसे पहले हम दीप प्रज्वलन के लिए सभी विशिष्ट अतिथियों को आमंत्रित करते हैं। मैं सभी गणमान्य व्यक्तियों से अनुरोध करूंगा कि वे अपना स्थान ग्रहण करें। आज हमारे लिए अत्यंत हर्ष और गर्व की बात है कि हमारे साथ मंच पर उपस्थित हैं माननीय मुख्यमंत्री श्री विष्णुदेव साय जी, माननीय विधानसभा अध्यक्ष डॉक्टर रमन सिंह जी, साथ ही एवर केयर क्वालिटी केयर इंडिया लिमिटेड के ग्रुप एमडी श्री वरुण खन्ना जी, सीईओ क्वालिटी केयर इंडिया लिमिटेड के डॉक्टर पवन कुमार, आईएमए रायपुर के अध्यक्ष डॉक्टर कुलदीप सोलंकी, आईआईसीसीएम रायपुर के अध्यक्ष डॉक्टर एसपी साहू, रामकृष्ण केयर हॉस्पिटल के मैनेजिंग डायरेक्टर डॉक्टर संदीप दवे, क्रिटिकॉन 2025 के ऑर्गेनाइजिंग चेयरपर्सन डॉक्टर अब्बास नकवी और डॉक्टर विशाल कुमार। So we'll kick off the program by starting the journey of healthcare, the 36 years of the journey of healthcare. डॉक्टर संदीप दवे 36 साल छत्तीसगढ़ में। सबसे पहले मैं अनुरोध करूंगा कि वीडियो प्ले करें।
मेरा सफ़र इस शहर से शुरू हुआ और आज हर एक पेशेंट में मुझे वही दिलासा दिखाई देता है। 1992 में शुरू हुआ रामकृष्ण सर्जिकल नर्सिंग होम आज रामकृष्ण केयर हॉस्पिटल के नाम से सेंट्रल इंडिया का सबसे एडवांस्ड NABH एक्रेडिटेड हॉस्पिटल बन चुका है। मैं हूं डॉक्टर संदीप दवे। मैं यहाँ 36 साल से सर्जरीज कर रहा हूँ और मैंने हर एक सर्जरी को अपनी एक जिम्मेदारी माना। रामकृष्ण केयर हॉस्पिटल खुद में ही एक सर्जिकल सेंटर है। यहाँ मैं करीब 1 लाख लैप्रोस्कोपिक सर्जरीज और करीब 500 रोबोटिक सर्जरी मैं अभी तक कर चुका हूँ। डाविंसी 4th जनरेशन रोबोटिक सर्जरी प्लेटफॉर्म है। इसमें एडवांस रोबोटिक सर्जरी या एडवांस सर्जिकल प्रोसीजर्स किए जाते हैं। जहाँ मेरे 2 हाथ हैं वहाँ रोबोट के 4 हाथ मुझे सहायक रहते हैं किसी भी सर्जरी को परफॉर्म करने के लिए। और इसमें सूक्ष्म से सूक्ष्म प्रक्रियाओं को भी अच्छे से किया जा सकता है। रोबोटिक सर्जरी आने वाले कल की दौर की तकनीक नहीं, ये हमारे आज को बेहतर बनाने का एक जरिया है। लैप्रोस्कोपिक सर्जरी से कंपेयर किया जाए तो यह ज्यादा एक्यूरेट है, कॉम्प्लेक्स केसेस को हैंडल करने का एक आसान विकल्प है और आपको जल्दी स्वास्थ्य बनाने का एक माध्यम भी। रोबोटिक सर्जरी में चीरे सूक्ष्म होते हैं, सर्जरी का घाव जल्दी भरता है और आप कन्वेंशनल सर्जरी के कंपैरिजन में और जल्दी ठीक होते हैं। जब आप किसी को रेफर या रिकमेंड करते हैं, आप सिर्फ एक पेशेंट नहीं भेजते, अपना भरोसा भेजते हैं। कोशिश कर रहे हैं कि हमेशा बनाए रखें। आपका विश्वास कभी हमारे अस्पताल के प्रति ना टूटे। हम आपसे जुड़े रहना चाहते हैं। हम चाहते हैं कि आप कोई भी अपना इलाज करवाने के पहले एक बार हमसे जरूर संपर्क करें। सदा आपके लिए इसी विश्वास के साथ मैं संदीप दवे।
मैं सजता ही रहूं, सबको मिल सकूं आसानी से, मेरे वजूद को खुदा इतनी महंगाई न दे। इन शब्दों के साथ मैं डॉक्टर संदीप दवे का स्वागत करता हूं। उनका इंट्रोडक्शन देना अपने आप में बहुत मुश्किल है। ही इज़ ऑल्सो माई मेंटोर, ही इज़ माई गाइड, and he has not only performed immense surgeries and served the people of Chhattisgarh, but his consistent participation in global surgical forums and conferences reflects his commitment to learning and staying at the forefront of medical innovation. His discipline, humility, and relentless drive continue to inspire a generation of doctors, not only in Chhattisgarh, but all over India, making him a living legacy in the field of healthcare. Now I invite Dr. Sandeep Dave for his inaugural address.
छत्तीसगढ़ में 36 साल। 1989 से शुरू हुआ ये सफर आज 2025 में इस मुकाम पे पहुंचा है, जहां पर इस ऑडिटोरियम में भीड़ जो आई है, जो चिकित्सक आए हैं, सर्वप्रथम मैं आज रामकृष्ण केयर परिवार की तरफ से उन सब का स्वागत करता हूं।
मैं स्वागत करता हूं एक ऐसे व्यक्तित्व का जिसने हर कदम पर मेरा साथ दिया, जिसने मुझे नई जिंदगी दी, जिसने मुझे जीने का तरीका सिखाया। जब मेरा परिवार कठिनाई के दौर से गुजर रहा था, जब मैं एक ऐसे दौर से गुजर रहा था जिस वक्त मैं बेहोश था, वेंटिलेटर पे था, उस व्यक्तित्व ने सारी सरकारी मशीनरी को मोबिलाइज करके मुझे रायपुर से बॉस्टन पहुंचाया। ऐसे अभूतपूर्व व्यक्तित्व मेरे माननीय अग्रज डॉक्टर रमन सिंह, भूतपूर्व मुख्यमंत्री, वर्तमान स्पीकर, इनके लिए जो मैं कुछ भी कहूं कम है। मैं इनका जिंदगी भर मैं और मेरा परिवार एहसान मानेगा। आपके सहयोग के कारण आज मैं खड़ा हूं साहब, बहुत बहुत धन्यवाद। एक सीधा सरल व्यक्तित्व, हम कभी सोच नहीं सकते थे कि छत्तीसगढ़ के मुख्यमंत्री बनेंगे। ऐसा व्यक्तित्व जिसमें विष्णु भी समाये हैं, जो देव भी हैं और जो आज छत्तीसगढ़ के मुख्यमंत्री भी हैं, श्री विष्णुदेव साहब, आपका मैं तमाम छत्तीसगढ़ के सर्जन और बाहर से आए हुए सारे चिकित्सकों की तरफ से स्वागत करता हूं। एक डायनेमिक लीडर, एक विजनरी लीडर जो सोच रहा है कि केयर ग्रुप को किस लेवल पे, नेक्स्ट लेवल पे कैसे लेके जाना है। आज केयर ग्रुप उस मुकाम पे खड़ा है जहां पर वो हिंदुस्तान का दूसरा बड़ा ग्रुप होने जा रहा है। ऐसे व्यक्तित्व मिस्टर वरुण खन्ना का मैं स्वागत करता हूं। मिस्टर पवन देव, डॉक्टर पवन कुमार, हमारे नए सीईओ, इनके बारे में इतना ही कहूंगा कि आप नए हैं, केयर फैमिली में आपका स्वागत है। यह सफर, जैसे मैंने आपको बोला, 1989 में मैंने शुरू किया और मुझे मालूम है कि उस बुढ़ापारा के छोटे से नर्सिंग होम या छोटा पारा की क्लिनिक से जो मैंने सफर शुरू किया था, आज 2025 में 450 बिस्तर के अस्पताल के रूप में आप सबके सामने खड़ा है और मार्च तक के एक अनोखा कैंसर सेंटर भी हम इस छत्तीसगढ़ के क्षेत्र को देने जा रहे हैं। और शायद एक ऐसा सेंटर होगा जो अपने आप में अलग होगा, डिफरेंट तरीके से, एक एम्पेशनेट केयर, पेशेंट को जो हम एम्पैथी के साथ सिंपैथी भी देना चाहेंगे और एक डिफरेंट लेवल की कैंसर केयर प्रोवाइड करने की कोशिश करेंगे। इस क्रिटिकल केयर कॉन्फ्रेंस को करने का मेरा जो जज्बा था वो शुरू हुआ कुछ वर्षों पहले और ये हमारी 5वीं या 6वीं क्रिटिकल केयर कॉन्फ्रेंस है। और क्रिटिकल केयर के साथ मेरा जो जुड़ाव था वो बहुत पहले शुरू हुआ। यहाँ पे 2 डॉक्टर्स, 2 चिकित्सक बैठे हैं जिन्होंने छोटे से नर्सिंग होम में क्रिटिकल केयर शुरू की थी, डॉक्टर सतीश गोयल, डॉक्टर राजेंद्र बांटिया। अगर मैं बोलूं कि ये दोनों ने इस क्रिटिकल केयर को रायपुर में लाए थे तो अतिशयोक्ति नहीं होगी। और उसके बाद में हम वो अस्पताल बनाए जिसने कि क्रिटिकल केयर में को सही रूप में डिफाइन करने की कोशिश की, परिभाषित करने की कोशिश की। हमने प्रयास किया कि दुनिया में जो भी एडवांस टेक्नोलॉजी उपलब्ध हैं क्रिटिकल केयर में, वो हम अपने अस्पताल में ला पाएं। उस प्रयास में बहुत सारे कष्ट आए, बहुत सारे प्रश्न चिन्ह खड़े हुए और जो सबसे बड़ा प्रश्न चिन्ह आज की तारीख में क्रिटिकल केयर को लेकर खड़ा होता है, आईसीयू केयर को लेकर खड़ा होता है कि साहब पैसा ज़्यादा लग रहा है। पैसा कहीं ना कहीं क्रिटिकल केयर में कॉस्ट कंट्रोल करने के लिए हम सब आज सुबह से 2 या 3 लेक्चर्स उसके बारे में सुन चुके हैं कि कॉस्ट कंट्रोल कैसे की जाए, एंड ऑफ लाइफ केयर कैसे की जाए, कैसे घोषित किया जाए, किस मरीज में आप अपेक्षित नहीं करते हैं कि ये मरीज अब हम चाहे कुछ कर लें हम बचा नहीं सकते। तो इस प्रकार की जो चर्चाएं आज हुई हैं, जो विचार विमर्श हुआ है, उसके बहुत सारे निष्कर्ष और कल भी जो होना है उन सब से जो निष्कर्ष निकलेगा उससे मुझे पूर्ण विश्वास है कि हम छत्तीसगढ़ की जनता को बेहतर क्रिटिकल केयर सर्विसेज प्रोवाइड कर पाएंगे। हमारा ध्येय हमेशा से रहा है कि हम एक कॉस्ट इफेक्टिव क्रिटिकल केयर प्रोवाइड करने की कोशिश करें, जो बेस्ट टेक्नोलॉजी है उसको अपने अस्पताल में लाने की कोशिश करें। आप सबका सहयोग, आप सबका आशीर्वाद मुझे प्राप्त होता रहा है, मेरे चिकित्सकों को प्राप्त होता रहता है और भविष्य में ये उम्मीद रखता हूँ कि अब हमें और भी मिलता रहेगा, आपका सहयोग मिलता रहेगा, आपका विश्वास मिलता रहेगा, आपका प्यार मिलता रहेगा। बहुत बहुत धन्यवाद। आप सब ने आज यहाँ पर आके इतनी बड़ी संख्या में जो आप आए, एक रिकॉर्ड 1300 रजिस्ट्रेशन जो हुए, वो आज तक के रायपुर के इतिहास में इतने रजिस्ट्रेशन किसी भी कॉन्फ्रेंस में चिकित्सकों की नहीं हुए होंगे। उसके लिए बहुत बहुत धन्यवाद।
Thank you, sir, for your words. Now I'll take this opportunity of this ceremony to introduce the unique concept of emergency healthcare at Ramkrishna Care Hospital. I would like to introduce the power of 3 at our hospital, which refers to our emergency response system designed to deliver rapid and efficient care in critical situations. This system focuses on 3 specific time-bound promises to ensure quick access to emergency medical services. So the 3 components of the Power of 3 campaign are: first, the emergency calls to the hospital helpline will be answered in 3 rings. That's the number 1, 3. The number 2 is an ambulance which reach the patient within 30 minutes in specific service areas of Raipur. That's the number 2. And the number 3 is an ER or an emergency room doctor attends to the patient within 3 minutes of their arrival at a designated care hospital emergency room. So that is what is the power of 3 that we would like to introduce. Now let's watch a short video on this concept of the power of 3. Now, ladies and gentlemen, I introduce our next guest speaker, who is a visionary leader redefining Indian healthcare, who is our Group Managing Director of Quality Care India Limited, Shri Varun Khanna. With 3 decades of experience spanning healthcare, medtech, and hospital management, Mr. Khanna combines strategic insight with operational excellence to transform healthcare delivery. At QCIL, he drives patient-centric innovation, leverages technology, and builds synergies across care hospitals. A respected leader, Mr. Khanna contributes to shaping the national healthcare agenda through FICCI and Nat Health, making a tangible impact on the future of healthcare in India. Please join me in welcoming Mr. Varun Khanna.
Namaskar. Honorable CM Vishnu ji, Namaskar. डॉक्टर रमन सिंह, डॉक्टर सिंह, आपकी कहानी हर उस शाम को दोहराई जाती है और आपको दुआएं दी जाती हैं हमारे बड़े भाई द्वारा जब भी हम मिलते हैं, क्योंकि शायद उनकी कुछ ऐसी मोहब्बत है आपके साथ। आज हमारे साथ डॉक्टर अडवाणी भी हैं और आप लोग सब जानते हैं कि डॉक्टर अडवाणी ऑन्कोलॉजी के क्षेत्र में, इनका नाम हिंदुस्तान में नहीं, शायद दुनिया का ऐसा कोई देश नहीं है कि ना लिया जाता हो। और ख़ास तौर पे दवे साहिब, बड़े भाई, 36 साल, लगता ऐसे है कि इतने यंग हैं आज भी। हॉस्पिटल में इनको देखिए तो ऐसा लगता है कि 36 साल उम्र है इनकी। ऐसा नहीं लगता कि 36 साल से छत्तीसगढ़ में है। उसके दो रीजन है एक्चुअली, एक कि ये 36 साल के हैं, दूसरा भाभी 30 साल की हैं जो इनको चलाती रहती हैं। आज मैं 3 चीजों पे आप लोगों की तवज्जो चाहूंगा। पहली कि आप लोग रामकृष्ण केयर को काफी समय से जानते हैं, और जैसा कि डॉक्टर दवे ने कहा, अब हमारा जो ग्रुप है जिसको हम आज क्वालिटी केयर कहते हैं, जिसके अंदर 3 ऐसे ब्रांड्स हैं जो इंडिया में ऑपरेट होते हैं, केयर हॉस्पिटल्स, किम्स हेल्थ और बांग्लादेश में एवर केयर। और हम लोगों ने एक और अनाउंसमेंट की है कि हम लोग मर्ज कर रहे हैं एस्टर के साथ, जहां हमारी सीसीआई अप्रूवल आ गया है, सेबी आ गया है, वी आर वेटिंग फॉर एनसीएलटी। कलेक्टिवली हम लोग लगभग 38 अस्पताल चलाएंगे 27 शहरों में इस देश के। और हमारी कोशिश जो है, जिस तरह हम कहते हैं कि हम हमने जब सोचा कि इतना बड़ा स्केल बनाना है तो क्या अलग करें, तो हमने कहा कि जो बेसिक चीजें हैं ना हेल्थ केयर के, अगर हम उसको दे पाए तो और कुछ नहीं चाहिए। तो हमारे अस्पताल की 3 लाइनें हैं, क्लिनिकली बायस्ड, आउटकम फोकस्ड और डिजिटली एनेबल्ड। अगर ये 3 चीजें हम कर लें, क्लिनिकली बायस्ड, आउटकम फोकस्ड, क्लिनिकल आउटकम फोकस्ड और डिजिटली एनेबल्ड, तो उससे अच्छा अस्पताल दुनिया में कहीं नहीं। हमारी जो ग्रोथ जर्नी है उसमें 2 चीजों पे बहुत फोकस है। एक ग्रोथ, डॉक्टर दवे ने पहले जिक्र किया था, मैं दोबारा कहना चाहूंगा, रायपुर का सबसे बढ़िया अस्पताल और बढ़िया होने जा रहा है, क्योंकि वहां पर ऑन्कोलॉजी का एक पूरा हाई टेक्नोलॉजी, हाई टैलेंट एंड हाई एकेडमिक फोकस्ड सेंटर क्रिएट किया जा रहा है, जिसके लिए हमारी कुछ लागत 350 करोड़ की है। और उम्मीद करते हैं कि हम मार्च अप्रैल तक, am I right डॉक्टर दवे, मार्च अप्रैल तक उसको इनॉग्रेट कर पाएंगे। और आखिरी चीज जो मुझे कहा गया था कि इनॉग्रेट की जाएगी अभी, वो है पावर ऑफ 3। बहुत आसान चीज है, और आप क्रिटिकल केयर में इतना बढ़िया काम करते हैं कि हमें इस बात का डर नहीं है कि अगर मरीज अस्पताल पहुंच गया तो आप उसका क्या ख्याल रखेंगे, बहुत अच्छा ख्याल रखेंगे। लेकिन आज की बढ़ते ट्रैफिक में, कंजेशन में, ये बहुत मुश्किल हो गया है कि मरीज अस्पताल पहुंच पाए। तो उसके लिए, और बड़ी आसान बात लगती है वैसे, आज से 30 साल पहले सड़कें खाली थी, हर आदमी 25 मिनट में कहीं से भी अस्पताल पहुंच जाता था। अभी 25 मिनट में कई बार आप अपने घर से बाहर निकल पाए तो बड़ी बात है। तो उसको नजर में रखते हुए हमने पूरे कंट्री में एक कैंपेन निकाली है कि आपका जो फोन है 3 घंटे के अंदर आंसर किया जाएगा, और ऐसे आंसर किया जाएगा जो आदमी आपकी बात, आपका दुख, आपका दर्द समझ सकता है। 30 मिनट के अंदर आपके पास कहीं भी हो एम्बुलेंस पहुंचेगी, इस तरह हम एम्बुलेंसेस को प्लेस करेंगे। और 3 मिनट के अंदर आपको एक इमरजेंसी फिजिशियन देखकर ये जांच लेगा कि आपको क्या चाहिए। तो ये एक ऐसा विश्वास है जो हम आप सबके लिए लाना चाहते हैं कि ये मुमकिन है। इसको मुमकिन करने के लिए तकनीक का बहुत इस्तेमाल किया गया है। डॉक्टर सिंह, इंडियाज फाइनेस्ट हेल्थ केयर सेंटर हैज बीन एस्टैब्लिश्ड ऑन कॉल सेंटर्स। ये टेक महिंद्रा, सीएम साहब, टेक महिंद्रा एक कॉल सेंटर चलाता है, 400 सीट का एक कॉल सेंटर है। और तब हम ये प्रॉमिस दे पाते हैं कि 3 घंटे के अंदर अंदर आपकी कॉल उठाई जाए। तो मुझे बहुत खुशी है कि आज यहां पर हम इसको लॉन्च कर रहे हैं, एंड थैंक यू वेरी मच फॉर बीइंग हियर। नमस्कार।
We'll have that photo. Yeah. So now I request all the dignitaries on the dais to please join in the unveiling and the photo op for the power of 3. Thank you, respected sirs. हम आज यहाँ स्वास्थ्य क्षेत्र में उत्कृष्ट योगदान और उपलब्धियों की प्रशंसा के अलावा अपने आदरणीय डॉक्टरों को उनकी अमूल्य सेवाओं के लिए सम्मानित करने के लिए भी एकत्रित हुए हैं. We are also here to celebrate and recognize the achievements of outstanding services in healthcare. So we will be felicitating our honorable doctors. I request the dignitaries on the dais to felicitate our distinguished faculty and guests. First of all, it's my privilege and honor to introduce Padma Bhushan Dr. Suresh Advani, fondly known as the godfather of oncology in India, an internationally acclaimed oncologist with over 50 years of dedicated service in the fight against cancer. A true pioneer, he performed India's first successful bone marrow transplant and trained under Nobel laureate Dr. E. Donald Thomas in US. As the former chief of medical oncology at Tata Memorial Hospital, he revolutionized cancer care with his focus on personalized treatment and compassionate healing. He has been honored with the Padma Bhushan, Padma Shri, and Dr. B.C. Roy Award. Sir also continues to inspire generations in oncology. We honor his lifelong commitment to excellence. Please give a big round of applause. To continue in a felicitation, we would like to honor Now, I would like to call upon Dr. Kirino Piachaboli, author of more than 1,000 national and international publications in anesthesiology, critical care, and health. He is a director of Department of Anesthesia and Critical Care Unit at San Filippo Neri Hospital, Italy. He is a member of National Healthcare Agency, Italy, chairman of Clinical Risk Management Society, and chairman of Italian and World Society of Anesthesia. Welcome to this conference, sir, and thank you for being here. It gives me immense honor and privilege to take the next name. He is also my teacher, Professor Dr. I.M. Sethi. Dr. Sethi's journey began with a passion for healing. After his completing his MD in Gwalior in 65, he arrived in Raipur, and he has served as a demonstrator and later on becoming the HOD Professor of Medicine. And he has served with distinction until his official retirement in 1998. We felicitate him with a Lifetime Achievement Award for his commitment to service. Dr. I.M. Sethi, please give a big hand of applause. Next, I call upon Dr. A.S. Dikshit. He's not here. I call upon Dr. A.S. Dikshit. He's a renowned medical specialist from Rajnandgaon. We thank Dr. Dikshit for his invaluable contribution to society through his knowledge and dedication. We felicitate him for his excellence and expertise. Dr. A.S. Dikshit, Rajnandgaon. Dr. A.S. Dikshit from Rajnandgaon. Next, I call upon Dr. M.P. Agarwal, renowned physician from Ambikapur. A respected physician, his skill and dedication have benefited countless patients. We felicitate him for his commitment to medical excellence. Dr. M.P. Agarwal from Ambikapur. Next, I call upon Dr. L.P. Soni from Ambikapur. His empathy and commitment as a general practitioner have touched many lives. We felicitate him for his excellent contribution to medical health. Dr. L.P. Soni from Ambikapur. Next, I call upon Dr. A.K. Srivastav, a distinguished surgeon from Kavardha. He's not here, sorry. 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 Dr. A.K. Srivastav, sir, is a distinguished surgeon from Kavardha. His excellence in surgical specialty has transformed many lives. We felicitate him with gratitude. Dr. A.K. Srivastav. Next, I call upon Dr. J.K. Singh, who is a renowned physician from Ambikapur with his deep insight and compassion for medicine and services. He has greatly served the community as a physician. We honor him for his excellence and devotion. Dr. J.K. Singh, sir. Next, I call upon Dr. S.K. Datta from Bhilai. Sir has served his larger part of life in Sector 9 Hospital, a respected surgeon, a teacher. He has years of dedicated service as a distinguished surgeon and compassion. He has truly served. Dr. S.K. Datta. Dr. R.S. Okay. Dr. R.S. Naik, I don't think. Please give a big round of applause for Dr. S.K. Datta. Now I call upon Dr. Shankar Paliwal, who is a valued surgeon from Korba. His efforts have brought hope and healing to many. We honor his service and contributions to healthcare. Dr. Paliwal from Korba. Next, I call upon Dr. S.K. Tiwari. He is a committed medical specialist from Bilaspur. His selfless service has touched many lives. We thank and honor him for his noble contribution to society. Dr. S.K. Tiwari. Next, I call upon Dr. Kalvet, He stands out for his devotion and compassionate service in medicine from Bilaspur. We felicitate him for his outstanding contribution. Next, I call upon Dr. Colonel Y.S. Dubey. He's a distinguished cardiologist from Bilaspur. He brings both experience and empathy to his practice. We honor him for his long-standing dedication to health services. Dr. Dubey, sir. Now I call upon Dr. Nandkishore Agarwal. With tremendous courage and vision, Nandu sir, a renowned surgeon from Basna, has built a 150-bedded hospital in a rural area, a truly remarkable act of compassion and commitment to healthcare. We felicitate him for his outstanding contribution to the rural services in the area of Chhattisgarh. I think Dr. Marcus Schulz is here. So again, sir, please, we were waiting for you. Please come on stage. We welcome Dr. Marcus Schulz, an intensivist, a principal investigator of academic medical care, a professor of intensive medicine, University of Amsterdam. Also, sir has performed up to 60 clinical trials. His main research interests are area of lung injury, mechanical ventilation. He's a founding member of Provinet, that is Protective Ventilation Network, which is a worldwide collaboration of intensivists and anesthesiologists in ventilation research and lung protection. He has immensely contributed to the service of intensive care. Welcome, sir. We welcome you to the conference and thank you for being here with us. Next, I call upon Dr. Prakash Sadani, a respected medical physician from Rajnandgaon. Sir has made significant contributions to his clinical excellence and compassionate care in the region of Rajnandgaon. Next, I call upon Dr. Baljit Singh from Rajim. He is a general practitioner of masses, if I say, a service of more than 50 years of dedication, known for his precision and excellence. His dedication to his profession is commendable. We honor him for his service. Please give a big round of applause for Dr. Baljit Singh. Next, I call upon Dr. Dilip Shah, a renowned name from Rajim in the field of medicine, with more than 30 years of dedicated service, exemplifying excellence and compassion in patient care. We felicitate him for his remarkable contribution. Dr. Dilip Shah. After this, we'll take a small break. We will continue the rest of the felicitations after we hear our next guest. मैं सभी अतिथियों से अनुरोध करता हूं कि मंच पर विराजमान हो जाएं। हम इस समारोह को आगे बढ़ाते हुए आज इस सम्मानीय समारोह में हमारे बीच उपस्थित हैं छत्तीसगढ़ राज्य के यशस्वी नेता माननीय श्री रमन सिंह जी। आप लंबे समय तक छत्तीसगढ़ के मुख्यमंत्री के रूप में सेवा देते हुए राज्य का विकास, सुशासन और जन कल्याण को आपने नया आयाम दिया। आपके कार्यकाल में छत्तीसगढ़ ने शिक्षा, स्वास्थ्य, कृषि, सड़क, बिजली और उद्योग के क्षेत्र में अभूतपूर्व प्रगति की है। आपको डॉक्टर रमन सिंह के नाम से ही नहीं बल्कि छत्तीसगढ़ के विकास पुरुष के नाम से भी जाना जाता है। आपकी सरलता, सौम्यता और जनता से जुड़ाव आपको एक आदर्श जनसेवक बनाता है। मैं विनम्र अनुरोध करता हूं आदरणीय रमन सिंह जी से कि मंच पर आएं और अपने विचार हमारे साथ साझा करें। श्री रमन सिंह जी, प्लीज गिव हिम अ बिग राउंड ऑफ अप्लॉज। प्लीज वेलकम हिम।
आज का यह गरिमामय आयोजन क्रिटिकल केयर कॉन्फ्रेंस 2025, मैं इस कॉन्फ्रेंस में आए हुए छत्तीसगढ़ के साथ साथ पूरे देश और देश के बाहर दुनिया के प्रसिद्ध चिकित्सक आज छत्तीसगढ़ में आए हैं। मैं आप सभी का छत्तीसगढ़ की इस पावन धरती पे स्वागत करता हूं, अभिनंदन करता हूं आपकी उपस्थिति के लिए। इस आयोजन में उपस्थित माननीय छत्तीसगढ़ के मुख्यमंत्री विष्णुदेव साय साहब, एमडी क्वालिटी केयर श्री वरुण खन्ना जी, सीईओ क्वालिटी केयर डॉक्टर पवन कुमार जी, डॉक्टर संदीप दबे एमडी रामकृष्ण हॉस्पिटल, डॉक्टर अब्बास नकवी जी संयोजक, डॉक्टर विशाल कुमार, डॉक्टर कुलदीप सोलंकी आईएमए के अध्यक्ष, डॉक्टर एमपी साहू और यहाँ जितने भी चिकित्सक आए हैं उन सब का विशेष सम्मान करते हुए मैं कहना चाहूँगा कि आज हम सब के लिए गौरव का विषय है कि दुनिया के प्रसिद्ध ऑन्कोलॉजिस्ट डॉक्टर अडवाणी जी की उपस्थिति इस कार्यक्रम की महत्ता को और बढ़ा देता है। उनका मैं विशेष रूप से छत्तीसगढ़ में स्वागत करता हूं। जिस समय अडवाणी जी की जरूरत पड़े किसी को, मैंने देखा है उस समय रात को 12 बजे भी फोन लगाएं, सुबह फोन लगाएं, इनका सुझाव, इनका सलाह कभी भी किसी समय उपलब्ध रहता है। इस उम्र के बाद भी इतनी सक्रियता के साथ एक एक केस का जितना डिस्कशन करके उसका सलूशन निकालते हैं, ये अपने आप में अद्भुत अनुभव मेरे जीवन में जुड़ा हुआ है। मेरे मिसेस के उपचार में, उनके ट्रीटमेंट में अडवाणी जी ने बहुत मेहनत किया और आज वो ठीक ठाक हैं, तो इनका भी एक बड़ा योगदान है। ये रायपुर का 2 दिन का क्रिटिकॉन रायपुर 2025 का ये कार्यक्रम और रायपुर को मेजबानी करने का अवसर मिला। दुनिया के और हिंदुस्तान के प्रसिद्ध एनेस्थीसियोलॉजिस्ट, पल्मोनोलॉजिस्ट, इमरजेंसी विशेषज्ञ, स्वास्थ्य के नवाचार से जुड़े हुए चिकित्सक, ट्रॉमा के सभी चिकित्सक आज यहाँ पे आए हैं। मुझे लगता है कि इस विचार विमर्श से निश्चित रूप से क्रिटिकल केयर का जिस तेजी के साथ लोगों के स्वास्थ्य की चिंता करते हुए रक्षा के लिए उपाय किया जा रहा है और महत्वपूर्ण सुझाव आएंगे। भारत में क्रिटिकल केयर सेवाओं को और अधिक सशक्त, आधुनिक और प्रभावी बनाने की दिशा में जो आप विचार विमर्श कर रहे हैं, निश्चित रूप से यह अभिवादन के योग्य है। मैं आप सबका स्वागत करता हूं। यह कार्यक्रम केवल स्वास्थ्य और तकनीक की चर्चा नहीं, बल्कि नए भारत की कहानी है जो हर जीवन को बचाने के लिए नई सोच, नई नीति और नई तकनीक के साथ आगे बढ़ती जा रही है। मुझे बताया गया है कि इस कार्यक्रम में अंतर्राष्ट्रीय विशेषज्ञ मौजूद हैं। डॉक्टर मार्स सुल्स नीदरलैंड से, डॉक्टर किरिनो पियाचेवोली इटली से, इनका मैं विशेष रूप से छत्तीसगढ़ में स्वागत करता हूं उनकी उपस्थिति के लिए। 1000 से ज्यादा प्रतिनिधि चिकित्सक और विशेषज्ञ यहाँ उपस्थित हैं। ये छत्तीसगढ़ के लिए गर्व का विषय है कि इस महत्वपूर्ण विषय में आप लंबी यात्रा करके छत्तीसगढ़ आए हैं। क्रिटिकल केयर निश्चित रूप से हर सेकंड जीवन और मृत्यु के बीच का अंतर कम करता है। आईसीयू के डॉक्टर, आईसीयू के नर्स, आईसीयू के तकनीशियन और उपकरण सब मिलके कहीं न कहीं व्यक्ति के जीवन बचाने के दिशा में सतत प्रयत्नशील रहते हैं। ईश्वर जीवन देता है, मगर उस जीवन की रक्षा करने की बड़ी जवाबदारी आज के इस दौर में चिकित्सकों की है। तो कहीं ना कहीं ये बात बिल्कुल सही है। ईश्वर के बाद दूसरा सम्मान का दर्जा यदि किसी प्रोफेशन में मिलता है तो चिकित्सक को मिलता है, आप सबको मिलता है, पूरे देश में मिलता है। और ये आपके इस तकनीक को और विकसित करने की दिशा में जो प्रयास हो रहा है कि हम जीवन को कैसे बचा सकें, कैसे क्रिटिकल केयर में हम और बेहतर तरीके से आगे बढ़ सकें, निश्चित रूप से इसका काम आप लोग सब कर रहे हैं। आज मुझे बहुत खुशी है कि आईसीयू में जब उपचार के लिए मरीज पहुंचता है और उपचार के बाद पहुंचने के बाद परिजनों के चेहरे का जो भय होता है, उस भय को समाप्त करने में वहां बैठा हुआ चिकित्सक की महत्वपूर्ण भूमिका होती है। और उस भूमिका को आप सब मिलके बहुत महत्वपूर्ण तरीके से करते हैं। ये आज मुझे लगता है कि देश में आज सबसे बड़ी आवश्यकता, हर जिले में, हर ब्लॉक में क्रिटिकल केयर के यूनिट, आईसीयू के यूनिट स्थापित हो, क्योंकि 5 लाख तक के इलाज के लिए प्रधानमंत्री जी ने व्यवस्था कर दी है। हर डिस्ट्रिक्ट में बेहतर काम हो रहा है। अलग अलग प्रदेश में, अलग अलग देश में 30 से ज़्यादा एम्स और 300 से ज़्यादा मेडिकल कॉलेज बनाए जा रहे हैं। तो मेडिकल क्षेत्र में बहुत तेजी के साथ इंफ्रास्ट्रक्चर पे जो ग्रोथ हो रहा है, और उसके लिए मैं कहूँगा कि छत्तीसगढ़ में भी उसी दिशा में काम कर रहे हैं। जब छत्तीसगढ़ का निर्माण हुआ था 2 मेडिकल कॉलेज थे। आज विष्णुदेव साय जी मुख्यमंत्री बने हैं और इस यात्रा में आज 14 मेडिकल कॉलेज छत्तीसगढ़ में हो गए हैं। सिर्फ 150 सीट मेडिकल कॉलेज के लिए, स्टूडेंट के लिए मिलता था, आज 2000 की संख्या हो गई है। इसका क्रेडिट जाता है विष्णुदेव साय जी को जाता है, जो लगातार प्रयत्नशील है। नए मेडिकल कॉलेज हर जिले में पहुंचाने का प्रयास चल रहा है। उसके लिए बेहतर इंफ्रास्ट्रक्चर छोटे से छोटे स्थान में बने, उसकी चिंता ये सरकार लगातार कर रही है। और निश्चित रूप से मुझे खुशी है कि आज इतना शानदार आयोजन यहाँ पे आपने किया। मोदी जी के नेतृत्व में इस देश में न केवल दवाइयों की कीमत में फर्क पड़ा है, बल्कि स्टेंट और नी इम्प्लांट को कैसे सस्ता किया जा सकता है, उस दिशा में भी उनका प्रयास महत्वपूर्ण रहा है। और आज मैं यही कहना चाहता हूँ कि इस क्षेत्र, जिस क्षेत्र में आप काम कर रहे हैं, और सबसे महत्वपूर्ण आज मुझे जो लगा कि आज छत्तीसगढ़ के उन चिकित्सकों का सम्मान किया गया जो दूरस्थ अंचल में, सरगुजा में, कोरबा में, कवर्धा में पूरी जीवन जिन्होंने खपा दिया सेवा करते करते, और उनकी एक प्रतिष्ठा और एक उनके समाज में बहुत बड़ा स्थान उस जिले में है। मगर आज इनको प्रदेश स्तर के इस शानदार आयोजन में, इस कॉन्फ्रेंस में उनको सम्मानित किया गया। ये निश्चित रूप से बहुत अच्छा प्रयास है। मैं संदीप जी को बहुत बहुत, पूरी टीम को बधाई दूंगा कि ऐसे चिकित्सक जो दूरस्थ अंचल में रह के, छोटे छोटे स्थान में रह के 100-150 बेड के हॉस्पिटल चला रहे हैं, पूरे मनोयोग से काम कर रहे हैं, उस क्षेत्र में जनता के बीच विश्वास अर्जित किया है। तो ये सब चलता रहे। और मैं आज अपनी शुभकामना व्यक्त करने आया हूँ कि ये जो हमारा कॉन्फ्रेंस है, इतने विशेषज्ञ यहाँ पूरे देश दुनिया से आए हैं, तो निश्चित रूप से इस दिशा में और तकनीक को आगे बढ़ाकर हम कैसे एआई का यूज़ करके कैसे रोबोटिक सर्जरी में और बेहतर तरीके से उन सारे कामों का क्रियान्वयन कर सकें जो आज देश की और दुनिया की आवश्यकता है। तो आज आप सब ने मुझे बुलाकर यहाँ पे इस महत्वपूर्ण कॉन्फ्रेंस में अवसर दिया। मैं संदीप जी को और पूरे टीम को, आयोजन समिति के सभी लोगों को बहुत बहुत धन्यवाद दूंगा, बधाई दूंगा। आप सबको बहुत बहुत शुभकामना।
सादर धन्यवाद सर। अब हम अपने सम्मान समारोह के क्रम को आगे बढ़ाते हैं और भी जो हमारे गणमान्य चिकित्सक यहाँ उपस्थित हैं उनके सम्मान करेंगे। सबसे पहले डॉक्टर प्रभात पांडे दुर्ग से। Dr. Prabhat Pandey, who is also the state president of IMA, is a distinguished medical specialist, has been a pillar of compassion, and we honor him for his tireless service and excellence in medical field. Next, I call upon Dr. Kaushlendra Thakur from Bhilai, a skilled neurosurgeon, medical director, Sector 9 Hospital, known for his precision in surgery and also his commitment to excellence in patient care. We felicitate him for his outstanding service. Dr. Kaushlendra Thakur. Next, I would like to call upon Dr. Sanjay Pandey from Korba, a symbol of humility and expertise in medicine. He has set benchmarks in patient care. We felicitate him for his sincere services to medical field. Dr. Sanjay Pandey from Korba. Next, I would like to call upon Dr. Avinash Tiwari from Korba. Dr. Avinash Tiwari, his passion for improving health outcomes reflects his dedication to humanity. We appreciate and felicitate him for his compassionate services. Okay. Next, I call upon Dr. Govind Khandelwal. Dr. Govind Khandelwal is a highly regarded general physician. He is known for his deep knowledge and patient-first approach. We appreciate his excellence in the field of medicine. Next, I call upon Dr. Prakash Bhagwat. Dr. Prakash Bhagwat continues a proud family tradition of medical excellence. Followed by he has followed his father. He is devoted to healing. He exemplifies true professionalism, and we felicitate him for his excellent services rendered to society. Next, I call upon Dr. Khileshwar Singh. Dr. Khileshwar Singh comes from Jagdalpur. जगदलपुर के दूरस्थ क्षेत्र से हमारे फिजिशियन. His compassion and excellence in medicine make him a role model for the area of Bastar. We honor him for his sincere dedication. Dr. Khileshwar Singh. Next, I call upon Dr. Divakar Rangari. Sorry, he's not here. Dr. BP Bajpayee? It's not here. Okay. Dr. Anil Rawat? He's not here. Dr. Umesh Lohana? Yeah. Next, I call upon Dr. Umesh Lohana, sir. Dr. Umesh Lohana is an orthopedic surgeon with a skill and compassion in orthopedics. He has served with unwavering devotion. We felicitate him for his excellence and his services dedicated in the area of Dhamtari. Next, I call upon Dr. Ranjit Singh Chabda. Dr. Ranjit Singh Chabda is a dedicated specialist in medicine in the region of Khariyar Road. His compassion and commitment inspire all in the remote area of Khariyar Road. We honor his services to humanity. Next, I call upon Dr. S.K. Goyal. Dr. S.K. Goyal, sir. Dr. Goyal sir is an eminent physician and visionary from Raipur. His expertise and dedication to medicine have earned him great respect. We honor his consistent efforts toward community health. Next, I call upon Dr. Kalyan Swarup Mishra. Sorry, he's not here. बुलाओ हाँ या सबको बुला लो एक साथ या डॉक्टर काली डॉक्टर शैलेश नहीं और भी बच्चे डॉक्टर प्रमोद बिनायके I call upon Dr. Pramod Binaike from Bhilai. Dr. Binaike is an experienced physician. He has consistently served with care and dedication. We felicitate him for his services. He is also the ex-HOD and CMO of Sector 9 Hospital, Bhilai. Dr. Pramod Binaike. Dr. Pradeep Jain. Dr. Pradeep Jain from Balod. Dr. Yash Javeri was the Vice President, Society of Critical Care Medicine, Director, Critical Care, Regency Hospital, Lucknow. Welcome, sir, to the conference. Dr. Pradeep Jain from Balod. Dr. Pradeep Jain is a reputed senior physician. His unwavering dedication and service continue to inspire all around him in the remote area of Balod. Dr. Pradeep Jain. Next, I call upon Dr. Sanjay Jaiswal. Dr. Jaiswal is the Vice President Society of Vice President Society of Emergency Medicine and Clinical Director of Emergency Medicine in Max Hospital, Delhi. Welcome, sir, to the conference. Next, I call upon Dr. Vinita Divedi from Bhilai. She's a renowned anesthetist and CMS, Sector 9 Hospital, Bhilai. Dr. Vinita Divedi, madam. And now, last but not the least, we would like to honor members of our own Ramkrishna Care family. Dr. Kale, Dr. Shailesh Sharma, Dr. Prakash Chauhan and Dr. Ajay Parashar. And दवे सर उनके बारे में कुछ पहले आपसे बात करना चाहेंगे.
शैलेश शर्मा है. सर्वप्रथम मैं डॉक्टर अजय पराशर को बुलाना चाह रहा हूं, एकमात्र किडनी ट्रांसप्लांट सर्जन ऑफ छत्तीसगढ़. अजय और मेरा साथ बहुत सालों का है और इसने किडनी ट्रांसप्लांट को एक नई ऊंचाई पे पहुंचाया है और आज 350 से ज़्यादा किडनी ट्रांसप्लांट कर चुका है. किडनी ट्रांसप्लांट अकेले नहीं होता, उसके साथ में एक नेफ्रोलॉजिस्ट की भी आवश्यकता पड़ती है. और छत्तीसगढ़ में सबसे पहला किडनी ट्रांसप्लांट करने में जिस आदमी ने सहयोग किया उसका नाम है डॉक्टर संजीव अनंत काले. शैलेश मेरे अस्पताल का एक ऐसा चिकित्सक जो हमेशा पर्दे के पीछे रहा, कभी सामने नहीं आया, पर डॉक्टरों की सहायता उसके बिना नहीं हो सकती थी, उसकी मौजूदगी के बिना नहीं हो सकती. एक ऐसा पैथोलॉजिस्ट जो कभी मैंने फ्रंट पे आते नहीं देखता. पैथोलॉजिस्ट एक ऐसे डॉक्टर्स होते हैं जो पेशेंट्स के साथ में उनका डायरेक्ट रिलेशन नहीं होता. डॉक्टर प्रकाश चौहान मेरे साथ, हम दोनों ने एक साथ MBBS किया. इसने पैथोलॉजी में MD की और मैंने सर्जरी में किया. ऐसे डॉक्टर प्रकाश चौहान. वो है नहीं. हाँ, डॉक्टर शैलेश शर्मा का भी मैं अभिनंदन और वो सम्मान करना चाहता हूं, बट अनफॉर्चुनेटली वो अभी तक के पहुंच नहीं पाए, इसलिए मैं यहाँ पर इसको विराम देता हूं. और अगर वो जब आ जाएंगे तो हम बीच में किसी वक्त डॉक्टर शैलेश शर्मा का सम्मान कर लेंगे.
मैं सबसे अनुरोध करता हूं कि अपना स्थान ग्रहण करें. आज हमारे इस गरिमामय अवसर पर हमारे बीच उपस्थित हैं छत्तीसगढ़ के राज्य के मुख्यमंत्री, जनप्रिय एवं कर्मठ नेता, हमारे माननीय मुख्यमंत्री श्री विष्णुदेव साय जी. अपने दृढ़ संकल्प, निष्ठा और जनसेवा के प्रति समर्पण के बल पर आपने राजनीति में एक विशिष्ट स्थान बनाया है. आपने छत्तीसगढ़ और विशेषकर आदिवासी समाज के विकास के लिए निरंतर कार्य किया है. आप कई बार सांसद सदस्य तथा मंत्री के रूप में देश की सेवा कर चुके हैं और अब छत्तीसगढ़ राज्य के यशस्वी मुख्यमंत्री के रूप में राज्य के सर्वांगीण विकास का नेतृत्व कर रहे हैं. आपकी सरलता, ईमानदारी और जनता से गहरे जुड़ाव से आपको छत्तीसगढ़ की जनता का सच्चा प्रतिनिधि बनाया है. मैं शैलेश शर्मा सर को मंच पर आमंत्रित करता हूं. मैं माननीय मुख्यमंत्री श्री विष्णुदेव साय जी से अनुरोध करता हूं कि आप हमें अपने अनमोल विचारों से प्रेरित करें. श्री विष्णुदेव साय जी, कृपया इनका स्वागत करें.
क्रिटिकॉन रायपुर 2025 के इस कॉन्फ्रेंस में हम लोगों के बीच मंच में विराजमान जो स्वयं डॉक्टर भी हैं, हमारे प्रदेश के पूर्व मुख्यमंत्री जो 15 वर्षों तक छत्तीसगढ़ का चहुमुखी विकास किए हैं, वर्तमान में छत्तीसगढ़ विधानसभा के सम्माननीय अध्यक्ष डॉक्टर रमन सिंह जी, मंच में विराजमान क्वालिटी केयर के एमडी श्री वरुण खन्ना जी, क्वालिटी केयर के सीईओ डॉक्टर पवन कुमार जी, रामकृष्ण केयर के एमडी डॉक्टर संदीप दवे जी, क्रिटिकॉन के संयोजक डॉक्टर अब्बास नकवी जी, डॉक्टर विशाल कुमार जी, आईएमए रायपुर के अध्यक्ष डॉक्टर कुलदीप सोलंकी जी, डॉक्टर एसपी साहू, डॉक्टर सुरेश आडवाणी, और इस कॉन्फ्रेंस में उपस्थित छत्तीसगढ़ प्रदेश, देश और विदेशों से पधारे सभी वरिष्ठ चिकित्सकगण और मीडिया के साथीगण, आज मेरा सौभाग्य है कि इस महत्वपूर्ण कॉन्फ्रेंस में मैं आप लोगों के बीच में उपस्थित हूं। मैं सबसे पहले आप सभी लोगों का छत्तीसगढ़ की इस पावन धरती में हृदय से अभिनंदन करता हूं, स्वागत करता हूं, और ये अवसर प्रदान करने के लिए, कराने के लिए आयोजक समिति का भी हम आभार व्यक्त करना चाहेंगे। और मैं चिकित्सक बंधु गण को भगवान के बाद दूसरे नंबर पर मानता हूं, क्योंकि भगवान जन्म देते हैं लेकिन नया जीवन देने का काम चिकित्सक बंधुगण करते हैं। तो ऐसे सभी चिकित्सकों को भी मैं नमन करता हूं। और मुझे लगता है कि ये क्रिटिकॉन रायपुर 2025 न केवल एक सम्मेलन है, बल्कि एक चिकित्सा विज्ञान, विशेष रूप से क्रिटिकल केयर के क्षेत्र में नवाचार और उत्कृष्टता का एक मंच है। अभी डॉक्टर साहब बोल रहे थे, जो 15 वर्षों तक इस प्रदेश के मुख्यमंत्री के रूप में छत्तीसगढ़ की सेवा किए, और जो स्वयं डॉक्टर हैं, और वो बोल रहे थे कि जब छत्तीसगढ़ राज्य का निर्माण हुआ तो 2 मेडिकल कॉलेज यहाँ पर होते थे, अब वो 14-15 से ज़्यादा हो गए हैं, और उसका श्रेय हमको दे रहे थे। ये उनका बहुत बड़ा बड़प्पन है, जबकि हकीकत ये है कि उनका जो लंबा कार्यकाल रहा 15 वर्षों का, 15 वर्षों में अधिकांश मेडिकल कॉलेज यहाँ पर खुले हमारे छत्तीसगढ़ के अंदर में, और एम्स जैसी संस्था भी उन्हीं के समय में यहाँ पर आई। इसलिए हम उनका बहुत बहुत धन्यवाद करना चाहेंगे। और खाली चिकित्सा के क्षेत्र में ही नहीं, जैसे मैंने पहले कहा कि उन्होंने 15 वर्षों में छत्तीसगढ़ का चहुमुखी विकास किया। छत्तीसगढ़ में भूखमरी होती थी, बच्चे उपवास होते थे, भूख से मौत भी होती थी, और आपने भूख भगाने का काम किया। पीडीएस की एक अच्छी प्रणाली छत्तीसगढ़ में लागू किया, जो पूरे देश में विख्यात हुआ, और चाउर वाले बाबा के नाम से भी विख्यात हुए। और यहाँ पर शिक्षण की सारी संस्थाएं भी इन्होंने स्थापित की, आईआईटी से लेकर आईआईएम, ट्रिपल आईटी, नीट, लॉ का यूनिवर्सिटी, ये सब सारा कुछ शिक्षण की जो संस्थाएं आज हम लोग छत्तीसगढ़ के अंदर में देख रहे हैं, सब इनके 15 वर्षों के कार्यकाल का वो देन है। और सड़क, बिजली, पानी, किसानों के लिए सिंचाई के साधन, जितने भी विकास हुए हैं, मैक्सिमम इनके 15 वर्षों के कार्यकाल के हैं, इसलिए उनके बहुत आभारी हैं। और छत्तीसगढ़ अपने 25वें वर्ष में प्रवेश किया है, रजत जयंती वर्ष में हम लोग प्रवेश किए हैं, और रजत जयंती वर्ष की भी आप लोगों को हम शुभकामनाएं देना चाहेंगे। और हमारे प्रदेश का सौभाग्य होगा कि रजत जयंती के वर्ष में स्थापना के दिवस 1 नवंबर को स्थापना दिवस के दिन हमारे देश के यशस्वी प्रधानमंत्री आदरणीय डॉक्टर नरेंद्र मोदी जी पधार रहे हैं और उनके कर कमलों से हमारे विधानसभा का भी रजत जयंती वर्ष है, जिसके अध्यक्ष आप स्वयं हैं। तो नए विधानसभा भवन का भी लोकार्पण हमारे देश के यशस्वी प्रधानमंत्री के कर कमलों से होना है। तो इस तरह से डॉक्टर साहब का बहुत बड़ा योगदान छत्तीसगढ़ के निर्माण में, छत्तीसगढ़ के विकास में है। और जहाँ तक चिकित्सा की बात है, हम भी लंबे समय से राजनीति में हैं, तो आज धन्यवाद देना चाहेंगे। एक तो छत्तीसगढ़ में जो चिकित्सा के साधन यहाँ पर उपलब्ध हैं, उसके लिए डॉक्टर रमन सिंह जी को, उन्होंने यहाँ पर आयुष्मान भारत कार्ड योजना तो माननीय प्रधानमंत्री जी की देन है, लेकिन इन्होंने जो एपीएल के भी लोग हैं उनके लिए भी मुख्यमंत्री स्वास्थ्य बीमा योजना में 50,000 तक की सुविधा उन्होंने भी अपने 15 वर्षों के कार्यकाल में शुरुआत की थी और आज उसका लाभ मिल रहा है। मैं गांव का रहने वाला हूं। आजकल ऐसा वातावरण हो गया, ऐसी खान पान हो गई है, वायुमंडल ऐसा हो गया है कि बड़ी बड़ी बीमारी आज गांव के लोगों को भी होने लगा है। आज ये शुगर की बीमारी, पहले हम सब लोग ये सब खाली गद्दीदार जो गद्दी में बैठ के व्यापारी लोग विशेषकर जो ज़्यादा मेहनत नहीं करते हैं उनको होता है ऐसा समझते थे, लेकिन आज मेहनतकश लोगों को भी ये शुगर वगैरह की बीमारी होने लगी है। आजकल ये कैंसर, जिसको लेके इस 2 दिन के कार्यशाला में विशेष चिंता होगी और यहाँ पर उनके विशेष डॉक्टर आडवाणी भी यहाँ उपस्थित हैं। आज ये कैंसर जैसे बीमारी भी आज आम हो गई है। आज महिलाओं में कैंसर, पुरुषों में कैंसर, सब में एकदम आम बीमारी, गांव के लोगों में भी बीमारी हो रही है। और हम इसके लिए भी डॉक्टर साहब को धन्यवाद देना चाहेंगे कि मेकाहारा में पहले अगर किसी को कैंसर हो गया तो फिर बॉम्बे वहाँ पर जाना पड़ता था, लेकिन अब मेकाहारा में उन्होंने अच्छी व्यवस्था कराई है, बालकों के हॉस्पिटल में है, रामकृष्ण केयर में है। इस तरह से ये पिछले 25 वर्षों में काफ़ी विकास हुआ है और हमारी सरकार लोगों को सस्ती और अच्छी चिकित्सा उपलब्ध कराने के लिए प्रतिबद्ध भी है। इसके लिए तमाम हम लोग उपाय भी कर रहे हैं। अभी नया रायपुर में मेडिसिटी बना रहे हैं, वहाँ पर अस्पताल खुल रहे हैं जिसमें 5,000 बिस्तर की सुविधा होगी और नए नए अस्पताल तो रायपुर में बहुत आ रहे हैं। हम अभी 21-22 महीने से मुख्यमंत्री के दायित्व में हैं, तो हमको लगता है कि 6 से ज़्यादा हॉस्पिटल का इनॉग्रेशन करने का सौभाग्य तो हमको भी मिला है। अच्छे अच्छे अस्पताल यहाँ पर आ रहे हैं। और जहाँ तक रामकृष्ण केयर की बात है, डॉक्टर संजीव दवे जी हैं, उनका भी हम धन्यवाद करना चाहेंगे कि बहुत बड़ा सहयोग रामकृष्ण का रहता है, डॉक्टर दवे जी का रहता है। तो उनको भी बहुत बहुत आज के इस अवसर में धन्यवाद देना चाहेंगे। और ये 2 दिन का कार्यशाला निश्चित रूप से एक मेडिकल साइंस के क्षेत्र में इसके विकास में मील का पत्थर साबित होगा। और आज के इस अवसर में सभी जो वरिष्ठ चिकित्सक, विशेषकर जिनको उत्कृष्ट कार्यों के लिए, उत्कृष्ट कार्य हम नहीं कहेंगे बल्कि उत्कृष्ट सेवा, उन्होंने सेवा लोगों का किया है, उसके लिए उनको सम्मानित किए हैं। उनको बहुत बहुत बधाई, बहुत बहुत शुभकामनाएं देते हैं। और अंत में फिर से एक बार प्रदेश, देश और विदेशों से भी आए सभी चिकित्सक बंधुगण का हृदय से अभिनंदन, स्वागत करते हुए और ये कॉन्फ्रेंस की सफलता की कामना करते हुए एक बार फिर से आयोजक समिति का आभार करते हुए अब हम अपनी बात समाप्त करते हैं। जय हिंद, जय छत्तीसगढ़।
बहुत बहुत धन्यवाद माननीय मुख्यमंत्री जी। अब मैं डॉक्टर संदीप दवे और डॉक्टर अब्बास नकवी सर से अनुरोध करूंगा कि हमारे माननीय अतिथियों का स्वागत करें, उन्हें स्मृति चिन्ह प्रस्तुत करके। Please give a big round of applause. Thank you, sir, for being here. थैंक यू सर। अब इस कार्यक्रम के सबसे अंत में मैं डॉक्टर शमीक दवे को आमंत्रित करता हूं धन्यवाद ज्ञापन के लिए।
नमस्कार। सबसे पहले मैं एक छोटी सी स्टोरी बताना चाहूँगा। 17 अक्टूबर 2007 में एक शख्सियत ने मेरे सर पे हाथ रखा था और मेरे को आशीर्वाद दिया था मेरे पिताजी के सामने, और उन्होंने ये कहा था कि तू अपने पिताजी जैसा बड़ा सर्जन बन जा। आज जब वो शख्सियत मेरे सामने बैठी है तो मैं उनको ये बताना चाहता हूँ कि सर, मैं सर्जन तो बन गया हूँ, पर आपका आशीर्वाद रहा तो मैं बड़ा भी बन जाऊँगा। वो है श्री डॉक्टर रमन सिंह सर। मैं उनका तहे दिल से धन्यवाद देता हूँ कि वो आए अपना टाइम निकाल के इस सभा को, जो डॉक्टरों से भरी हुई है, उन्हें अपने शब्दों से अच्छा कहा और किया। अगला मैं श्री विष्णुदेव साय जी से एक अनुरोध करना चाहता हूँ कि मेरा सफ़र अभी बस 3-4 महीने हुआ है शुरू हुए, उनका भी सफ़र 22 महीने हुआ है जैसा उन्होंने कहा। मैं उनको ये बताना चाहता हूँ कि मेरे पिताजी और रमन सिंह साहब ने भी साथ में शुरू किया था अपना सफ़र, और तब रमन सिंह सर जी ने 15 साल इस शहर पे राज किया। तो मैं ये चाहता हूँ कि वो हाथ अगर आप मेरे सर पे रखेंगे तो क्या पता हम वो लेगेसी तोड़ के 20-25 साल आगे बढ़े और आगे रामकृष्ण रहे और आप भी इस प्रांत के मुख्यमंत्री रहें। और बाकी फॉर द वोट ऑफ थैंक्स, good evening everyone. It's my great pleasure with a ribbon of pride to propose a vote of thanks on this special occasion. First and foremost, I would like to extend our deepest regards and appreciation to our esteemed chief guest, Dr. Suresh Advani sir, for gracing this occasion with his august presence. Sir, your words of wisdom and insight have truly inspired us, and we are honored to have had this opportunity to learn from your vast experience. Your commitment to the cause in field is truly admirable, and we are grateful for the time you have taken to share your knowledge with us. I would also like to take a moment to express our heartfelt gratitude to all those who have contributed to make this event a resounding success, particularly the organizing committee led by Dr. Abbas sir and Dr. Vishal sir, for their tireless efforts in putting together this remarkable event, right from conceptualizing the theme to managing the logistics. Your dedications and attention to details have been exceptional, and your hard work behind the scenes has ensured that every aspect of this event runs seamlessly, and for that we are truly thankful. To our generous sponsors, partners, thank you for your unwavering support, commitment to our cause. Your contributions have not only made this event possible, but have also helped us to extend our reach and impact. We are honored to have you as part of our community and look forward to continuing our collaboration in future. I would also like to acknowledge the incredible work of our volunteers and support staff. Your willingness to lend a helping hand and your positive attitude have made a significant difference in the success of the event. From assisting with registration to ensuring the guests are well taken care of, your efforts have not gone unnoticed, and we are grateful for your dedication. Let me take this opportunity to appreciate the power of coming together as doctors, as a community, the exchange of ideas, the forging of new connections, and the collective pursuit of knowledge and growth, and what are make the occasions like these truly memorable. May the insights and inspiration from this event continue to guide us in our professional lives. Once again, thank you for all being a part of this remarkable journey. May the memories and lessons to be learned from this event stay with us long after we leave this hall. Let us continue to strive for excellence in all that we do and work towards building a better future for ourselves and for generations to come. आखिरी में बस इतना ही कहना चाहूँगा कि मैं आयु में यहाँ जितने भी डॉक्टर्स आए हैं उनसे सबसे छोटा हूँ, पर थोड़े सपने बड़े हैं. आप लोगों का आशीर्वाद रहा तो वहाँ पहुँच जाऊँगा. थैंक यू.
Due to time constraints, we are postponing our two panel discussions for tomorrow. Let's see how we can accommodate those sessions tomorrow. And I invite everyone for the grand gala dinner, which is in the dome